D'accord, sir? Hmm? Good evening, doctor. Doctor, this is Abhishek.
Hello.
Hello, ma'am. Ma'am, this is Abhishek.
Yes. Good afternoon.
Good afternoon, ma'am. So, ma'am, we'll be starting sharp at 3:30,
Okay.
and like we are calling each and everybody and
Shall
reminding
I
them so
call
that,
off? Shall I?
ma'am, you can be there, and if you want, you can mute your video or audio, anything you want. Yes, that's fine. That's fine, ma'am.
Check one, check one.
No.
Good afternoon, sir. Dulai sir. Good afternoon, Jina sir. Rahul
Good
Gulchi.
afternoon.
Good afternoon. Good afternoon, Sharmila ma'am.
Yes, yes.
How are you,
I'm
ma'am?
here.
Yes, ma'am. Ma'am, this is Rahul, ma'am.
শর্মিলা ম্যাম আপনার স্ক্রিনটা একটু ঠিক করে নিন, আপনার পুরোটা দেখা যাচ্ছে না মুখটা।
ঠিক আছে,
হ্যাঁ, এবার দেখা যাচ্ছে।
এবার দেখা যাচ্ছে।
Dr. Jena, how are you?
Good, good. Good. Everything's fine. अच्छा हुआ that.
Good afternoon.
Good afternoon, Didi. So अच्छा हुआ we could keep up this. At least we could complete this annual congress in virtual. This whole, but thanks to Dr. Tofan and his entire team and Didi, it was made possible. Because with, I think it was done with the very shortest time. Probably within 4 weeks it was arranged. Within 4 weeks. Even I was reluctant, and Didi was also reluctant. I could guess from her comment also. It's only Dr. Topan who insisted. No, we'll go ahead. We'll go ahead. We'll go ahead. So it was not possible.
No, because we don't have a because अगर हमारा वो February में there is a BESCON is there 2021. So if you delay it, so that might affect the BESCON 2021.
So BESCON को physical कर दो hopefully.
हाँ, शर्मिला मैम तो बताया है physical होगा.
हाँ, BESCON को उसको physical कर दो. Now it has calmed down. Now the incident has calmed down. Hopefully the things will settle down in February.
Yes.
अच्छा हुआ ये जो we could arrange 2 good sessions, one on sickle cell and one on multiple myeloma with the shortest time. Time was very short and it could be well managed to record their speech also. That was good.
नहीं, the international speaker is only possible for you only, ना? That is your effort.
ये जो sickle cell का बहुत, तो he is a very important person. ये जो अब्दुल कुटलर है ना, he was one of the principal for that by Tizamzamab. Anyway, thanks to Kalpana, who could rope him. That was good possible. दीदी क्या खबर, बोले हमारा बड़ा दीदी कैसा है? आप दीदी ठीक ठाक है तो? Bengal is now, whole India is watching and Bengal.
So this is welcome, isn't it?
Yes. Welcome. But a lot of things are happening. The whole India is converging on Kolkata now. आपका इलेक्शन कब है दीदी? इलेक्शन कब है?
इलेक्शन पॉसिबली मार्च अप्रैल में होगा. अप्रैल में होगा. अप्रैल में.
So during BESCON there will be no heat. So BESCON
It is hotting up. Election mood is there.
हाँ, तो mood तो अभी शुरू हो गया ना.
Every day there is something.
Every day there is something.
Good afternoon, ma'am. Good afternoon, sir.
Good
Good
afternoon.
afternoon, Jenna, sir.
Good afternoon.
I think Dr. Jena and Sormila ma'am, during the inauguration, I will take 10 to 15 minutes because I prepared the presentation of digital hematology group, the past events and present event and also the future event. So I will highlighting the Eastern Hematology group through the slide, right?
So we'll be finishing in 10 minutes. So Didi 5 minutes and myself and 5 minutes.
No, you take your time. Don't worry.
I will take
Because
only 5 minutes.
No issue because there is a half an hour inauguration is there. Half an hour is pretty long time. So you take your time. There is no issue. I am briefing that I will be doing this thing. That's why I am telling you. You
That's
take,
good.
you take your time.
I was worried that how the 30 minutes will be completed. Aapka PPT is good. That you have compiled everything, the past, present, and the future also. Good.
Yes. Surmila ma'am, you take your time. Comfortably, you take your time.
No,
hurry.
5 minutes.
No
I'll
hurry.
take 5 minutes.
No hurry.
I think now, Didi, Tofan is looking to the MB Agrawal. Everything is professional. Everything is ready.
ऐसे नहीं है. That is.
BEd, BSS, BEd, ISS, BT, BEd, workshop, whatever it may be, everything is ready.
Other people is also supporting. That is important.
His team is ready. His work people are ready. Everything is ready.
Rahul will start sharp at 3:30.
Sharp at 3:30.
Yes.
Noted, sir.
In AIMS partner, Dr. Bakchi is there.
Yes. Bakshi is there.
Who else is there besides Dr. Bakchi?
पार्टनर से तो बाकी है, अविनाश है.
अविनाश तो पारस में है, जो एम्स पटना में.
अच्छा हाँ, there is another fellow is there. He is from the medical oncology.
Okay.
He is from medical. So Dr. Prakash is there. So he will be announcing all the speaker. He will give some short introduction. Then Dr. Prakash will invite Surmila ma'am. Then subsequently the Dr. Jena and myself. Dr. Prakash will be conducting this inaugural session and also the plastic session.
Yes, sir. Thank you, sir.
শান্তনুদা কেমন? শান্তনুদা কেমন আছেন? হ্যালো, শান্তনুদা মনে চেম্বারে আছেন?
না চেম্বারে না।
এমনি
না,
ঠিক আছেন তো?
দেখতে পাচ্ছি না কেন?
দেখতে পাচ্ছি না ছবিটা।
তুমি আমাকে বলো যে আমি কি করব? কনফারেন্স আমি মরে গেলেও তোমার চলবে।
সেটা কথা।
এটাকে
বলো আমি মরে গেলেও তোমার এই কনফারেন্স চলবে।
সেটা কথা।
What do you want me to do?
আগে আমি মিউট করি, আওয়াজটা মিউট করি।
একটা মানুষের সহ্য করার সীমা তো আছে।
Doctor, 1 minute to go.
Yes, yes.
It's a request to all the faculties that when they talk or when they're hosting or when they're coordinating, session coordinating, they're doing anything, after finishing, please mute your voice so that other faculties don't get interrupted for that. Okay?
রাহুল, তোমার ওখান থেকে
অপশনস আছে স্যার,
মিউট রাখো। হ্যাঁ, তোমার অপশন থেকে রাখো।
আমার কাছে আছে। এক্স্যাক্টলি স্যার।
বিকজ তুমি প্রকাশকে আনমিউটে রাখো আর আমাদেরকে যখন আমরা নিজেরা আনমিউট করব তখন করে দেবো, বাকিদের তুমি করে দেবে। যখন অন্য লোক একজন কথা বলবে বাকিদেরকে অটোমেটিক্যালি আনমিউট করে দেবে।
ঠিক আছে, ওকে।
ঠিক আছে, এটা প্রেজেন্টেশন মোডে দিয়ে দাও।
स्पीकर की कोई प्रॉब्लम होगी ना, देखो मैं तो उसमें डॉक्टर प्रकाश को मैं कॉल कर दूंगा, फर्स्ट ईयर से किसी को ना
রাহুল, টাইমটা দেখে নাও।
Dr. Prakash, you can start the session now.
A very good afternoon to all. Today we are here. This is an Eastern Hematology Group annual virtual meeting, fifth meeting, and the sponsors are Novartis, Intas Pharma, AstraZeneca, Janssen, Takeda, Johnson & Johnson, Bharat Serum and Vaccine, and Plasmagen Biosciences. For this talk, the speakers for the first inauguration session are Sharmila Chandra Madam, she is President, Eastern Hematology Group. Dr. Ravindra Kumar Jena sir, he is Secretary, Eastern Hematology Group. Dr. Tufan Kanti Dulai sir, he is Scientific Chairperson of the Eastern Hematology Group. So first of all, I would like to invite Sharmila Chandra Madam. She is presently a senior consultant at Narayana Super Speciality Hospital and President of Eastern Hematology Group. So I would like to request Sharmila Chandra Ma'am to say a few words and give us.
Thank you, Prakash.
So over to you, ma'am.
Yes, thank you, Prakash. It gives me great pleasure to inaugurate the first talk in the 5th annual virtual conference of the Eastern Hematology Group. And I still remember the day in Cuttack where we sat in a small room and started conceptualizing the thought of having an Eastern Hematology Group, because we felt that we need to increase the cooperation between the states of Eastern India, because of the far-flung areas here, difficult to reach, not as easy as it is to get to Bombay from Calcutta, much more difficult than that. Also, to inculcate a sense of interest in the student population to take up hematology, because all of us felt very interested in the future of hematology and the developments that are taking place in hematology and its various aspects sort of made us feel that there should be a lot more interest in the field of hematology. And in order to popularize, we should do something. And we decided to take up hematology and go to far-flung areas, to smaller towns, smaller hospitals, to give talks to make hematology more interesting to everybody. And also, I must congratulate Dr. R.K. Jana. He is very active and dynamic personality, which thought of this Eastern Hematology Group and gave it a shape. And ultimately, today we are here in the 5th annual conference. And the past conferences, the popularity of the past conferences tell us that it has been a great success. And I'm sure this conference will also be enjoyed by all. I will also congratulate Professor Tufan Dolai, whose dynamism has made this conference possible. And he has been active in so many fields, in the hospital, as a teacher, as a doctor, as a caregiver, as so many fields in Bengal Hematology Society, in ISHBT, everywhere, plus carrying on with his own work. He has been a
মিউট হয়ে গেছে শর্মিলা ম্যাম, আপনি মিউট হয়ে গেছেন।
So thank you, ma'am. As ma'am already told that this was started in Cuttack, so I request next speaker, Professor and Head Dr. R.K. Jena sir. Sir is presently serving at SCB Medical College and Hospital Cuttack in the Department of Hematology, and Dr. Jena sir has already received training in bone marrow transplantation from the University of Minnesota, USA, and he has more than 70 publications in journals of national and international repute. Sir has done almost more than 65 BMTs, autologous transplant, and some of them are very older patients. So I request Professor Dr. R.K. Jena sir to say a few words.
Okay, thank you, Prakash. Respected President of Eastern Hematology Group, Dr. Swarmila Chandra, the Joint Secretary and Organizing Secretary of this conference, Professor Prakash Tale, all the office bearers of Eastern Hematology Group, all the honorable members of the Eastern Hematology Group, and ladies and gentlemen. It gives me immense pleasure to address you on the 5th annual conference of Eastern Hematology Group, which is a virtual one. At the outset, on behalf of Eastern Hematology Group, I must extend my sincere thanks and deepest appreciation to Professor Dolai and his entire team, conceptualizing hosting the EHG annual congress in a virtual format just 3 weeks before, though some members, including me, were a bit reluctant to organize within a very short time. We wanted to have it in the next year, but he insisted, and we could do it. And whatever you are saying, it's because of his own, Professor Dolai's effort, vision, and constant endeavor to accomplish such a wonderful academic fest or academic program in the annual Congress of Eastern Hematology. In continuation with our whatever the information our Honorable President Soumya Devi has told, I will tell you that when Eastern Hematology Group was general or was born, there was many skepticism across the country. Many people thought probably it's a setback for Indian Society of Hematology, but gradually you will be happy to know that even our greatest critics also have become the friend and have become the greatest admirer of Eastern Hematology Group. And now they have realized Eastern Hematology Group contribute and complement to the endeavor and the objective of Indian Society of Hematology and Blood Transfusion. As Didi has already told, the main objective of Eastern Hematology Group was to outreach the every part of Eastern India with the development of hematology and make not only the public and clinicians our hematology, so that our patients can be benefited whatever the development which is occurring in the field of hematology. I am happy to inform you that a lot of things has developed and changed the last 5 years across Eastern India. As for example, let me start from my Odisha, from my own state in Odisha. There have been a full-fledged hematology department other than SCB Medical College, Cuttack, which was the oldest one. AIMS Bhubaneswar was opened one full-fledged hematology department, and some hospital also having a full-fledged hematology department. And you will be happy to know that there is a DM course has started in the two institutions like AIMS Bhubaneswar and some. Hopefully, in our institute from the next year, you are going to start the PG program in hematology. So this is the development so far Odisha is concerned. And of course, the Bengal, the Kolkata always leads the development. So Kolkata is the face of Eastern Hematology Group for Eastern India. There are a lot of development both in NRS Medical College and Medical College headed by Dr. Maitri Bhattacharya. Dr. Soumya Devi is there in his Narayana Hospital. So many private hospitals come up with a full-fledged hematology department. And there's a good development in Northeast also. In Guwahati, I was happy to when I listened when Jina was vibrant and with a lot of encouragement and excitement. She called me that, Jana sir, it's a good news that the DM hematology has opened and the NCI has allowed to open DM hematology in Guwahati Medical College hematology department. That's a good development which is opening from this year. Another good news, the Imphal Medical College, Anil has joined. The Department of Hematology has started. I am sure Anil's dynamism will really steer to open a full-fledged hematology department in Imphal also. Coming back to Bihar, Bihar is a very important state, and there is a full-fledged hematology oncology department in that AIMS Patna, and Dr. Bagchi is there. I am sure with the guidance and with his sheer effort, the hematology to grow, and we will again pursue our request to Dr. Avinash Singh, who is the senior most hematologist in Patna, to really put to the effort how to popularize hematology in Patna and in Bihar. Only states which are left is Jharkhand and Chhattisgarh. If you remember correctly, EAG also went 2 to 3 times to every part of that Jharkhand and Chhattisgarh to pursue and to advocate to open hematology. And I am sure in the due course of time, if more and more suitable or qualified hematologists will be there, I think some kind of awareness and priming of the administrators of that area has been done by the EAG. Hopefully, in the short future, full-fledged hematology department is going to open. I'm sure in overall, if you look at the development of hematology in Eastern India and its initiation and advocacy by Eastern Hematology Group, I'm sure you will be happy that a good work, a good development has been done so far. Development of hematology is concerned in Eastern India, and EAG has really contributed in a significant way in accomplishing this. And another thing that whatever we have, there was a sort of, because of this challenging time of the pandemic, of the COVID pandemic, we couldn't meet each other, or else the things would have developed. Whatever we have planned to have a say workshop, CME, or a kind of standard treatment protocols, guidelines, collaborative or a networking like such of for any particular disease or registry of a particular disease on behalf of the Eastern Hematology Group. These were things which are planned, was discussed. There are some setback because of this recent pandemic which could not meet or could not contribute. I am sure as this challenging situation will gradually ease and will improve, the things will start improving. With this word, I welcome all of you to this 5th annual Congress of Eastern Hematology Group. I am sure the academic which has been planned, you will enjoy and you will learn many things. And I once again sincerely wish all of you to be member and to encourage others to become the life members of Eastern Hematology Group. Join hand to hand in developing hematology across Eastern India and contributing the development of hematology in the entire India. With these words, I thanks all of you to join in this annual congress. Thank you very much.
Thank you, Jena sir. Thank you for highlighting the importance of Eastern hematology. Now I would request Professor Dr. Tufan Kanti Dolai sir. Sir is presently Professor and Head Department of Hematology, NRS Medical College, and sir has published more than 80 research papers in journals of national and international repute, and has more than 100 abstracts which are presented in different conferences. And presently, sir is has written 25 chapters in different books and has received several medals and orations for his outstanding abilities. Special areas of interest for Dr. Tufan Kante Dolai sir is thalassemia, hemophilia, aplastic anemia, myeloma, leukemia, and stem cell transplant. So I request Dr. Dolai sir to please say a few words and.
Thank you. Thank you, Dr. Prakash, and good evening to all of you, and respected Surmila ma'am, the President of Eastern Hematology Group, and respected Professor R.K. Jena, the Secretary of the Eastern Hematology Group, and all the other members and the dignitaries that are present here. So Dr. Surmila ma'am and also Dr. Jena has been highlighted the importance of the Eastern Hematology Group, what the Eastern Hematology Group is made for, and what we did so far. I will highlight in my short presentation of Eastern Hematology Group, past, present, and the future. So initially begins with the small slide. That slide is already highlighted the Surmila ma'am and Dr. Jena also. This is basically the concept of this. The Eastern Hematology Group is brought in the June 2015 in the Hyderabad by Professor Jena, the Surmila ma'am, and the Jena Bhattacharji, and subsequently in the meeting held into the Odisha, that is the 7th annual conference of the Odisha Hematology Kotak. So we sat together and unanimously agreed for the formation of the Eastern Hematology Group, with comprising the state of the eastern region, that mainly the Odisha, the Jharkhand, the Bihar, and West Bengal, and also the northeast part of this state like the Assam, the Meghalaya, Tripura, Mizoram, Manipur, Nagaland, and also the Arunachal Pradesh. And gradually I think that this area is becomes evolving in the field of the hematology, and gradually the hematology is become shifted from this part of the country due to the lot of advancement in the last 5 to 10 years, as Dr. Jena is highlighted. And this is basically concept of Dr. Jena and Dr. The Surmila ma'am, and also the other senior hematologists are also there in our faculty, and also the other members from the different parts of this the eastern regions are contributing for developing the hematology in the eastern part of this country. So for this development we did the several CMEs to educate the people, the undergraduate student, the postgraduate student, basically to make them interest in the field of the hematology. If we consider the other super specialty, that the hematology, the interest of the hematology is very less. So
Doctor, your voice is not audible. Your voice is not audible, doctor.
sorry. So with this, we'll start these different conferences. So first annual conference of the Eastern Hematology Group held in the Kolkata in the 19th and the 20th of 2016, and subsequently from this the 2016 we have a lot of the advancement is there in terms of the hematology, but still we are continuing our different activities, particularly the different CME. And during that time, the Eastern Hematology Group decided to the as highlighting the different parts of this the Eastern region, particularly the Kolkata, which is held in the 9th January 2016, then into the Patna, the 16th January 2016, and then subsequently into the Guwahati, the 22nd January of the 2016. And also into the Guwahati, in the small city, we able to gather the lot of the people to make them aware in the field of the hematology, the different diseases, and also the highlights of this the American Society of the Hematology. And subsequently, we moved to the Bhubaneswar, the 13th February 2016. We did the as highlight into the Bhubaneswar also. And into the Bhubaneswar, the audience is around the 300. They have been participated with the leadership of the Dr. Dajena. And if into the mall town like the Jamshedpur, we are able to organize the as highlight also under the guidance of this the Subhrakanti Kundu. Then subsequently the second annual conference of the Eastern Hematology Group in the Patna held in the 25th and the 26th March into the 2017, and along with the Rakta Bigyan 2070 under the leadership of Dr. Avinash. And this conference is also very success with uh, the highlights of the different diseases. And the main important thing is that the first ever the hematology conferences organized by Dr. Avinash into the part of the Patna, and this conference has become very successful. And there is around the 300 people have been participated in this the conference of this the Patna. Then subsequently we moved to the bone marrow transplantation again to the Kolkata, the bone marrow transplantation update in 2017. This is done under the banner of this Eastern Hematology, but the organizing secretary is Dr. Anupam Chakrapani, and Dr. Demballa Bhattacharya did this wonderful job by highlighting the bone marrow update in the Kolkata also. And subsequently, the BMT data presentation meet also held into the 21st October 2017 into the Kolkata. And this is again the sharing the experiences into the different centers acting into the Eastern region, starting from the Tata Medical Center, the Apollo Hospital, the NRS Hematology, and the Medical College, and also the Saroj Gupta Cancer, and also the SCB Medical College, and also Dr. Avinash, and all the people have been sharing their own data, how the BMT is becomes developing into the eastern part of this country also. Then we move to the third annual conferences. We able to organize into the Jamshedpur also into the small town where there is none of the hematologists is there, but under the leadership of the Subhrakanti Kundu, he is the very dynamic and the young persons, and we able to organize the third annual conference of the Eastern Hematology Group in the Jamshedpur. Though it is small town, so we approach there by the road or by the train, but yes, the people are very energetic, and they are able to gather in the Jamshedpur, and we are able to in that region by involving the physician, by involving the pathologist, by involving the other general specialty people for awareness of the different hematological diseases. And subsequently, the second BMT update is the 11th May 2019, held into this Kolkata also into the leadership of this Dr. Anupam Chakrapani again. The audience is the huge audience in this meeting. So we are able to conclude the BMT session also. Now into the part of this 2019, there is the August. This is one of the biggest event we did so far, called the Hope Asia 2019, along with the European Hematology Association and the Indian Society of the Hematology and the Blood Transfusion from the 23rd to 25th August. And in this conference, this is basically the huge conference. And in this conference, we are able to do the different activity in the field of the hematology, not only into the different lectures, but also in the field of the hematology, we able to do the different social activity, we able to do the small workshop, and we are able to do the activity not only to the main part of the city, but also the across the city also, to improve the hematological awareness across this country. And in these conferences, there is a lot of the around the 30 to 45 international speaker is there, and around the 700 to 800 people have been participated in this the Hope Asia, and this is the one of the most successful, the first Asia event into the under the banner of the Eastern Hematology Group and the European Society of the Hematology. We able to did in a very successful way, and the rating of these conferences out of 10 it is the 8.5. The majority of the people is becomes very give the big hands for our this Hope Asia conferences. And the first time we able to organize the work in the hematology for awareing the different hematological diseases to the general people. What is the hematology? What is the leukemia? What is the thalassemia, hemophilia? What is the anemia? To making the people become aware related to the field of the hematology, we did the work for the hematology, and this is also very successful. And there is a, from the senior to the junior, all the people becomes able to participate, and they are very dynamic, and they work a lot for the field of the for the awareness, and also making the hematology popular in this part of this country. So along with this, there's a lot of the international person is there from the European Hematology Association. They have been given big applause for arranging our Hope conferences in the Kolkata in this year 2019. After that, there is a COVID-19 scenario has been coming back, and from the 23rd March, the India is totally becoming the lockdown. And in the lockdown phase, our Eastern Hematology Group is not stopping, and Eastern Hematology Group is doing the different conferences through the webinar, not only for the hardcore hematologist, but also the involving the other general people also in the field of the hematology. And in terms of the arranging the webinar, we did the once module that is called the MPN under the microscope. We did the 4 modules for teaching the pathology people becomes aware of the myeloproliferative neoplasm. Our first module is the diagnostic issue in the 3rd July 2020, and subsequently our the second module is the morphological diagnosis of the MPN. The case-based discussion is did into the 10th July 2020, and then subsequently into the 17th July, that is called the module 3, the molecular diagnosis of the myeloproliferative neoplasm and the role of the diagnosis and the prognosis. So in this, the 4 module, there's interacting MPA diagnosis, the clinical picture, and the management, the 24th July. If we consider this 4 module, the response is very huge. Around the 500 to the 600 the attendee they log in our webinar, and we are able to make this even very successful and the very popular in the field of this hematology, particularly into the undergraduate people becomes interested to log in this MPN under microscope. And subsequently, there is an update of the MPN, that is the Martin Bissamars. They have been kind enough to give the lecture on this the 22nd August in Saturday 2020 for updating the myeloproliferative neoplasm. Then subsequently, there is a sickle cell disease update into the 3rd September 2020 by Dr. The Raffaella Colombati. Also becomes highlighted the aspect of the sickle cell disease into the current scenario. And then subsequently into the toward the disability free hemophilia, we did into the 10th October 2020 through our the Eastern Hematology faculty group, and this event is also becomes very successful in the field of hematology. And subsequently into the 21st November 2020, we able to do the sickle cell expert engage the current outlook and to the future. The Julie Cantor is our the main speaker. So from this the Julie Cantor, we are gather a lot of the information on what the sickle cell disease is going on and what the present scenario of the sickle cell disease. This webinar is also very become very successful. Around the 350 people becomes participated in this conference, and more recently into the previous Saturday, we did that is called the 12th December 2020. What is new is CLL. This is the another international speaker that is called the Chris Patel, and this conference, all this webinar is also becomes very successful. So even into the lockdown period, the Eastern Hematology Group doing different scientific activity to make the people aware in the related to the hematology and become upgraded in the knowledge of the field of the hematology, what the activity going on in the world, so we should know about it. Then subsequently, as Dr. Jena and Dr. Surmila ma'am is rightly pointed out, decided to do the virtual conference also, that is in the 18th and the 19th December. So very short period of time, Dr. Jena is able to catch the Dr. Saji Kumar, the Mayo Clinic, Dr. The Dragon, Dr. Kalpana Gupta and Abdul Kudar from the myeloma and the sickle cell disease. This is becomes the two important topic in this the conference, because this the e-conferences is nowadays becomes very successful, and people can able to listen what the international, the national people is becomes telling into the different aspect in the field of hematology. I think into the subsequently the 2 days, the 18th and the 19th December, we are able to give little bit of the flair of the different aspects of the hematology, particularly the recent advances. And our friends of this, the conferences are Novartis Oncology, the AstraZeneca, the Intas, the Johnson, the Takeda, and the Inter Celestial Division, Bharat and also the Plasmagen Life Sciences. And our future conference is the HematCon 2020. The annual conference of the ISHBT will be held in the Calcutta. It also will be under the banner of the Eastern Hematology Group. The organizer will be the Eastern Hematology Group, and also it will be in the Kolkata. So the Bengal Society Hematology and the other parts of this the Eastern group becomes active participation, active involvement to making this HematCon 2020 become successful, I think, with the help of these people from the Eastern Hematology Group. If you want to more information, you can visit our website, that is called the www.easternhematology.com. So we are able to find out the more information, different activity, the scientific conferences in the field of hematology. With this, I thanks all the members of the Eastern Hematology Group, the executive committee member of the Eastern Hematology Group, all well wishers, all the participants, and all the audience who are listening us. I think in the down the 2 days, we are able to give the good flavor, different hematological disease aspects, and the people will enjoy it, the 2 days scientific extravaganza. I think with this, we'll end here, and thank you very much. Over to Dr. Prakash.
Thank you, sir. Thank you for highlighting the importance and all the past presentations and all the seminars which we all have enjoyed a lot. And it was a beautiful introduction for this 5th annual conference. Now it's time we move forward, we move ahead for the main programs as highlighted. And I think we all will gain enough by attending these webinars. Fortunately, unfortunately both. This webinar is sponsored by. So for this next session, I would like to request Dr. Pradeep Mitra sir. He is COVID coordinator for the government of West Bengal and is director of hematology research.
Hello. Hello.
Yes, doctor. Doctor, you can go ahead. I think Dr. Prakash.
Am I audible?
Yeah, you are audible, doctor.
Okay. Thank you for the introduction. Actually, I'm not the presently director. I'm the former director of the medical education. Anyway, so first session is on aplastic anemia. And you know, the aplastic anemia, usually the hematologist, all the hematologists will agree that aplastic anemia cases, they do come to the hematologist very late. And we know that the aplastic anemia treatment is totally unpredictable. Who will respond to non-transplant treatment and who are not is a matter of question. So let us listen from Uttam Nath, Dr. Uttam Nath, head of the department hematology in AIMS Rishikesh, who will speak on the non-transplant treatment of idiopathic, aplastic anemia in 2020. So what is new about that? So without wasting time, we can go forward to Uttam Nath.
Dr. Uttam, should I share your PPT? Doctor, your voice is not audible. Doctor, your voice is not audible. Dr. Uttam, your voice is not audible. Dr. Uttam, your voice is not audible. I'm sharing your PPT, doctor, from my angle. You can just tell me next.
Hello?
Yeah, doctor. Now your voice is audible. Can you see the screen?
Am I audible now?
Yeah, you are audible now.
Hello?
Yeah, doctor.
Is my voice audible now?
Yes, doctor, your voice is audible now.
Okay. Thank you. So,
so
good
you
afternoon,
want me to share
everyone.
the PPT or you will be sharing, doctor?
Can I share now?
Yeah, you can share. I'll just stop it.
Okay.
Now
Let
you
me
can
try.
start. Yeah, you can start now.
No. Host disabled participant screen sharing. I think it's disabled from your end. Okay, please share.
Doctor, you can do it now. You can do it now.
Okay.
You can do it now.
Yeah. Share. Okay. So is the screen audible? I mean visible now?
Yeah, screen is visible. Make it.
And I'm audible. Okay, just a minute. Let me make it full screen. Okay. So good afternoon, everyone. Good afternoon, and thanks to the organizers for giving me the opportunity to be the first opening batsman for this academic extravaganza. My talk is on non-transplant treatment of idiopathic aplastic anemia in 2020. So I think there is a considerable amount of participation from the postgraduate residents in Eastern Hematology Group conferences as per my experience. So I would keep it friendly, the presentation and talk postgraduate friendly, and I can answer at the end of the presentation through chat. So aplastic anemia is characterized by peripheral blood pancytopenia and a hypocellular bone marrow without any evidence of malignancy, that means leukemia or some other malignancy, dysplasia in the marrow and or significant fibrosis. The major causes are secondary, out of which idiopathic is the commonest, and in children and young adults we get several disorders which present like aplastic anemia. These are the inherited bone marrow failure syndromes. I will just focus my talk on the secondary and idiopathic aplastic anemia for today's discussion. Now, acquired aplastic anemia is immune mediated destruction of the bone marrow, hematopoietic stem cells and progenitor cells, leading to a hypocellular marrow and pancytopenia, or one or more lineages are affected. Before initiating treatment of aplastic anemia, hence it is very important to exclude MDS, acute leukemia, and the inherited bone marrow failure syndromes, mainly Fanconi anemia, dyskeratosis congenita, etc. As you can see through molecular studies, it has been seen that there is a considerable overlap. There can be an overlap between the IB, inherited bone marrow failure syndromes, and acquired aplastic anemia. And sometimes some environmental insult leads to unmasking of this genetic predisposition. Now, the major causes of inherited aplastic anemia are Fanconi anemia, dyskeratosis congenita, Shwachman-Diamond syndrome, as I have already, megakaryocytic thrombocytopenia, as I have mentioned, some GATA2 abnormalities. Acquired aplastic anemia, the major causes, major condition is mainly idiopathic, as I have mentioned. Other disorders which can lead to aplastic anemia are PNH, immune disorders, any viral infections, drugs, radiation, chemicals, environmental toxins, etc. Now, as you can see, severe aplastic anemia, non-severe aplastic anemia, all these have a considerable overlap with other autoimmune disorders, PNH, and sometimes hypocellular or hypoplastic myelodysplasia can mimic severe aplastic anemia. Okay, so we need to make the correct, accurate diagnosis for a better outcome and definitive management. In brief, the pathophysiology of acquired aplastic anemia is mainly, as I have said, it's mediated by cytotoxic T lymphocyte population, a subset of the cytotoxic T lymphocytes, which suddenly start destroying the bone marrow stem cells, hematopoietic stem cells, and progenitor cells, either mediated by Fas ligand or cytokines, different cytokines, and in the process the marrow becomes hypocellular. The reserve or pool of hematopoietic stem cells or progenitor cells in the marrow is drastically decreased and leads to cytopenias of varying severity. Now, to classify classify idiopathic or secondary aplastic anemia, the Kamita and Bacigalupo classifications categorize the disease into non-severe, severe, and very severe. Severe aplastic anemia is the criteria of diagnosis are absolute neutrophil count of less than 500 per microliter, platelet count of less than 20,000 per microliter, and reticulocyte count, absolute reticulocyte count of less than 20,000 per microliter. And 2 out of these 3 peripheral blood cytopenias must be present to categorize as severe, plus severely hypocellular marrow of less than 25% cellularity and with less than 30% residual hematopoietic cells is essential for diagnosis of severe aplastic anemia. Now, there is another category under severe anemia, that is very severe aplastic anemia, where the neutrophil counts, absolute neutrophil counts, are further decreased to less than 200 per microliter. Non-severe aplastic anemia is any aplastic anemia which does not fit into the category of this severe or very severe aplastic anemia. Now, in brief, if we see this algorithm for management of acquired aplastic anemia, it's mainly dependent on whether the person has a matched sibling donor for allogenic stem cell transplantation and what is the age of the patient. These ages, age cutoff of 40 is actually nowadays being blurred. So sometimes you can consider it as up to 50. If the person has a matched sibling donor, HLA-matched sibling donor, and age between age less than 40 or less than 50, then straightway the person should go for sibling BMT or allogenic BMT from the sibling after initial stabilization. And if there is no matched sibling, then in younger patients less than 20 years, the consensus is either towards an immunosuppressive therapy or towards unrelated donor BMT. Okay, because the outcomes in this age group may be still better with an unrelated donor BMT. Now, non-transplant management of severe aplastic anemia or moderate aplastic anemia, this includes mainly the immunosuppressive therapy, that is anti-thymocyte globulin and cyclosporin combination. Nowadays, we have another regimen which is the triple immunosuppressive therapy, which includes addition of L-trombopag to this ATG plus cyclosporine therapy combination. So my talk would be focused on this immunosuppressive therapy, including ATG and cyclosporine, and now it is with L-trombopag combination. People have tried other modifications to this immunosuppressive regimen, immunosuppressive therapy regimen, in the form of sirolimus, mycophenolate, danazole, anabolic steroids, monoclonal antibodies, growth factors, but basically there was no significant improvement to this ATG plus cyclosporine combination prior to the addition of L-trombopag. Regarding ATG plus cyclosporine combination, this is the standard first-line regimen for severe aplastic anemia. Response rates vary between 60 to 70% cases, and if started early, long-term survival is very good among those who respond within 6 months. So all patients who do not have a matched sibling donor for transplant, or even patients who are older than 50 years maybe, they are recommended, it is recommended that they receive immunosuppressive therapy with ATG plus cyclosporine without any delay. Suppose if there is a failure after an initial response, that is relapse, or the disease does not respond at all in 6 months, then the choices are between a matched unrelated donor transplant or a second course of ATG. I'm coming to that later. Horse ATG and rabbit ATG have been compared, and it has been seen that till date horse ATG response rates and survival rates are far superior to rabbit ATG, and hence horse ATG is the recommended form of ATG for first line therapy in combination with cyclosporine. And if there is no response or there is relapse, then either horse ATG or rabbit ATG can be considered for a second IST therapy trial. What are the dosages for the postgraduates? The dose of horse ATG is 40 milligram per kg per day on 4 consecutive days. This is horse ATG is administered through intravenous infusion. You need a central venous access preferably, and you need a test dose. Usually 1 vial is given in a very diluted concentration with pre-medications, and also corticosteroids are continued for around 2 to 3 weeks to
Dr.
prevent.
Nath, your time is up, so try to
Okay. Sorry, yes. To prevent serum sickness. The dose of cyclosporine is between 5 to 6 milligram per kg per day in 2 divided doses, and the dose of rabbit ATG, if rabbit ATG is tried, then the dose is 3.5 milligram per kg per day for 5 consecutive days. Again, you need pre-medications, corticosteroids, and long infusion. You need to keep the platelet count maintain above 20,000 on these days where you are administering ATG. There is an age relation in ATG response to ATG plus cyclosporine. Younger patients respond better, and older patients have a lower response rate compared to younger patients. In patients older than 60 years, the response rate is around 40% compared to 60 to 70% in younger patients. This is the Indian data from different centers, and the results are comparable to Western literature. Responses between 60 to 80% is seen. What are the problems with immunosuppressive therapy? One is it is not curative, unlike BMT. Second, if there is no response, the response rates to a second course of ATG plus cyclosporine is between 30 to 40%, hardly. And if there is relapse, again, the response rates to second course of ATG are lower. There can be clonal evolution to PNH, frank PNH, or there can be evolution of a PNH clone. And if there is cytogenetic evolution to MDS, or particularly monosomy 7 or deletion 7, chromosome 7 abnormalities, then it is very difficult to treat. You need BMT straightway. GCSF combination with ATG plus cyclosporine may be beneficial in the Indian scenario, because if it reduces the neutrophil recovery time, then as we know, infections, many patients will be saved from infections. but there is no role of single agent GCSF in aplastic anemia. So it has to be combined with ATG plus cyclosporine. Regarding androgens, androgens alone or in combination with cyclosporine has shown encouraging results. Mainly danazol is used, and in children you can use oxymetholone or stanozolol. Androgens are also preferable for patients who are not fit for intensive immunosuppressive therapy, and particularly those patients with telomere abnormalities are more likely to respond. Now coming to newer approaches, as we have discussed,
You have to
L-thrombopag.
finish. You are
Yes, sir.
overshooting your time.
Sir, actually there was some problem in starting. So
That's right. That's right. I know.
Give me 2-3 minutes. Okay.
Yeah.
So combination of L-thrombopag has been shown to be effective and increase the response rates and early recovery. Alemtuzumab is another viable option, although it is not available in India. So I will be focusing on triple immunosuppressive therapy in the form of ATG plus cyclosporine plus L-thrombopag. L-thrombopag, as we know, it is a TPO receptor agonist, orally administered small molecule, and it directly affects the marrow and stimulates the marrow to increase the pool of the residual CD34 positive stem cells and progenitor cells. Previously, it was approved by FDA in refractory severe aplastic anemia, but now recently it has been approved as first line in combination with ATG plus cyclosporine. This is how it acts. The depleting bone marrow pool of stem cells and progenitor cells. The earlier you start L-thrombopag, the better, because it depends on the amount of residual stem cells. There is some risk of chromosomal and clonal evolution with L-thrombopag, but till now the responses are in favor of addition of L-thrombopag. What is the dose of L-thrombopag? In aplastic anemia, the dose is 150 milligram per day, and there are restrictions with dietary restrictions, like it has to be given in empty stomach, at least 2 hours away from meals, and at least 4 hours away from calcium containing or magnesium containing elements. It is usually very well tolerated, and you need to monitor the LFT. It has been shown that the response can be very robust, so that you can, at one point of time, you can even think of discontinuing L-thrombopag, and still the residual, still the hematopoiesis is salvaged. So just to summarize the non-transplant options for treatment options for severe aplastic anemia and even in non-severe aplastic anemia, the last decade has seen tremendous progress. The new drug L-thrombopag, this is the first drug to be approved in 30 years in aplastic anemia. Horse ATG and cyclosporine combination is the standard first line immunosuppressive therapy. Rabbit ATG, although it's more toxic and responses are somehow lower, it is a viable option as a second line, and addition of L-thrombopag is to ATG plus cyclosporine is the standard of care for severe aplastic anemia at present. Thank you, and I can answer questions through chat. Thank you.
Okay. Okay. Definitely going to the second speaker. I know these are very tight scheduled, so we can't help. Dr. Biju George is professor and head of the Department of Hematology, CMC Vellore, and he is a member of ASH and chairman of the Inherited Bone Marrow Failure Committee. He will speak on the transplant treatment opportunities, transplant treatment in aplastic anemia.
Thank you. Is my video going to be played? I think it's already recorded.
Yes, doctor, I'm going to play your video.
We are now all learning how to talk on a virtual platform with nobody in front of us. I'm going to be spending the next 10 to 15 minutes talking about bone marrow transplantation for aplastic anemia. Now, aplastic anemia can occur in 3 different ways. One is exposure to cytotoxic drugs, radiation, Second is what we commonly see is idiopathic, and we believe it's because of immune destruction. And third, there are a lot of inherited bone marrow failure disorders, including Fanconi anemia, dyskeratosis that we commonly know, telomere disorders, and we are now finding more germline mutations that we can see. But irrespective of what the pathophysiology is, hematopoietic stem cell transplantation is one of the best treatment options for any patient despite all the etiologies. If you look at patients who have an idiopathic or immune-mediated destruction, you have the option of a stem cell transplant and immunosuppressive therapy with ATG and cyclosporine. Now, this is, you can see different algorithms of how you treat, but I pulled this out mainly because now this is slightly different. So in adults, we are looking at whether an HLA match sibling is available. If there's an available, that would be the best treatment. Now, there is an age cutoff. Some people say 40. At our center, we would keep 50. If you go to Seattle, they would say 60 for a sibling donor transplant. And if the donor is not available or if the patient is too old, you would consider immunosuppressive therapy. If there's no response at 6 months, then you would consider other forms of bone marrow transplantation, including a matched unrelated donor or a haploidentical transplant. Now for children, you should remember it's slightly different. Yes, if you have a matched sibling donor, it is best. If you don't have, you would consider immunosuppressive therapy, but people have also understood that a lot of the response to immunosuppressive therapy in children is not as good as adults. And so you may actually directly decide to go for an alternate donor transplant. Now, India is a part of Asia, and so we got a large incidence of aplastic anemia. With a population of about 1.35 billion, we would estimate about 10,000 or more cases of aplastic anemia. And the important thing to remember is that this affects all strata of society, right from the very rich to the poor. So we should have treatment solutions which are applicable to all patients, if you want, even we are practicing in India. So I think the first and foremost, when you see a patient with severe or very severe aplastic anemia, is we need to make decisions fast. Is this patient a transplant candidate? If we think it's a transplant candidate, we need to get HLA typing done quickly. Now, a lot of times people make a decision of saying, let us give a trial of drugs and then let us see whether it fails before we take up. Now, we need to remember that unfortunately, there are a lot of problems related to that, notwithstanding the fact that you may have cytotoxicity related to the drugs. So cyclosporine can cause renal dysfunction, and somebody comes with renal dysfunction for transplant, then you're going to have problems with post-transplant. If you are put on danazol, and your liver enzymes go up, you're again going to have problems. So ideally, you should not start any drugs unless you feel, or after talking to the patient, you feel that you're going to take a few months before you can actually take up for transplant. Otherwise, we should proceed for transplant as quickly as possible. There are big challenges in developing countries like India. One major problem is the fact that many, especially in the rural society, have poor access to healthcare. So less effective therapy is given initially, and so they are referred late. Second, of course, transplant is a financial burden for most of the people, because in India, most of us have to pay out of the pocket. So you need money to arrange finances. So both these financial constraints and late referrals both lead on to multiple transfusions, recurrent infections, recurrent hospitalization, and all the subsequently leads on to poor outcomes. So if we can minimize this and we can get them early to transplant, that means you can minimize transfusions and infections, you can probably deal with better outcomes. Now, if you did a transplant, what are the chances? And this is data from the CIBMTR looking at patients below the age of 18. So they're close to 88 to 90% would be cured with a sibling donor, and about 80% with an unrelated donor. While if you go above the age of 18, it comes down to about 78, 80%, and unrelated donors come down to about 70%. Now, this is our own data. This is till June, about 2,500 transplants that we've done overall. And aplastic anemia is the third highest indication for transplant after thalassemia and acute myeloid leukemia. We have done roughly about 425 transplants for aplastic anemia, including sibling, MUDs, and haplos. And over a period of time, we have learned and adopted protocols to suit the Indian scenario. So we started with the original protocol of cyclophosphamide ATG, and we did about 26 transplants of over 10 years with the graft source being narrow. Rejection rates close to 26%. 5 patients had a second transplant with an overall graft host disease incidence of 35%, but our survival was poor at about 52%. Subsequently came out the data from Slavin looking at reduced intensity, the addition of fludarabine, which is actually more immunosuppressive. And so we used flubu with very low dose AdGam, about 19 patients. We changed over to PBSC. There we managed to bring down the rejection rates to about 10.5%, but the GVHD rates went up slightly, 40%. It increased slightly from 52 to 57%, with death still due to infection and GVHD. Now, 50% in a malignant transplant is all right, but I don't think it's good for a non-malignant disease like aplastic anemia. And one of the challenges was to see whether we could have a better protocol which could be afforded by a larger number of patients, which was cost effective. So we started this protocol of fludarabine, cyclophosphamide, where we essentially changed the busulfan to cyclophosphamide. We used ATG for a few patients, but we finally took it off. And then we went on to using cyclosporin methotrexate and PBSC looking at 6 to 8 million CD34s. So we've done about 230 patients with stem cells, peripheral blood stem cells being the source. We managed to bring down the rejection rates to about 4%. We had an acute GVHD rate of 27, a chronic GVHD rate of 38, and we managed to improve our overall survival to about 76%. So from 55%, 57%, we have gone up to 76%, infection still being due to GVHD and infection. Now, if you split it up, less than 20 years, our cure rates are 82%, and 20 to 40% about 76%. That means we are about 5% lower than what you would see with the CIBMTR, which is reasonable, and above the age of 40, it's about 55%. But if you divided the whole group into high risk and low risk, and what we defined as high risk is somebody more than 20 transfusions, more than 3 months from diagnosis, somebody whom we are taking with active infection, major organ bleeding, or if they have failed previous ATG, then if they did not have any of this, that means they were low risk, we had almost a 92% chance of cure rates. While if we had any of this, you had a 67%. Now, unfortunately, if you take the whole group, only about 1/3 fall into a low risk category and 2/3 fall into a high risk category. So we need to see how we can modify that. But one of the problems with this approach is that we still have a lot of chronic graft versus host disease with the cyclosporin methotrexate. And so we were wondering whether we could do something about it. Then came out the data on using post-transplant cyclophosphamide. And so we did our initial analysis looking at a phase 2 study of looking at graft versus host disease prophylaxis with PTCY alone in patients undergoing matched sibling donor transplants. And this is the data compared with a historical cohort. We managed to bring down the acute GVHD rates to almost 22% from 50 and 60%. And we managed to bring down our chronic GVHD rates also down. We had a slightly higher incidence of infection, because of which overall survival did not change. So the PTCY was very useful in decreasing the GVHD rate. So we have actually now started a multi-center Indian trial comparing PTCY with cyclosporin methotrexate in patients who have undergone sibling donor transplants for aplastic anemia. The other area of interest has been with telomere. We know that telomere biology plays an important role in aplastic anemia. And so we were looking to study the impact of the patient and donor telomere length in patients having transplant for aplastic anemia. Now, there is data from around the world suggesting that in unrelated donor transplants, the donor telomere length seemed to play an important part. So we looked at about 163 patients who underwent sibling donor transplant. We looked at patient and donor telomere length and its effect on outcomes. The manuscript is in preparation, but what we essentially showed was a highest quartile of donor telomere length was significantly associated with transplant outcomes, as did the presence of acute GvHD and age. So donor telomere length seems to be a problem. We need to explore this further in larger studies. Now, those who do not have a donor, what can you do? This is our own data on ATG. So if you look at people above the age of 15, all of them have almost a 60% response, while under the age of 15, the response is only 30%. So what do we do for these patients? Now, what has come up is haploidentical transplants. There are multiple studies done overall, suggesting between 50 to 90% overall survival. But I would say, please be careful, because our own data, and I know talking to other investigators around the country, we are having a big problem. We have done about 4 to 5 transplants for aplastic anemia. Our overall survival is sitting at about 40–45%. We have about 25% graft failure rates, and second, importantly, graft versus GNB sepsis. So haploidentical transplants in India is not as effective because of all the complications associated with it as what is described in the West. But if you take these patients up early, you may have a benefit. So we looked at about 16 children who went for 20 transplants without being exposed to ATG. And these were small children because of a previous experience with ATG where we knew that we would not get much improvement. We decided to take them up. They had no active infection, age between 1.5 to 12 years. Out of the 16, 4 had mud transplants, 12 had haploidentical transplants, and the overall survival rate is 80%. So it is reasonable to think that for small children or children where you do not have the luxury of exposing them to ATG and after that they have the finances to go for a haploidentical transplant, you could consider upfront alternate donor transplant for these patients. So in conclusions, a transplant using a matched sibling donor is associated with cure rates of more than 75% in young patients. An earlier transplant is associated with better outcomes, so you should try to take them in as quickly as possible. Outcomes with haploidentical transplant are still poor. We need to look at newer protocols, but you get more than 70% survival if taken up early, and we need to explore cost-effective methods of transplantation for aplastic anemia. With this, I will close and I'll be happy to take questions.
Tight schedule. So thank you, Dr. George, again. Now we'll be going to our panel discussion. You have heard the non-transplant and transplant management overall, and now we are going to the case-based management. Here, the moderator will be Dr. Rajiv De, who is the associate professor in the hematology department in NRS Medical College. And we have 5 panelists. Dr. Parthospotim Gupta, he is also associate professor in same college in NRS. Shubham Bhattacharya, also associate professor in the department of hematology, NRS. And Dr. Tushti Ganguly, she is the consultant hematologist, Sarojgupta Cancer Center. And Pritish, Pritish Chandra Patro is the assistant professor hematology, IMS and SAM Hospital, Bhubaneswar. And last one is Vijit Fukan. He is a consultant hematology and hemato-oncologist, Excel Care Hospital, Assam. So I'd like to hand over this session to Dr. Rajiv De to moderate the session and case-based management to start with.
Yeah, I would like to First of all, thank you all, and thank you EHG for inviting me to conduct this panel discussion session. I would like to present my panel discussion from my side. Okay, so I'm sharing the screen. Is it visible to all? Hello.
Yes, visible. Yes, visible.
Okay, fine. And yes, I'm putting it in the slideshow mode. Okay. So after discussion on non-transplant and transplant-based management of aplastic anemia, so here the topic is case-based management of aplastic anemia. Basically, in this panel discussion, what I tried to do is all of us, all of the panelists, they know how to diagnose, how to treat. So there is no point discussing all those things. So we need to find out what the issues with aplastic anemia in managing day-to-day practice and how we practice. So this panel discussion is basically to share our experience and to know each other, how we practice or how we handle each issues in our day-to-day practice. So this already mentioned by our chairperson. I just presented this. Shuam's photo is not for any other reason, but he has sent me the slide. That's why I put it here. So these are the issues in aplastic anemia to be discussed. One is during diagnosis, in addition to conventional diagnostic methods, whether the screening for somatic mutation at baseline has got any value or implication. Number two is the patient will present with pancytopenia and symptomatic pancytopenia. They won't come with a diagnosis of aplastic anemia. So while approaching a pancytopenia, whether there is any role, do we actually need to differentiate hypoplastic anemia and hypoplastic MDS? Does it has got any real implication as far as treatment is concerned, as far as prognosis is concerned? Then the determinants of treatment algorithm. The treatment algorithm, multiple treatment algorithm we have already seen in previous two presentations. So what are the determinants of those treatment algorithms? Have we improved the efficacy of immunosuppressive therapy, double versus triple, role of L-thrombopag, the pros and cons, rabbit versus horse ATG, which should be used and when, donor with the optimum donor, and if the optimum donor, mass sibling donor is not there, whether we have any other options, sources of progenitor cells, bone marrow or peripheral blood, and factors related to transplant outcome. And most important is real world practice scenario, how we address these issues. So this has already been shown by Biju sir. So it is taken from NEGM. We know that pancytopenia may have different etiologies, but here we are discussing, focusing the middle one, that is idiopathic pancytopenia or immune-mediated pancytopenia or aplastic anemia. And this is overlapping syndrome. It may include the telomeropathy, the inherited bone marrow failure syndrome, and it may progress to myelodysplastic and AML. And there are different roles of B-cell immunity, T-cell immunity, depending on the lineages. If a single lineage is affected, usually the B-cell immunity comes into play. And when it is over, aplastic anemia, full-fledged aplastic anemia, so T-cell immunity becomes very important. And so keeping these things in mind, these overlapping features, so I am presenting a case. This is how to approach. It is a typical 41-year-old male patient presented with symptomatic pancytopenia. On examination, there was no lymphadenopathy, organomegaly, peripheral blood, typically pancytopenia, bone marrow, hypocellular marrow. not significantly dyshematopoiesis, only few mild dyserythropoiesis is there, low erythrocyte count, B12 folate normal limit. So this is a typical case of aplastic anemia. Now, with these informations, how confident we are to diagnose these as an aplastic anemia and straightway starting treatment, rather than whether we need to do some other evaluation, some other investigations. I am not directing the questions to any of these panelists. Anybody can pick up this issue and can just volunteer. Dr. Pritish, you are
Okay, sir.
interested. I can see you are interested to reply. Please.
Thank you, sir. Sir, actually, everything is likely typically aplastic anemia, except the finding that there is significant dysplasia in the erythroid lineage. There is karyorrhexis and other things also. So we have to also differentiate it from hypoplastic MDS. Though the management may not differ much in most of the situations, but I would like to differentiate it at this point of time.
Okay. So what are the investigations you want to do at this point of time?
Sir, cytogenetics.
The dysplasia is not that significant. Okay, it is the only mild dyserythropoiesis is there. So I don't think if you don't consider those dysplasia, then what are the investigations you need to do at this point of time before going for therapy?
Sir, apart from this bone marrow aspiration biopsy, I would like to also do the conventional cytogenetics, and with this dysplasic features, I will also like to do a fish panel for MDS also.
Fish panel for MDS, and the routine which we do the PNH clone to rule out PNH clone.
Yes, sir. Apart from the stress cytogenetics and PNH clone.
And 41 is borderline. Any panelists want to add or give their comment? Anybody? Dr. Tushti, Abhijit. So
I think they cannot unmute themselves.
Please, all the panelists, please unmute your microphone and please give your comment. So, so in addition to this, yeah. So at this age, that is at the age 41-year-old, as the age of doing stress cytogenetics is increasing day by day, so now it is 50 roughly. So I think we need to do stress cytogenetics also, and to do assess PNH clone. My issue is whether we need to do the mutation study, the panel of genes which we found mutated in aplastic anemia, whether we need to do those mutation study at the baseline. That mutation doesn't only include the fish for MDS panel, only not chromosome 5, 7. So the panel of gene mutations by next-gen sequencing, whether it does got at value at the baseline investigations for panel discussion. Anyone? Dr. Shubham is there? Hello, Dr. Shubham. So it is seen that.
So at this point of time, doing the mutation testing, I don't think these are any going to get help in decision of the treatment or response assessment or further long-term survival of the patient. But it has been also known that at the point of presentation, the incidence of cytogenetic abnormalities around 12 to 15%, and the incidence of around the mutations is around 40 to 50%. And though the clinical importance is not significantly affected by these findings, but it is to be mentioned that the presence of any driver mutation at this point of time, like DNMT3 or ASXL1, will have the potential to turn the disease into MDS or AML on the long term. And apart from that, the percentage of the clone of the Piga gene mutated population may also change, and it may also decrease with the response or it may also increase in those patients which are going to turn into frank PNH.
Perfect. So there are some issues with the gene mutations by NGS in aplastic anemia. Clonal hematopoiesis is seen around 47% of the patients of aplastic anemia, and 1/3 of patients showing somatic mutation in addition to the germline mutations. And some mutations, as Dr. Pritish mentioned, that like BCOR1, PIGA, they are associated with good response to immunosuppressive therapy, and some mutations actually have a worse outcome. So these are findings, and these are findings found in different studies, trials, but this clonal dynamics is not very straightforward, and till now it is not directing our therapy, though it has got some implications as far as prognosis is concerned. It doesn't have any treatment guidelines. So this is a very good article published in NEJM. So we can see a lot of gene mutations are there by NGS, and BCOR, PIGA, DNMT3, ASXL, these are there. And with age, their number and frequency increases. And we can see clearly that the genes PIGA, BCOR, these genes are associated with very good overall survival to immunosuppressive therapy. And there are some genes like DNMT3, ASX1, and RANX1, which are associated with poor response to immunosuppressive therapy, and many of them progress to MDS or AML. So although there is no guideline to do all these investigations at baseline, so we need to keep these things in mind. If patient can afford, these informations may help in prognosticating the patients. Now, okay, once we have diagnosed, how to treat? So what are the determinants of treatment algorithm? Any of the panelists can pick up this question. We have seen multiple algorithms already mentioned over here, and sir also said that a lot of algorithms are there. So I can show a few of them here. So what are the treatment algorithm? Determinants of treatment algorithm. Yeah, Dr. Shubham. Hello.
Hello.
Yeah, Dr. Shubham, tell me.
Hello. Am
Yes.
I audible?
Yeah, you are audible.
Hello.
Yeah, you are audible.
Yes. There are various treatment. Yes. Okay, I'm starting. There are various treatment algorithms. The first thing which is important, that whether the patient, what is the age of the patient, and prior to that we have to prognosticate that it is not a inherited bone marrow failure syndrome, because the treatment of inherited bone marrow failure syndrome is more or less different from the idiopathic aplastic anemia. So first we have to differentiate it. Secondly, we have to see what is the age of the patient. Is it less than 40 years or more than 40 years? This is the consensus, or this is the standard dictum. If it is more than 40 years, then usually transplants is not effective. Although there are several case reports and studies for the adverse prognostic factors regarding transplant, but the general dictum is if less than 40 years, we'll go for transplant. If more than 40 years, we'll first try the immunomodulator or immunosuppressive therapy, and later, if failure of it, we can try for transplant. So most important factor is age, and second thing in our context, it is the availability of the resource. If I advise some patient regarding allogenic stem cell transplant, it is not always possible to do transplant straight away. There must be an available donor. The person should have a good financial and other backups. Then only he or she can go for transplant. So these are the important factors regarding the treatment issues. In children less than 40 years or less than 18 years in this chart, pardon? Hello?
Yeah, tell me. It is audible.
Hello?
You are audible, please. You are audible. Okay.
So first, first transplant in less than 40 days.
So
yes. And I'm started to try transplant if this ATG.
Yes. So Dr. Shubham has addressed the issue very perfectly. That is, the options are transplant or no transplant. There are different determinants. Number one is availability of donor, matched sibling donor. And one important is age of the patient. The way we see the different guidelines, suppose the BSH guideline published in 2015. Here, the cutoff is 35. Then came the this Basic-Aluko article in 2017. The cutoff is 40. And in this Neil Young article in NEJM, published in 2018, so it is 40, but as I said, that some groups also practice up to 50 years of transplant as a cutoff of transplant. So our intention is to do allogenic transplant if matched sibling donor is available. Up to 40, yes. Between 40 to 50, it is okay. But if it is less than 18, we are very inclined to do transplant, whether it is matched sibling donor or an alternative donor. And in other cases, we do immunosuppressive therapy. So I think this is the practice which we follow. Any panelists that differ from this approach? I think no one.
No, sir.
So once we decide to give immunosuppressive therapy, because very few of our patients are either eligible, either clinically or financially for transplant. And when they decide for transplant, it becomes a difficult transplant because already they have received a lot of transfusion, as well as we have started cyclosporin, the renal function started deteriorating. So these issues are there. So while going for immunosuppressive therapy, double or triple therapy. Again, in the previous two lectures, we have seen that triple therapy is better than double therapy. So any of the panelists give any light on this, what you practice, double therapy or triple therapy? How do you decide whether to give double therapy or triple therapy? Any of the panelists? Parthoda, Dr. Tushti, any comment on it? Dr. Ovijit? So,
hello.
Do you counsel for triple therapy or still follow the double therapy?
No. Nowadays, see, looking at the data of triple therapy is really exciting. The overall response rate is going up to almost 90%, and 50% of patients are going into CR. So it's really exciting if you compare with double therapy with 70% overall response and 10% of CR. So if the patient in our socioeconomic status in our hospital, if the patient can afford triple therapy, we always go for triple therapy.
Yes.
And if the patient is fit otherwise, medically. And
exactly. So different trials showed that the triple therapy is better than double therapy, but issues with clonal evaluation, long-term side effects like progression to MDS or AML, these issues are there. But till now, the different trials didn't show that L-Tromopag is associated with significant clonal hematopoiesis. But most important determining factor is finance, because it adds a lot of finance, because it is very difficult to afford ATG in our population also, but therapy will be very expensive. And we can see that different trials showed that L-Tromopag is associated with increased clonal abnormalities, increased accumulation of clonal abnormalities. This is there in different trials, but this trial, which is L-Tromopag added to the upfront standard immunosuppressive therapy, where there was 3 arms, it showed that if L-Tromopag was added from day 1 and continued till 6 months, the overall response is definitely much better, and overall response is around 87%, so near more than the response of transplant. So that information is there, and the side effects are actually not much as per this trial. And as far as bone marrow cellularity is concerned, CD34 is concerned, so this triple therapy really showed a significant improvement. But long-term toxicity clonal evaluation, we still are waiting for this RACE trial, which is an European trial, which is a basically cohort trial comparing it with the control population. So let's wait for the preliminary report, which is published in August and September this year. They are showing again encouraging results. So if patient can afford, we will go for triple therapy. Now, while using ATG, what you choose, whether it is rabbit or it is horse, and when. So whether rabbit is out of scenario altogether, or there is some role of rabbit also. So what is your opinion? Dr. Obhijit, Pushti, are you there? They are silent. So anyone, Dr. Partho, Dr. Pritish, Shubham,
the various results from various institutes have already shown that the horse ATG has a better result. We know that rabbit ATG is more immunosuppressive than the horse ATG, so the toxicities and complications are more in the rabbit ATG as per the current evidence. And some trials are there, and as per this slide showing that the result is significantly better in those patients receiving the horse ATG and those patients who are young.
Yeah. So definitely rabbit ATG is more immunosuppression, more lymphotoxic. In spite of that, it is associated with more infections, more mortality, and the overall response is almost half compared to the horse ATG as far as immunosuppressive therapy is concerned.
And another thing is that at which point of time we are considering to give the ATG. If it is an initial therapy, then we should prefer the horse ATG. If the patient has not responded to initial therapy or has relapsed after getting the first ATG therapy, then we can think. Then if we think repeating the ATG therapy, then at that point of time we may consider giving a rapid ATG.
You are absolutely correct.
Transplant setting.
Yes.
Also rapid ATG can be preferred.
Yes. So it is absolutely correct. That is, it is not that the rabbit ATG is a big no-no in treatment of aplastic anemia. There are some areas where rabbit ATG is also effective. One is when we are giving second ATG, patient relapse or refractory to horse ATG. And in the case of transplant, it has shown that rabbit ATG is VSD compared. But as far as IST is concerned, it is clearly shown that horse ATG is better, showing overall survival, better overall survival. So it is there. But when there is relapse or refractory disease, then there is a role of rabbit ATG in choosing a second ATG. And we are very aggressive about counseling these patients for transplant, I think. Transplant in aplastic anemia. Who is the preferred donor and when to counsel? So what is the ideal donor for transplant in aplastic anemia? Anyone, Dr. Partho? You are a transplanter. So,
yeah. Am I audible?
Yes, you're audible.
The ideal donor is always a matched sibling donor.
Yes. And any options when it is not there? Shubham, you are muted. Please unmute yourself.
Okay. The best option is always matched sibling donor. If it is not available, then the next choice is matched related donor. If still not available, the choice is mod or matched unrelated donor, and it should be properly matched. Haploidentical donor is comes next to the choice, and although umbilical blood as a source of stem cell is so it is the least preferred regarding transplant anemia.
Exactly. So matched sibling donor is the best donor for aplastic anemia. If we get it, I think we can be a bit lenient about the age of the patients. If a full match 10 by 10 or 8 by 8 haplo 8 by 10 matched sibling donor is available. If it is not available, then we can opt for other donors depending on the scenario. It can be matched unrelated donor. But regarding haplo, there are a lot of issues. The issue of transplant in aplastic anemia is we don't want any GVL effect. So we want to actually reduce the GVHD, and GVHD is around 20 to 30% patient has got GVHD. And the interesting protocol which Biju sir has shown that in non-haplo transplant also in aplastic anemia, they are using PTCY, and PTCY is reducing the GVHD in matched sibling donor transplant. That is a very interesting practice. I think we are waiting for the outcome, and it can really change the transplant outcome in matched sibling donor in aplastic anemia. Preferred graft source, peripheral blood or bone marrow. Although bone marrow, different groups use bone marrow, but most centers in India, I think, use PBSC. So what is the advantage of PBSC has got in aplastic anemia in our country? Any comment on it? What you will choose, bone marrow or PBSC? Anybody?
Bone marrow is likely to cause less GVHD. And on the other hand, PBSC.
What you will choose? What you will choose in your center? You have got an aplastic anemia. You are planning for transplant. Have got a matched sibling donor. Whether you will go for bone marrow or
if the donor agrees for donating his bone marrow, then bone marrow will be the preferred.
Okay. So it is a standard practice, definitely, but there are some issues, especially in our country, because we know that PBSC causes earlier engraftment. Yeah. And if we can reduce the day of engraftment at least 3-4 days, then the chances of febrile neutropenia and other complications we can reduce. So although the standard practice is doing bone marrow, most of the centers in India prefer to do it for PBSC, and we can handle the GVHD. Only GVHD is a concern, so we can handle GVHD, I think. And with this new protocol, I think we'll be able to handle it more in a more better way. So,
Ajib, our time is up.
Okay. So can I get one minute time?
1 minute.
1 minute, yeah. So almost all the issues we have covered. Risk factors, we have, Sarah has already described that if it is in children, the outcome is better. So take home message in management of aplastic anemia is at baseline, if patient can afford, we can look for the mutation studies. It can give you a good prognostic informations. And triple therapy is better than double therapy, so please go for it. And if the patient is having a matched sibling donor, it is a better way to handle it. So thank you all the panelists, and thank you.
Thank you very much, sir, for associating us. Thank you, sir.
Thank you. Is there any specific questions to the speakers? I don't know. I don't have any question in my chat box. So
No.
is there any specific?
No, there are no questions here.
Okay. Okay, thank you for the panelists. We can conclude here.
Sir, I have a question to Biju sir, if I am allowed.
Okay, quickly.
Sir, one of your patients underwent 3 transplants, sir, aplastic anemia. Whether he was opted for IST?
No, no. So once you fail a transplant, I don't think IST will work.
Okay, sir.
So I don't think there's any point in trying to give ATG after you failed a transplant.
Okay, sir.
Just I have only one question. I will take one, not even 1 minute. my question is also to Biju sir. Sir, regarding this PTCY in matched sibling donor, it sounds very interesting to me. And so how have you selected, because it is only used for haplotransplant. So in a matched sibling donor, you are thinking of giving PTCY.
So after the data on haplotransplants, there was also a publication on using PTCY in older patients with AML who had matched sibling donor, where they showed that there is very good reduction in GVHD. So our idea of using it was that if you can get away with 2 doses of PTCY, and roughly about 50% of our patients who we gave PTCY did not require any immunosuppression after that.
So whether you are giving cyclosporine, methotrexate,
no, nothing. No. It is only 2 doses of PTCY on day 3, day 4. Okay. That means you save upon an entire 1 year's cost of cyclosporine. So that becomes very cost effective, especially in an Indian scenario.
Yes. Thank you, sir.
Thank you. Thank you. So we can close the session now.
Yes, sir. Thank you, Pradeep sir. Thank you, all the speakers, all the panelists. And now I'd like to invite my next host, Dr. Avriti, to take this session further.
Good evening, everybody.
Mute.
So, good evening, everybody. So the next session is on lymphomas, and the session is being sponsored by this session is being sponsored by CIPLA. Sorry. A very good evening to everybody. So this session on lymphoma is being sponsored by INTAS, Celestial, a division of INTAS, and our session coordinator are Dr. Sudipto Roy. He is the lab director at Armory, Kolkata. So I welcome sir for coordinating the session.
Thank you very much. Am I audible?
Yes, doctor, you're audible.
Yeah. So good evening, and I would sort of thank the organizers and especially Dr. Tufan for allowing me to chair the session on a very difficult and always an updated topic of lymphoma. So as we have a limited time, I would ask my first speaker, Dr. Devdeep De, who is a very famous person in the field of diagnostic pathology, now being a consultant at Tata Medical Hospital in Kolkata. And his passion has always been lymphoma till his days in UK. So may I ask Dr. Devdeep to start his lecture on the role of IHC for the diagnosis of high-grade lymphoma. Dr. Devdeep, up to you.
I'm playing the recorded session of Dr. Devdeep.
Today, I am going to speak on the role of immunohistochemistry in the diagnosis of high-grade NHL. For those of you who don't know me, I'm Dr. Devdeep De. I'm a consultant oncopathologist at Tata Medical Center in Kolkata. I thank the organizers for giving me an opportunity to speak on this topic. So the diagnosis of lymphoma is notoriously difficult because of the one has to assess morphologically the architecture of a lymph node, because the atypia or the mitosis that almost gives the game away in carcinomas is not is relevant, but not so relevant in lymphoma pathology. And to complicate matters, new entities are coming out every day, which is making our life difficult. In lymphomas, that is in both high grade and low grade, IHC is essential to produce a report that will be responsible, that will be acceptable to the hemato-oncologist for treatment. It is essential for, IHC is also essential for tissue-based lymphoma subtyping. Example, for some subtypes, it is a disease-defining methodology. Example, ALK-positive anaplastic large cell lymphoma. Now, we have to understand that in a resource constrained setting like ours, not every lab will have the facility or the expertise to do a detailed immunohistochemistry panel. Therefore, there should be a low threshold for referral, and both the clinician and the pathologist should try to create some centers of expertise in lymphoma pathology, which will help the general public for a definitive report. Now, one also needs to know not only the expertise, but also needs to be aware of the pitfalls of immunohistochemistry. So over the next 15 minutes or so, I will sort of run you through the different immunohistochemistry that is needed for lymphoma diagnosis, and will explain some of the pitfalls associated with it. Diagnosis of lymphoma is actually an integration of clinical, radiological, morphology, immunohistochemistry report in most of the cases, followed by flow cytometry, clonality, and cytogenetics. But in high-grade lymphomas, it is morphology and immunohistochemistry along with cytogenetics that is needed. So the immunohistochemistry here plays both a diagnostic as well as a prognostic role. So what is the sort of the walking, how do you actually work through a lymphoma case? Suppose you look at a lymph node, it looks like a morphologically high-grade lymphoma. So the basic stains that you have to do is a CD20, CD3, and CD30. And then once the CD20 comes positive, you are sure that this is a high-grade B-cell NHL, and then you go down the path of CD5, CD23, cyclin D1, TDT, BCL2, CD10, BCL6, Ki67, MUM1, P53, and CIMIC. And then you sort of subtype it according to your Burkitt, DLBCL, double hit, triple hit, pleomorphic, and mantle. Once the CD3 comes positive, then you think it's a T-cell NHL, but you have to be very sure that it is an NHL and not an atypical T-cell hyperplasia. Then you do your markers, the T-cell, the CXCL30, NICOS, PD10, CD30, Ki67, and then you go down the route of peripheral T-cell lymphoma or an angioimmunoblastic T-cell lymphoma. If CD30 comes positive, then I'm hoping you have ruled out Hodgkin morphologically, and then it's an ALCL. It could also be PTCL, but PTCL is sort of CD3 positive most of the times. But all three negative, then you have to think about plasmablastic lymphomas, myeloid sarcomas, means anything which looks like a high-grade lymphoma, but it's both CD3 and CD20 negative and CD30 negative. You have to do your CD138, PAX5, PAX5, MPO, and CD45. So this is a prototypical high-grade lymphoma, which is showing pleomorphic cells with vesicular nuclei and a very prototypical stain of CD20 positive, CD10 positive, MIB1 positive, and BCL6 positive. Now, this is the WHO classification of the high-grade lymphomas. And what I'll do, I'll pick out certain entities and show you how IHC plays a role in the diagnosis. So on morphology, a high-grade B-cell lymphoma can comprise a blastoid, Burkitt lymphoma, DLBCL or Burkitt morphology, or DLBCL morphology. So if your phenotypia, if your immunophenotype is TDT positive, you go down the route of lymphoblastic lymphoma, TDT negative, cyclin D1 negative, and then you go into the whole gamut of high-grade B-cell, DLBCL, Burkitt. But nowadays, you have to do the MYC, the BCL2, and the BCL6 fish to get to your diagnosis of the varieties of lymphoma, which I'll come to you later. Now, DLBCL may be one name, but it is actually a disease, many diseases. So it consists mainly of two heterogeneous groups of tumors, which led to the cell of origin of classification. One is the germinal center B-cell-like and activated B-cell-like. These were the gene expression profiling studies were done on microarray, which needed fresh tissue, which is not possible in routine practice. Most common is Hans algorithm, which is used as an immunohistochemical surrogate using CD10, BCL6, and MUM1, but IHC is in concordance with gene expression profiling studies only to approximately 80%. So these are the two algorithms, the new algorithm and the Hans algorithm. The new algorithm is concordant with gene expression profiling to about 93%, while the Hans algorithm is much lesser. But in routine practice, we generally use the Hans algorithm to subtype into germinal center B cell and activated B cell type. So this is the germinal center B cell like, which has to be CD10 and BCL6 positive. And this is the germinal non-GCB or the activated blast, which is the which should be MUM1 positive. Why do we need this? We need this because it has got a prognostic significance, and thereby the IHC has a role in the prognosis of the high-grade lymphomas. Patients with ABC or the activated B cell like will have a poorer outcome compared to GCB, and that's why it's important, as you can see from the Kaplan-Meier curve here. High-grade B cell lymphoma with MYC, BCL2 and BCL6 rearrangements, or NOS. So this is a case of a 29-year-old male with complaint of severe body pain, loss of appetite, and loss of weight, diagnosed in Hyderabad as a diffuse large B-cell lymphoma with a CD20 positive and a Ki67 of 30%, but high LDH, bone marrow packed with cells, and cells are large. It's CD20 positive with a Ki67 approaching 100% almost. And in addition to that, the BCL2 is negative, but BCL6 is positive. So this was a high-grade B-cell lymphoma, but we don't stop it there. So the karyotyping showed a balanced translocation between the long arm of chromosome 3, which houses the BCL6 gene, and the long arm of chromosome 8, which houses the c-MYC gene. And this is showing a balanced translocation within 3 and 8. The fish using the c-MYC break-apart probe also shows the MYC rearrangement. So here it shows both the c-MYC and the BCL6 rearrangement. So it's a double hit lymphoma. This is another case of a very high-grade lymphoma where no problems in diagnosing this high-grade lymphoma. It's CD20 positive, CD10 positive. So clearly going down the GCB pathway. Ki67 very high, but look at this too. This is the BCL, this is the MYC, which is more than 30–40%, and this is the BCL2, and this is the BCL6. So when you get MYC more than 40% and BCL2 more than 50%, we go for fish testing, and fish testing is showing this MYC rearrangement, as you can see here by the widely separate red and green signals here. I thank my colleague, Dr. Mayur, for the pictures here. So this was signed off as a double hit lymphoma, which has got BCL2 and MYC rearrangement. So this is also called a double hit lymphoma because it is the co-occurrence of MYC along with BCL2 and BCL6 translocations. Concomitant BCL2 and BCL6 translocation without a MYC breakpoint is not a double hit, and any other gene translocation such as CCND1 with the MYC translocation is also not a double hit. And high-grade double hits will have a GCB phenotype in around 90% patients. Now, what is double hit versus double expressive? Double hit is a genetic event diagnosed by fish MYC break as well associated with BCL2 and BCL6 rearrangements, whereas double expressor is confirmed by IHC. So this is another case. You don't see the Burkitt lymphoma here because technically the cells are intermediate size and not large. This is a 27-year-old man with an HIV positive. You can see the classical follicular hyperplasia with follicular lysis here. And on this part, you see this starry sky pattern and diffuse infiltrate of cells, the typical starry sky pattern here. and the cells are showing medium sized with prominent nucleoli. CD20 positive, CD3 staining the background T lymphocytes, CD10 positive, BCL6 positive, but the important thing is BCL2 is negative, along with the Ki67 approaching 100%. CMYC is also in the range of 80%. So this is a fish picture showing the CMYC rearrangement positive with no evidence of BCL2 and BCL6 rearrangement. Iberish is positive, so this is a case of Burkitt lymphoma. Then we come to T-cell histiocyte-rich large B-cell lymphoma. This is a lymphoma where the neoplastic cells are in minority, as you can see here, one cell here, one here, and one here, and it does not form in sheets. So this is a very classical CD20 pattern of staining of a T-cell histiocyte-rich large B-cell lymphoma. This is notoriously difficult to diagnose, and it gets misdiagnosed very easily, seeing the number of histiocytes that are present there. And the important markers which are there are the CD21, which shows a loss of dendritic cell meshwork, and CD8 plus T cells will predominate over the CD4 plus T cells. So the other differential diagnosis is the nodular lymphocyte predominant Hodgkin, which along with T cell rich B-cell lymphoma, and where these things will play a role. It's the BCL6 is present in nodular lymphocyte predominant and is much less in T-cell rich B. The IgD is present in about 1/3 of the cases. The predominant background population in nodular LP is B cells, where it is T cells and T cell histiocyte rich large B-cell lymphoma. CD4 T lymphocytes are much more in nodular lymphocyte predominant, while CD8 is much more in a T-cell rich histiocyte. And follicular center T lymphocytes are present in NLPHL, which is diagnosed by CD57 and PD1, forming very nice rosettes. And the follicular dendritic cell meshwork is also present. So next we go into the ALK positive large B-cell lymphoma. This is a lymphoma where the pattern of distribution is typically sinusoidal and partial involvement, notoriously difficult because of the rarity of the diagnosis and the cells mimicking like metastatic carcinoma here. And it's negative for 30, 79A, 20, PAX5, but EMA positive, so is CD138 and MUM1, and with copper light chain restriction here, EBER negative, and the ALK shows the typical cytoplasmic granular staining. So this is an ALK positive large B-cell lymphoma, which is negative for CD20, 79A, very weak CD30 with light chain restriction, but important thing is 138 and MUM1 positivity. Primary fusion lymphoma is another lymphoma, which is HIV positive, pleural fluid containing sheets of these large cells, which are positive for MUM1 and CD30 and negative for HHV and positive for HHV8. So this is a primary fusion lymphoma. Then we come to the primary mediastinal or thymic large B-cell lymphoma, which is an aggressive large B-cell lymphoma. It is predominantly occurs in young adults and female predominance, and it's mainly present as a mediastinal mass with regional involvement of supraclavicular and cervical lymph nodes. It is essential that you pick up this one because the therapy differs from a diffuse large B-cell lymphoma. Therefore, it is imperative we pathologists are able to pick this one up. So the typical feature is either a diffuse infiltrate or a clustering pattern, which shows compartmentalization and fibrosis with these clear cells, which is the giveaway. It's positive for CD20, CD23, and CD30, as well as MUM1. And therefore, it is a separate entity as a primary mediastinal thymic large B-cell lymphoma. The important thing to consider here is that in primary mediastinal large B-cell lymphoma, we have P63 positive in 100% of the cases. So that might be a diagnostic pitfall because P63 is normally used in cases in a squamous cell carcinoma. So if you have not picked up morphologically that would be lymphoma, then you're in for trouble because your P63 can give us an erroneous diagnosis of a squamous cell carcinoma. And not only it is diagnostically useful because it is present in 96% of primary mediastinal large B, but it is very rare in classical Hodgkin, which can also present with a mediastinal mass and with a similar age group. And it is also involved in DLBCL tumor progression, and it is an unfavorable prognostic marker in DLBCL. So the next case is of a 12-year-old boy with a duodenal polyp, again a very high-grade lymphoma with a starry sky pattern. Cells have very prominent nucleoli with a plasmacytoid nuclei, and it's negative for your 320CK. MUM1 is positive, PAX5 is negative, CD10 is positive, which gives you the first indication that we are dealing with a hematopoietic lymphoid marker, even in the absence of CD20 and CD3. CD138 is positive, so is kappa, and kappa shows large chain restriction. And Ki67 is 100%. So this is a case of a plasmablastic lymphoma, again an lymphoma which is very easily misdiagnosed as a DLBCL. So now we come to the T-cell lymphomas, again a very long list, and it's 15 minutes. It's difficult to cover everything. But this is a case of a 44-year-old male cervical lymph node. You can see the lymph node being effaced by nodules. On high power, you see some proliferation of endothelial venules with a lot of abundant clear cytoplasm. It's positive for CD2, positive for CD3, PD1 is strongly positive, and Ki67 is more than 90%. But it is negative, or CD7 expression is lost and CD8 expression is lost, and CD23 shows loss of sort of expanded dendritic cell meshwork with almost like a moth-eaten appearance. The other, so this is an angioimmunoblastic T-cell lymphoma, which is again a type of T-cell lymphoma which might cause some problems. It can be diagnosed either way as a reactive lymphadenopathy or as a diffuse large B-cell lymphoma, because sometimes the blasts, EBV positive blasts, can express CD20, or at the type 1, the pattern 1 of AITL, which is this case, is you can see a germinal center surrounded by these clear cells. These are the clear cells here, and as you can see, the CD20 staining the germinal center with scattered blasts being positive for CD20, and this is the CD10 staining lightly the germinal center along with the clear cell staining of the CD10. This is the PD1, which is the staining that, and this is the CD3. So this is that pattern 1 of AITL, which is notoriously misdiagnosed as a reactive lymphadenopathy. So here also IHC can play an important role. The other markers that might help is CXCL13, PD1, and ICOS, and CD10 can also help in this AITL immunophenotype. Another important here is an ALK-positive large B-cell lymphoma, a very typical horseshoe-shaped nucleus here with CD3 positivity, CD4, CD3 faint positivity, CD4 strong positivity, CD5 strong positivity, along with CD30 positivity, EMA positivity, porphyrin negativity, and DUS22 rearrangement. This is quite a complex chart of the different differential diagnosis of ALCL. So the markers that you need to do is CD30, ALK, EMA, CD15, CD45 B cell, T cell antigen, cytotoxic granules such as granzyme and porphyrin, and EVV. So what are the limitations? So due to fixation, IHC may not work properly, which causes real problems in assessing the Ki67. The cell size creates shrunken due to this year causing difficulties. Limitations are diagnosis of double hit, triple hit lymphoma. It is not possible without the help of cytogenetics and karyotyping. And my colleague, Dr. Mayu, really does a good job there in helping us with all the cytogenetic cases, ambiguous lineage clonality. My colleague, Dr. Mishra, helps us with the clonality studies here, and infectious mononucleosis. It's where the clinical and the serological indicators do help. Aberrant expression is B cell NHL expressing T cell markers, PTCL expressing CD20, plasmablastic expressing CD3, and ALCL expressing PAX5. All these things can cause real problems in diagnosis. So I'll just quickly run over the 66-year-old female having that abdominal nodal mass, very obviously high-grade lymphoma, but both CD20 and CD3 coming positive with the high Ki67. There now you start doing more B and more T cell markers. This is CD79 APAX5, both T cell markers positive, but also CD7 is positive. BCL2 positive, CMYC is positive, but CD2, CD4, CD8 are all negative. So is CD5. So we have got 3 B cell markers positive, 2 T cell markers positive, and all other markers are negative. So Iberish is negative. So we have a case where there is 3 B cell markers positive and 2 T cell markers positive. So this is a high-grade non-Hodgkin lymphoma, but what to do? So we go to the clonality route where this is where IHC falls apart. And as you can see here, the T cell gene rearrangement, it's polyclonal. And the IGH PCR gene rearrangement shows a clonal arrangement. So this is a B cell NHL with aberrant expression of CD3 and CD7. So this is another case of a plasmablastic lymphoma, as you can guess from the CD138 and MUM1, but look at this CD3, it's strongly positive. So you do your CD20 and CD3 and do not pick up on morphologically that this is a plasmablastic lymphoma. You might have missed the boat and you can erroneously diagnose it as a T cell lymphoma. So CD4 is negative, 20 is negative, and it shows kappa light chain restriction. So this is a plasmablastic lymphoma with aberrant CD3 expression, and this is a paper sort of confirming that that it is a diagnostic pitfall. So the take-home message is IHC is essential for high-grade lymphomas. However, one needs to be aware as aberrant expression of antigens in NHL is a well-documented phenomena and can cause erroneous diagnosis. Extensive panel is needed to avoid missing these cases. Testing for clonality helps in making a diagnosis. And prognostically also, it is useful in the diagnosis of double expressor lymphomas and to decide when to do FISH. So I'll just conclude by saying the more you know that you don't know.
Thank you, Devdeep. That was extensive and the entire gamut of IHC. Yes, for my clinical colleagues, you have to understand that IHC we do on a stepwise fashion, and so therefore it might be taking a little more time for the final diagnosis to come in because you see there are a lot of pitfalls. So with that, we now go to the treatment of follicular lymphoma, which would be presented by Dr. Avinash Singh, and he is a pretty famous hematologist in the eastern part. He hails from Patna and he's a consultant at the Paras Hospital. Over to you, Dr. Avinash, for the treatment of follicular lymphoma.
I'll be sharing the recording of Dr. Avinash.
Okay.
I would like to first thank organizers for giving me opportunity to speak today. And my topic is treatment of follicular lymphoma. So I would just start with some basics of follicular lymphoma. We know that follicular lymphoma is the most common indolent lymphoma and second most common lymphoma overall. So about 35% of all NHL and 70% of all indolent lymphoma are follicular lymphoma. Median age is 65 years and its incidence is slightly increased among relatives. The its malignant counterpart of normal germinal center B cell, and about 85% of patients have classical translocation 14-18, which result in overexpression of BCL2, and there are some chromatin modifying gene mutations which are common feature of follicular lymphoma like KMT2D, CRE-BBP, and EZH2, which has got prognostic significance, as well as some novel therapies are being targeted these gene mutations. The altered normal T cell function within the malignant microenvironment also plays a very important role in pathobiology of the disease, and also there are some novel therapy which are being targeting this normal T cell function in the microenvironment. So patients with follicular lymphoma, they generally present with asymptomatic lymphadenopathy which may wax and wane for years. Bone marrow involvement is seen in about 70%.
Is anybody able to hear Dr. Avinash on
They
board?
can present with B symptoms, and about 20% of patients can have high LDH. This is as per NCCN 2020. For diagnosis, these things are required, and as per WHO 2016, they divide follicular lymphoma into 4 types: typical follicular lymphoma, and the other 3 variants are rare, so we don't see them so frequently, and at present we don't have much knowledge about them. Gradually we will understand more about them and their treatment and prognosis. How to diagnose follicular lymphoma? So lymph node or mass biopsy is must. It should be as per WHO diagnostic criteria, and the follicular lymphoma cells, they express monoclonal immunoglobulin light chain as well as other germinal center markers. Then we have to do grading, and it should be as per presence of centrocytes and centroblasts, and they are graded into either 1, 2, 3, and also again 3 has 3A and 3B. 3B grade of follicular lymphoma, it behaves as aggressive lymphoma, as diffuse large B-cell lymphoma. Staging is done as per Ann Arbor staging, and these follicular lymphoma patients also has risk of transformation to large B-cell lymphoma in about 10% to 70% of patients over time, with a risk of 2% per year. How to prognosticate newly diagnosed follicular lymphoma? So it is done by FLIP-P criteria, which includes age, LDH, hemoglobin, staging, and number of nodal sites. Recently, FLIP-P2 has come, but commonly for practical purposes and also in most of the study, FLIP-P criteria is being used for prognostication. You can see FLIP-P divides patients into low risk, intermediate, and high risk, and the overall survival and GFS is different among them widely. Recently, M7 FLIP-P is another prognostic model which has been found by studying about 74 genes which are there in follicular lymphoma patients. So 7 gene has been found to have prognostic significance along with FLIP-P other parameters. Then deletion of TP53 and CRBBP are associated with shortened survival, and another prognostic model is PRIMA-PI, which includes beta-2 microglobulin and bone marrow involvement, and they divide patients into 3 groups, again low risk, intermediate, and high risk. Other than these prognostic models, so recently we have found that the duration of response is also very important. So if a patient relapses within 2 years of primary chemoimmunotherapy, they are having a bad prognosis compared with patients who relapse after 2 years, or who are surviving for more than 2 years in follicular lymphoma. So this has been studied from National Lymphoma Care Study. Out of about 588 patients, 20% they relapse within 2 years, and the rest they act as a reference group. And you can see that the progression-free survival were worse in early POD compared with reference, and also the overall survival is significantly different in both groups. Coming to management, so we have to grade the follicular lymphoma, as I have said, and 1 to 3A grades. They have common histologic and molecular features. They behave as indolent lymphoma, and grade 3B is similar to DLBCL as aggressive lymphoma. Then first we have to divide patients into early and advanced stage. Early are stage 1 and 2, which are mainly 20% of patients. Stage 3 and 4 are advanced stage patients. So for limited stage 1 and 2, there is currently no accepted validated standard therapy, and this is the early stage patients where FDG PET becomes important, because there is a study which show that if we stage FDG PET based staging for early stage, they have better result with radiation or with other therapy. And since follicular lymphoma, they are very radiosensitive. So for early stage patients, recommendation is to give 24 gray of radiation, and that gives the best result in early stage patients. This is as per NCCN. You can see stage 1 or contiguous stage 2. ISRT is the preferred regimen. Other options are anti-CD20 monoclonal antibody, and in non-contiguous stage 2, again anti-CD20 monoclonal antibody with or without chemotherapy is the preferred regimen. In advanced stage, that is stage 3 and 4 patients, we have to see the tumor burden as per Guelph criteria, and if any criteria is present, patient is in high tumor burden, and if all are absent, they are in low tumor burden group. This is the Guelph criteria, and for low tumor burden in advanced stage patients, recommendation is to watch and wait. And for high tumor burden, we have different treatment options. So as per NCCN 20, we can see these are the preferred regimens like bendamustine with obinutuzumab or BR, rituximab or obinutuzumab with different combinations. Len-R are the preferred options in first line therapy. There is still INHL study which has compared BR with RCHOP in indolent lymphoma, and they have found that it is non-inferior compared with RCHOP. So BR is the preferred regimen for first line follicular lymphoma symptomatic patients. For consolidation or extended dosing, optional is maintenance because it doesn't change the overall survival. We can give maintenance rituximab 375 mg per meter square every 2 to 3 months, total 12 doses. Then we have started from radiation, chemotherapy, chemoimmunotherapy, whether any chemo-free regimen is there or not. So relevance study is there where lenalidomide rituximab has been compared with rituximab chemotherapy, and they have found that rituximab-len combination is non-inferior compared to ART chemotherapy, and you can see that progression-free survival and overall survival is almost similar in both the groups. And this is the study based on which this Len-R combination has been approved by FDA for newly diagnosed as well as relapsed follicular lymphoma. So at relapse, what we should do if patient is asymptomatic, no treatment is required. What are the factors we should consider? So always at relapse, we should do rebiopsy to rule out transformation. And if there is clinical trial, then always we should encourage to enroll them into clinical trials. The factor we should consider at relapse are what is the goal of therapy, whether it is palliative or curative. Then performance status of patients, previous therapy, what he has received. Then response, how deep was the response to the primary therapy or last therapy. Duration of response, that is POD 24, is very important. These are the different options for relapsed follicular lymphoma. So again, it depends upon what therapy patient has received in the past, and depending upon that, we should decide. So in the relapse setting, we have other novel agents like PI3K inhibitors, EZH2 inhibitors. For difficult to treat patients like histologic transformation to DLBCL who has relapsed after more than 2 prior lines of therapy, and the effect of ASCT is independent of the tumor grade, and also it is not affected by introduction of rituximab in chemoimmunotherapy administered before transplant. The allogenic stem cell transplant has limitations in follicular lymphoma because of lack of donors as well as high TRM that we see in follicular lymphoma. This is recent study published in December this month in BMT 2020 on risk factors and outcome of follicular lymphoma after allogenic HSCT using HLM as sibling, unrelated and haplodonors, and they have come up with 4 risk factors for poor progression-free survival. And these risk factors are age more than 50, high SCTCI, more than 3 lines of therapy, and non-CRS status before a stem cell transplant. This is a treatment algorithm to show that in first line, stage 1 and 2, radiation is the regimen. The treatment that is preferred, then watch and wait. Stage 3 and 4, low tumor burden, watch and wait is recommended. Then for high tumor burden, we have different options. And then we can give rituximab or obinutuzumab maintenance. For second line, we should consider rebiopsy. If it is low tumor burden, no transformation, watch and wait. High tumor burden, again we should see POD 24, early relapse or late relapse. Early relapse, change to another rituximab to obinutuzumab. Len-R, single agent rituximab are options. Late relapse, we can use the same regimen which has been used previously. In the third line or third line, we can have novel agents like PI3K inhibitors, Len-R, CAR T-cell, and single agent rituximab or palliative RT as options. This is just model to show how different drugs they act in follicular lymphoma, like checkpoint inhibitors, CD20 antibodies, CAR T-cell engagers, then immunomodulators, BTK, PI3K inhibitors, BCL2 antagonists, and HDAC inhibitors. Then few words about some novel agents which are being tried currently in relapsed refractory follicular lymphoma. So mantle cell lymphoma, and which has changed the treatment of CLL totally, is not so effective in follicular lymphoma with only 21% response rate. The data on CAR T-cell therapy in follicular lymphoma first time is being presented as 2020, and it has shown very good result in difficult to treat follicular lymphoma patients who are relapse refractory, with about 90% of overall response rate. Then this is EZS2 inhibitor in combination with rituximab for treatment of the relapsed refractory follicular lymphoma has been planned, and the first author is Chris Patel, which we had opportunity to interact with him in one CL specific meeting recently. Then this is bispecific CD20 to CD3 monoclonal antibody mosunetuzumab, which has shown very good high and durable response in subgroups of patients with follicular lymphoma, and this abstract is being presented as 2020. And the beauty of this drug is that all patients which were included, around 70-75 patients, were very bad, failed CAR T-cell therapy, failed PI3K inhibitor, and this drug has shown about 60-70% of response rate in that difficult to treat patient group with tolerable side effects. So to conclude, follicular lymphoma is the most common indolent lymphoma which we encounter in our practice. Grade, stage, tumor burden, and symptoms are important to consider before deciding treatment. And treatment options are gradually shifting from chemotherapy, chemoimmunotherapy to chemo-free regimen. And novel agents, different kinase inhibitors, bispecific antibody, and CAR T-cell therapy are hope for relapsed refractory, difficult to treat follicular lymphoma patients. Thank you all.
Thank you, Dr. Avinash. That was pretty extensive of a very heterogeneous group of diseases, which is clubbed under follicular lymphoma. And now we have Dr. Devmallo Bhattacharya, a young hematologist, has in his true right established himself in the field of hemato-oncology. He's going to talk us about the treatment of another heterogeneous group, DLBCL, the commonest type. What is new? So Dr. Devmallo, if you're here, please start your proceedings.
Doctor, I'll be playing the recording of Dr. Malia.
Yes. Good evening, everyone. So thank you, EHG, and especially Professor Tufan Kanti Dalui sir for organizing this nice conference on the virtual platform. It's really a pleasure to meet with so many of educated, so many of updated PPTs with all. So it's a nice nice thing to happen. So without further delay, I'm going to my topic. So the topic allotted to me is a treatment of DLBCL. What is new? So everyone knows that what is DLBCL, what is the primary treatment that is arch of everywhere mostly. But what are the recent updates I'm going to discuss. But I am taking you. I am telling sorry that I have not mentioned many things like many references because it will be a virtual platform and the time is only 15 minutes. So I have omitted quite a few references and some details. So let's start. So what is DLBCL? DLBCL is the most common subtype of NHL. You know, 30% of all newly diagnosed cases and more than 80% of aggressive lymphomas are usually DLBCL, and we know that it is curable, but there is every chance of relapse anytime, anywhere, and it's a heterogeneous group of disorders. Many patients behave in a very various ways, so presentation may be very different from patient to patient. And also the immunological characters are different, genetic features are different. Though in India we are not as accustomed with some genomic profiles and other intricate molecular studies, but nowadays it is in the fashion and also in the need definitely that we do gene expression profiling and other molecular studies to hit at the target only, so that there is less side effect and more benefit. So these are the main things for deciding treatment in next 5 years. I think that the therapy will shift it from gross chemotherapy to immunotherapy or targeted therapy or cellular therapy like this. So what before that I am sharing that what is the current NCCN guidelines with this DLBCL recently. So what is the guidelines is, because before you start for the any further newer therapy or any new medicine or new protocol, before that we should know that what is the current guideline, what is the gross therapy, or for most of the patient, 80% patient will not require these special therapies or newly updated therapies at the beginning. So what is the guideline? I'm just telling according to the NCCN version 4.2020. The first line therapy is obviously R-CHOP followed by ISRT or R-CHOP 6 cycles plus minus ISRT, that is clinician's choice and the availability of the resource in the treating center. So within the non-bulky stage 1, stage 2 disease, it is very easy, and so there are some protocols also which we don't use usually, that is R-CHOP 4 cycles followed by rituximab monotherapy for next 2 cycles, but there will be less toxicity definitely. And the bulky disease is almost treatment like same stage 3, stage 4, that is R-CHOP 6 cycles. If there is any mass, or you can decide in ISRT or radiotherapy in the localized site. And for stage 4 stage 2 disease, you can go for clinical trial directly. Though in India we definitely don't go for that, but we go for R-CHOP therapy, that is initial 2 to 4 cycles. Then we do PET scan assessment. If there is a good response, we go for another 2 to 4 cycles. So this is the main guideline. So next, for the follow-up therapy, there are many variations or many options for the follow-up therapy. Initially, we complete planned course of treatment. If there is no residual disease in the PET scan, that is PET negative disease. If there is partial response, that is partial PET positive, this is residual disease is persistent, then we can do for chemotherapy plus higher radiotherapy dose to the localized site. And PET positive study, if there is more involvement, then we can go for higher radiotherapy dose like the previous one, or after that we can go for directly autologous stem cell rescue plus minus ISRT, or we can go for clinical trial. So there is a clinical trial in every complicated or every not so well responding patients, but we can go for autologous stem cell therapy if there is mild partial disease or partial response. And if there is no response of progressive disease, then the patient to be treated as relapsed refractory DLBCL, we can directly go to the clinical trial or the newer therapies. Now regarding follow-up of the patient, these patients, because we know that anytime this can relapse or this can become refractory, you can do biopsy definitely, that whether to confirm that whether it is biopsy is the same diagnosis as the previous one, or you can review the slides of the initial biopsies also. And after completion of therapy, if there is any progressive disease, we can treat the patient as relapse refractory treatment. The relapse refractory DLBCL. Now for the relapse refractory disease, we should go for proceed for transplant. If there is transplant, this patient is eligible. I will be coming in detail later. And if there is second line of therapy, you can go for autologous transplant, transplant. Some clinical trials are there. If there is partial response, you can go for CAR T-cell therapy. You can go for allogeneic hematopoietic stem cell transplant. And if there is no response or progressive disease, the patient should be put on palliation therapy or through other clinical trials. And the patients who are not for candidate for therapy, obvious answer is obvious, go for palliative radiotherapy or clinical trial. Now follow up after the treatment of relapse and refractory disease, that is do every 3 to 6 months follow up and scan, but not more than every 6 months. And always if there is response or relapse or progression of disease, newer therapies to be advocated or base supportive care if there is no options left. So this is as a whole what are our current treatment guidelines, that is on the book. These are the main guidelines for treatment of DLBCL. Now, most of the patients, obviously, we know that it's not cured with initial conventional therapy. When there is suspicion of therapy, a biopsy should be obtained because there may be change of histologic pattern or change of acquisition of the new mutation. So these are the points I have already told, that whenever any doubt, you should review the initial slide as well as do a fresh biopsy and whatever you want to do, like histological investigations, IHC or other molecular studies or for mutations. And first of all, you have to decide whether the patient, when there is a relapse, you should know whether the patient is eligible for transplant by financial, by logistics, or by the physical condition of the patient. So first option is always autologous transplant, because autologous transplant is less toxic. Now, first I'm going for what are the options for the transplant ineligible patients, because in India most of the patients are transplant ineligible, unfortunately, because there are the financial issues. Patients are already drenched out of money, because mostly these patients are relapsed patients or refractory patients, and many patients are having diabetes, hypertension, cardiac disease, comorbidities. Also, there may be issues with the healthcare giver, like that. So mostly our Indian patients are transplant ineligible. So for them the treatment is generally palliative, those who have not many options. And selection of therapy is informed by medical fitness, comorbid conditions, toxicities, patient's preference, that is also you have to keep in mind, and pathological features of the disease. Better they should take part in a clinical trial, and other of the options available at the CAR T-cell therapy where it is available, lower intensity salvage therapy, or sequential single agent chemotherapy or immunotherapy. But those patients who cannot afford for transplant, they also cannot afford the CAR T-cell therapy or any special immunotherapy. So options left for the Indian patients are usually lower intensity salvage chemotherapy or sequential single agent chemotherapy or radiotherapy if the disease is a localized disease. And last but not the least, we can go for some palliative therapy or base supportive care therapy. Now, what are the drugs available for lower dose intensity chemotherapy or sequential chemotherapy? Usually lenalidomide with or without rituximab. From my personal experience, many patients with DLBCL, they do very well with lenalidomide 10 to 15 mg. They cannot tolerate the dose of 25 mg as the Western patients do. But still, lenalidomide is a good and cheaper option for the Indian patients, those who are relapsed refractory and didn't have much treatment options like autologous transplant or CAR T-cell therapy. Next, these are the new drugs like bendamustine with rituximab, bendamustine plus rituximab, brentuximab vedotin for those patients who are having CD30 positivity on the immunohistochemistry. And obviously, there is the drug everywhere, that is ibrutinib. proton kinase inhibitor with or without lenalidomide and rituximab. And there is another protocol, that is RGB protocol, rituximab, gemcitabine, and vinorelbine. But usually we are not so familiar with RGB protocol. Particularly, I have not used this many instances, but mostly we are very fond with very familiar with lenalidomide protocol. This works quite well in a few patients. And also, brentuximab vedotin is also less toxic and it can be used if the patient is affording. And obviously, ibrutinib with or without lenalidomide and rituximab is a good protocol for this category of patients. Those are transplant ineligible. Now, coming to transplant eligible patients. So there is a general consensus that salvage therapy followed by autologous HCT is the preferred treatment for medically eligible patients with the first relapse of DLBCL or primary refractory DLBCL. So the first scope, you should go for autologous transplant preceded by a salvage chemotherapy for to bring into remission. Now there are two subtypes of DLBCL, that is GCB and ABC type. So obviously GCB patients do well or do better. 2 or 3 cycles of the RGTV based on its efficacy, outpatient administration, acceptable toxicity profile, and familiarity with this regimen. Other acceptable regimens include RICE and RTAP. So these are the salvage therapy for transplant patient. And from the uptodate.com, I have found this this stanza that for the ABC type of BCL or double lymphoma who are primarily refractory or relapsed after the first cycle of chemotherapy, first protocol of chemotherapy, that is to take part in a clinical trial, because patients with these features are generally have poor outcomes. And with conventional salvage therapy. Outside a trial, we can treat with RGTP or other comparable regimen, but not for the target with a complete remission, but a partial response. So the next, for the patients who have a chemo-sensitive disease, autologous HCT is preferred rather than allogenic HCT or observation. This recommendation is based on the superior overall survival with acceptable toxicity for autologous transplant when compared with chemotherapy alone or comparable relapse with cyclophosphamide, but less treatment-related mortality when compared to transplant. So if there is a comparison between autologous and allogenic transplant, so autologous will be ahead because of its less toxicity and other advantages like costing and comparable relapse to survival when compared with allogenic HCT. Now, for patients who are having chemo-resistant disease, that is inadequate response or primarily refractory to the salvage chemoimmunotherapy, or even relapse after the autologous transplant, allogenic stem cell transplant and CAR T cell therapy are the appropriate options. So we can wait for another relapse if we want to go for allogenic HCT to see what the more refractoriness of the tumor on with the chemotherapy. So first choice, you should go for autologous. If it fails or there is there is relapse, then you should go for allogenic transplant or CAR T cell therapy. And obviously there are pros and cons of cell therapy like CAR T cell therapy. Sorry. Yeah. So for patients, sorry for the delay. So for the patients who are having chemo-resistant disease, you can go for allogenic HCT or chimeric CAR T cell therapy. And this CAR T cell therapy has limited access and associated fatal neurological events or cytokine release syndromes, all of us know. And allogenic HCT can achieve durable response, but is associated with substantial treatment-related mortality and GVHD. Now coming for another scenario, that is second or later relapse. This patient is a target for clinical trial, allo-HCT or CAR T cell therapy. So there are many newer drugs available like polatuzumab vedotin, which is an anti-CD19 and 79G antibody, and another is brentuximab vedotin, that is with or without rituximab you can use for those for the only 30 positive patients. Now tafasitamab is an humanized anti-CD19 monoclonal antibody with activity in patients with relapsed refractory B-cell malignancy, and selinexor is a quite popular drug right now for these trials. It's an orally available, it is orally active, orally available selective inhibitor of the nuclear export, that is SINE, that has activity in multiple relapse DLBCL. Now, immunotherapy of the in DLBCL, this is a newer horizon in the treatment scenario. That is a revolutionary development of immunotherapy in the B-cell lymphomas in the last few years. This is cellular therapy with CAR T-cell therapy plays an increasingly important and evolving role. Definitely, we know in every aspect there is scope for CAR T-cell therapy. Now, there is anti-CD19 directed CAR T-cells have been already developed. There are 2 products usually approved by FDA for relapsed refractory DLBCL. But these patients must have received 2 prior lines of systemic therapy. So these are the 2 drugs, that is axisabine ciloleucel or Axicel short form, and CTL019, that is tisagenlecleucel. So these are the new 2 CAR T-cell therapy drugs which are approved, but definitely they have side effects like fatal neurological events or cytokine release syndromes. Now, coming to the additional novel therapies which are in the trials, but these are the also very important treatment options in the coming few years. So these are the phase 3 trial, that is the Axicel and T-cell and this tisagenlecleucel. Most of them are with in the phase 3 trial. So if they are doing well, then we can have more options. There are other phase 1 trials like this AutoT3 or CD19 CD20 immunoconjugate. So these are the other trials which are in the loop. Next is trials with polatuzumab. This is a phase 1b/2 trial are going on. So these are the study that obinutuzumab with polatuzumab and lenalidomide in relapsed refractory follicular lymphoma or relapsed refractory DLBCL combination. And they are combined with polatuzumab and lenalidomide in relapsed refractory DLBCL. So they actually combine with treatment with follicular lymphoma and DLBCL. Another trial, they have also with rituximab, atezolizumab, and polatuzumab in the patients of, that is atezolizumab with polatuzumab and rituximab in relapsed refractory DLBCL. And another is that rituximab with polatuzumab in a combination with rituximab or obinutuzumab bendamustine in the patients with relapsed refractory DLBCL and follicular lymphoma. So these are the trials with polatuzumab. They are on the 1b or 2 phase. And blinatumomab is a bite cell therapy. There's lenalidomide and blinatumomab in relapsed refractory Hodgkin's lymphoma, non-Hodgkin's lymphoma. And another study, blinatumomab in combination with pembrolizumab and lenalidomide and blinatumomab in treating patients with relapsed NHL. So these are the phase 1 or 1b trial. They have used blinatumomab in combination with other agents like lenalidomide or rituximab. Next is a trial we're combining with nivolumab. So nivolumab, they are combined copancelicid and nivolumab in patients with DLBCL, or nivolumab and lenalidomide. Another is nivolumab with barilimumab, treating patients with aggressive B-cell lymphoma. So these are in the phase 2 trials. Another option is pembrolizumab. Pembrolizumab, they have in combination with blinatumomab, they have used 1 trial. Another phase 1 trial going on with vorinostat and pembrolizumab, and there is another phase 1/2 trial, that is mogamulizumab and pembrolizumab in treating patients with relapsed lymphoma. So all these are monoclonal antibodies which have been used with in combination. And last but not the least is venetoclax, the magic molecule BCL2 inhibitor, which can be used in many other malignancies, hematological malignancies. So they have mixed and matched with obinutuzumab, venetoclax, and lenalidomide in patients with non-Hodgkin's lymphoma refractory. Another study of ABT199, that is venetoclax with ibrutinib and rituximab. Another is venetoclax, ibrutinib, prednisolone, obinutuzumab, and revlimid. This is VIPO trial in adult cell lymphoma. So these are mix and match with venetoclax, and these are all in the phase 1 trial. Now, some other updates in the published in last conferences. Kind of the conclusions and the heading. So first one is published in ASH 2019 abstract, that is Mosunetuzumab induces complete remissions in poor prognosis NHL patients, including those who are resistant to relapsing or refractory after CAR T-cell therapy, and is active in treatment through multiple lines. So from this trial, the investigators' conclusions are where in patients with NHL, the relapsed refractory NHL, mosunetuzumab and monotherapy associated with complete remissions, even among patients with aggressive disease, like the patients who have been treated with CAR T-cell therapy with prior autologous transplant or CD20 refractory disease, and the patients with indolent NHL with CD20 and alkylating agent refractory disease, even PY3K inhibitor refractory disease or history of disease progression within 24 months. Now, CRs are durable following cessation of treatment. Retreatment can achieve beneficial responses, additional monotherapy and
Hello.
combination. So,
I would request the organizers to come to the conclusion
another
slide. We're
abstract,
already half an hour
that is
delayed.
pivotal safety and
Can you
efficacy
come to the
results
last slide,
from
please? Whoever is
moving
moving the slide.
001 trial in multi-center phase 1 study of misocabatagene megalucil in adult cell lymphoma, that is a CAR T-cell therapy. Safety profile, very few side effects according to them, and no neurotoxicity. RPD to range of 150, 450 to 6 dose with pembrolizumab on the day 1 was selected. Complete responses achieved without severe cytokine syndrome or neurotoxicity. Complete responses are durable. 10 out of 11 are ongoing, and outpatient expansion cohorts will enroll shortly. So this is another new horizon, that is combined CAR T-cell therapy, anti-CD19 and anti-CD22. So this much. So thank you for your patience hearing. Thank you.
Thank you very much, Dr. Devmallo. Then we are already half an hour behind schedule. Now we have a panel discussion, and this is a topic is the case-based management of T-cell NHL, a difficult area. And I hand over to the moderator, a very famous person, an eminent hematologist, Dr. Ganesh Jayaswar from Hyderabad Yashoda Hospital. The panelists are Dr. Ujjal Mani from Calcutta, Narayana Hospital, Dr. Kumar Saurav from HCG Hospital, Ranchi, Dr. Shubhrokanti Kundu from Jharkhand, he is a radiation oncologist, Dr. Ranjan Kapoor from Command Hospital, Kolkata. Dr. Ganesh, it's over to you to conduct the panel discussion.
Thank you for the kind introduction. And at the outset, I would like to thank the organizers for giving me this opportunity to share the dais amidst the august and esteemed speakers, stalwarts in the field. So I hope my slides are visible and I'm audible.
Yes, doctor. Your slides are visible.
Yeah. So I would like to thank all the eminent panelists, Dr. Kumar Saurav, Dr. Rajan Kapoor, Dr. Shubhrakanti Kundu, and Dr. Ujjal Mani sir. So we have a great series of deliberations on lymphoma, and one of the eminent speaker has already elaborated about the T-cell lymphoma, the intricacies in diagnosis, and the histopathology, histomorphology of lymphoma. So on a lighter note, before I start, it's such a controversial clinical arena. So there may be many controversial discussions. So I'm only responsible for what I mean and not for what the audience understands across the cases. So just to quickly start with the cases, we have, I think we are running short of time. I'll quickly jump on to our first case. This is a 50-year gentleman with progressive swellings over neck, armpit, groin. Also has constitutional symptoms in the form of fever, night sweats, and significant weight loss over last 2 to 3 months. And on workup, his LDH is high. He has generalized lymphadenopathy, as you can see here. You can make out from the PET CT scan. And the cervical lymph node, the largest and the most FDG avid node, was targeted, and it turned out to be lymphoid, diffuse lymphoid infiltration, effacing the complete lymph node architecture. and on ISC, this lymphoid population is CD3, CD4 positive, and the proliferation fraction is 80%. There are interspersed CD7 positive cells, and sorry. So I'm sure the diagnosis has been elaborated. So after thorough evaluation, clinical as well as the histopathological features, this case was labeled as PTCL, not otherwise specified. And looking at the overall picture, this happens to be stage 3B with constitutional symptoms. So I will start with Dr. Kumar Saurav. PTCL, looking at the Western data, they say it constitutes about 10% of all overall NHL group. So how common is PTCL in your practice? Do we have Dr. Kumar Saurav on board?
No, doctor, he has not joined. He has not joined.
So anybody can take up this question, Dr. Ujjal Mani sir, Dr. Rajan, and
yeah, Ganesh, if I may take this, great seeing you. So PTCL, T-cell lymphoma, generally we don't see it that commonly. If the Western literature, as you pointed out, it is 10%. So in my practice, it would be less than that. So there are two issues in it. One is arriving at a diagnosis. Diagnosing T-cell lymphoma is always a challenge compared to the B-cell ones. And second is how many make it to us. So it is definitely, I would put the figure at 6 to 7% of all lymphomas.
So actually there is, as you correctly pointed out, the data from our country, there are just probably biased presentations and the literature. So there is a large series from CMC Vellore, the T-NHL comprised about 20 to 25%. Sir? So T-cell NHL from Vellore group comprised about 20 to 25% of total lymphoma spectrum. And then Apollo Chennai has...
Somebody listening?
Hello.
Am I audible?
Yes, doctor, you are
Yes,
audible.
yes.
Yes, Dr. Deepak, you are there.
Hello.
Oh.
Yes.
Okay, so also from Apollo Chennai and some reports from TMH Mumbai. So about 20% they say that the incidence of TNHL probably is more commoner in the Southeast Asian countries, and the reports, the literature evidence from India also supports about 20% of total NHL spectrum. So what major subtypes of PTCL are seen in your practice, like the International T-cell lymphoma project? The common three variants were PTCL, NOS, angioimmunoblastic T-cell lymphoma, and ALCL, both ALK positive and ALK negative. What is your take on Dr. Rajan, Dr. Ujjal Mani sir, and Dr. Kudu sir?
Yes.
So again, yeah, the same thing. We also that not otherwise PTCL and NOS forms the largest chunk, followed by ALCL. So ALCL is the one which we see more commonly next to the peripheral T cell lymphoma, and then the other ones, the hepatosplenic T cell, and very rarely we have come across subcutaneous panniculitis like. So PTCL, NOS, and ALCL are the major chunk which we come across in clinical practice.
Yeah, that's the practice. I think Dr. Ujjal and Dr.
Yes. Am I audible?
Yes.
Okay. Actually, in my practice, we find very less amount of T-cell leukemia, lymphoma, out of which anaplastic large cell, both ALK positive and ALK negative is common, and peripheral T-cell lymphoma, NOS, is most common out of all T cells.
Yes, sir. So overall, I think we see more of ALCL because that too ALK positive ALCL probably because the younger patient population do come to us more promptly, and the other subtypes being the median age being above 60 years, probably we might be missing out, or there is no robust data to suggest the exact prevalence incidence across our society, but we just go by the literature we have. So this is the international PTCL study. You can see the in Asia, the NKT cell type, particularly in the far Southeast Asian countries like Japan and the neighboring countries, the NKT cell lymphoma and ATLL are common. I'm sure all of you will agree ATLL we see occasionally, but what we see mostly is PTCL, NOS, ALCL, and also angioimmunoblastic T cell lymphoma. So so Dr. Ujjwal sir, what are the challenges in PTCL diagnosis and subtyping? Like even across the international literature, if you see the Central Review Committee across the trials, the consensus was to the max 75%. So that too in the Central Review Committees across the international expert, the centers where the hematopathologists are tuned to handle or diagnose such cases routinely. So what is your experience? Like many a times do we miss the PTCL diagnosis, and do as one of the facts, probably we see more PTCL NOS, probably we might be missing AITL because of the lack of the feedback from the pathologist.
Actually, this is a major challenge for the diagnosis of PTCL.
Yes.
Dr. Mishra can tell us much more about it. This is just because the heterogeneity of the disease itself.
Rarity and heterogeneity is the biggest challenge across the
challenge.
Yes.
So immunohistochemistry has a major role to diagnose the different types of PTCL. Recent advances in molecular and genomic profile have also provided insight to the pathogenesis of the disease and the molecular biomarkers in PTCL of different subtypes. That has the potential to transform the personalized care of the patients with PTCL, both in diagnosis and in the treatment. There are
this is a very
more than 30 different subtypes of PTCL, so it's very difficult to
So for the sake of
the things.
understanding, I am trying to project this slide where the four different subtypes categorized into cutaneous. Of course, that is not the topic of discussion today. We will be discussing systemic, either nodal, extranodal T cell, common T cell lymphomas. So amongst the cutaneous, aggressive, indolent. Aggressive is mycosis fungoides. Indolent is again can be indolent variant of mycosis caesarea. Cutaneous CD30 positive T cell lymphoma, gamma delta T cell lymphoma, cutaneous. And amongst the nodal, most of the nodals are aggressive, like PTCL, NOS, ALCL, and AITL. And extranodal is common, which is seen particularly in our, the Southeast Asian countries, is aggressive variant NK T cell nasal type. And the rare ones are enteropathy associated, hepatosplenic, subcutaneous panniculitis. And while the rare but more aggressive form is leukemic, like adult T cell leukemia, lymphoma, and aggressive NK cell leukemia, whereas indolent is T cell PLL and T cell PL. So, how will you prognosticate PTCL overall? Dr. Shubhrakanti Kundu sir, is Dr. Kundu sir is on board?
No, Dr. Shubhro has not joined.
Okay, so anybody, Dr. Ujjwal Mani sir and Dr. Rajan sir, this is actually mutually, a learning experience going through the PTCL, just trying to get a gist of PTCL. I'm also trying to learn. So it's kind of, for a very heterogeneous lymphoma subtype where all of us can learn together. So do you use a separate prognostic score for PTCL overall, Dr. Ujjwal and Dr. Rajan?
Actually, prognostic scoring is essential.
Yes.
For the staging and prognostic scoring. Otherwise, the treatment planning cannot be done.
Yes.
So, particularly in this case of PTCL, we have to take up the prognostic scoring for the age, for LDH level, performance status,
Yes.
whether some extranodal involvement is there, and how many sites are involved, and marrow involvement is there or not. So these are the usual prognostic markers.
So because PTCL as such, as a group, as a whole, most of them are aggressive lymphomas happening, presenting mostly in stage 3, stage 4, with more common extranodal involvement. So this PTCL specific international prognostic scoring, that is just considers 4 factors: age, LDH, performance status, and bone marrow involvement. And based on that number of factors, you can see the prognosis does vary from low risk to 62% 5-year overall survival, quite good, comparable to most B-cell lymphomas, to the 18%, dismal 18% in a high-risk group. So prognostication, as sir has correctly pointed out, is extremely important. This is again shown in this Kaplan-Meier curve from the German DSH NHL the study group. You can see the prognosis significantly, the overall survival as well as event-free survival changes as per the IPI score. And not only that, it's such a heterogeneous group that the survival also depends on the particular histomorphological subtype of PTCL. For example, here you can see the green bar, that is ALCL ALK positive, has the best possible long-term prognosis, with overall survival at 5 years exceeding 80% and event-free survival exceeding 70%. Whereas all other, there are the other group which has intermediate prognosis like ALK negative ALCL, PTCL NOS, and there are some bad performance like hepatosplenic gamma delta T cell lymphoma and the entropathy associated T cell lymphoma. So coming to our case, Dr. Rajan, how are you going to manage this case?
Yeah, just before I take on this one, one of the other prognostic markers which we feel is sometimes they present with cytopenia. They are the ones which are really do bad. And
Yes.
I'm sure everyone else would agree. Most of the PTCLs which we see, most of them are in a high risk, like whatever prognostics.
So the bone marrow involvement leads to cytopenia.
Yeah, and then we have to be very careful about the HLH also. I mean, they
Yes.
are the T cells are the ones which can present with hemophagocytosis. So that is one more diagnostic challenge which I would like to bring out. Sometimes the patients may present with cytopenias. There is hemophagocytosis. We start treating them as an HLH, and later on they turn out to be T cell lymphoma. So whenever you encounter an HLH like picture in an adult, we should actively actually look for a T cell lymphoma.
Yes.
So that is one thing.
That point. So that's a very valid discussion. Barring the angioimmunoblastic T cell lymphoma and the HLH, the cytopenias are due to the bone marrow involvement and can also be due to HLH as well as the autoimmune phenomena commonly seen in certain subtypes of T cell.
Yeah.
Yes.
So coming to the treatment, like this is one group of malignancy which seriously requires some new agent which should come in, because over the conferences we see CLL, Hodgkin's, everyone is progressing. But unfortunately for the T cell lymphoma, most of them are presenting at an advanced stage, and whatever treatment we give, we are talking about a ballpark figure of around 15 to 20% long-term survival. That's what we can expect. Now, coming to your case as such, is a young patient around 50 years of age and probably with a relatively good performance score. So we should give him the best possible therapy, which we use here. Though there is a targeted agent with brentuximab, which is not available to most of us.
Yes.
But if that's not available, I mean, otherwise you can give brentuximab with CVP kind of a thing without anthracycline. But what we use is etoposide. Now, etoposide is one agent which is very specific for a T cell malignancy. So I think everyone should be given an advantage, especially patients younger than 60 years of age should be given an advantage of etoposide. So as you have pointed out in this graph, which is clearly shown, like CHOP with etoposide for the first 3 days. So that is the one which we generally give to fit patients. But unfortunately, some of them are not fit to tolerate, then we go ahead with CHOP, which is not a good regime if you ask me for PTCL. So CHOP with etoposide would be the one which I would like to treat this patient with.
So Dr. Rajan, coming to etoposide, it was a learning experience even for me. Do you continue giving IV etoposide for 4 days or switch over to oral etoposide, and what do you continue on day 2 and day 3?
Yeah, generally now there are protocols. Since we try to keep our patients admitted also, so we are giving 3 days of IV etoposide 100 milligram per meter square. But yes, you can give the first day as IV, and day 2 and day 3 you can increase the dose because the absorption is not 100, bioavailability is not that. So you increase up to 150 milligram per meter square day 2, day 3.
So that's a very
equivalent
important point you made out, because it's a common mistake that we continue 100 mg per meter square even on day 2, day 3 oral. But oral bioavailability is almost 50% of IV. So the normal dictum is to continue if you are switching over to oral. So 200 milligram per meter square oral on day 2 and day 3. And as Dr. Rajan has pointed out, there are 2 retrospective data, German registry data and Swedish registry data, that the benefit of etoposide is, even though it is most marked in all positive LCL, but other subtypes also, it is statistically significantly superior to the conventional CHOP backbone. So adding etoposide does in young, eligible and fit patients less than 60 years of age without much comorbidities should be considered with, of course, in our setup, the provision of giving prophylactic GCSF, because the cytopenias can be sometimes serious. And as Dr. Rajan has pointed out, even the NCC and the recent version, the only prospective trial which has shown significant survival benefit to the CHOP platform, addition of a newer agent, targeted drug, monoclonal antibody brentuximab plus CHP. Now that is a category 1 preferred regimen recommendation, and subsequently, of course, the other recommended regimens in the event of non-availability or non-feasibility of brentuximab are CHOP, CHOEP. Of course, the dose-dense, dose-intense regimens, younger, fitter patients, but across the trials from the Western data, the MD Anderson trial as well as the European trial, the IPOC and other hypercivet kind of platforms, even there is even the response rates and the overall response rates are better, but the toxicity nullifies the benefit achieved out of the intensified regimens. Now, so this patient, not affordable for brentuximab, continues 6 cycles of PHOE, and young fit patients can still be PTCL achieves complete metabolic remission. So, Dr. Rajan, what will be your subsequent plan for this gentleman?
Yeah, so definitely this is a young fit patient who has achieved a CMR. I definitely would like to consolidate it with auto HCT. So in this case, definitely I'll autologous stem cell transplant.
So not allo as such?
Not allo as such. I would not recommend allo in this setting because there is not much data to support in complete metabolic response and upfront allo as such. Auto, yes, there is a data to suggest that it may prolong the remission. So the PFS would increase with consolidation with autologous.
Yeah. So even though the data is quite heterogeneous and there are 2 schools of thought, but what has been proven from as this has been, I had already projected this slide, barring the good players, ALK positive ALCL and cutaneous ALCL, rest all are poor performance. Even though the high response rate initially is difficult to maintain the response over time. So that's why consolidation with autologous transplant is a very valid, and there are a lot of prospective PTCL trials with at least benefit of the event-free survival improving from 30 to 50% on 3 to 5 years follow-up. Of course, the exclusions, as Dr. Rajan mentioned, hepatosplenic T-cell lymphoma, adult T-cell leukemia lymphoma, TPLL. These are the very, the HST, hepatosplenic T-cell lymphoma, adult T-cell leukemia lymphoma are very poor performance even with ATO. So probably these are the exceptions in T-cell subset where upfront allo can be considered, and the other good performance like TPLL and ALK positive LCL without autologous transplant consolidation, their long-term survival is quite promising, 70 to 90%. So autologous transplant doesn't have merit here. So as Dr. Rajan has pointed out, this is the largest Nordic lymphoma trial. You can see the overall survival and the PFS at 3 to 5 years is about 50%, which without transplant would have been somewhere between 25 to 30%. So there is a definitely merit of autologous transplant, particularly young fit patients in these PTCL-NOS subset. So this gentleman undergoes beam condition autologous transplant at CR1, and he is currently his disease-free survival of about crossing 2 years, doing quite well. So this is what I was mentioning, the CMC Velo data, the PTCL overall. You can see 3-year overall survival 33%, very dismal, 3-year event-free survival 30%. By the Vellore group published by Sandeep Nemani et al. In 2018. And you can see again, even in our subset of patients, the IPI, the conventional general IPI for all the lymphoma subtypes as well as PTCL directed IPI does play an important role. And looking at the Vellore data, you can see 244 patients, 50% were off study because either they didn't receive or lost to follow-up, and the 50% continued off. This 50%, that is 122 number of patients. The patients with progressive disease, 2/3, 61.5%. Number of patients achieving CR1, 40% only. And of these 40% patients, that is 47 patients, only 2 patients underwent autologous transplant consolidation. And of these 2, 1 relapsed and died. The other is CR till last follow. So you can see probably this might be an institutional referral bias, because the most poor performance must be studied in this subset. But the story is not nonetheless great even in our practice. And you can see even those achieving CR1, 30% relapsed, and only out of those 30%, the 15% could receive salvage. And you can see long run number of patients achieving CR2, 28%. And this is just to showcase the real life scenario in our subset. This is a recent paper published in May 2018. So PTCL, as Dr. Rajan has pointed out, needs a lot of collaborative work to improvise their outcomes. Now coming to our second case, this is a 32-year young gentleman, IT engineer, fever, dry cough, progressive breathlessness, significant weight loss. Actually was referred by a pulmonologist to us. He was extensively evaluated by the pulmonology team. He was found to have a tracheal mass, which was removed through fiber optic bronchoscopy, and the mass was the diffuse lymphoid infiltrate on ISC. These were positive for CD30, granzyme B, perforin, and TIA. And the Ki67 was quite high, 90%. So this is his endobronchial mass, and this is the PET CT picture, subsequent staging PET CT, extensive disease, nodal as well as extranodal in the lungs, and spleen. This was the histopathology, the large cells with the clear cytoplasm on ISC CD30 positivity and ALK negative. So this is a case of ALK negative LCL stage 3BE. So now again, both to Dr. Mani and Dr. Rajan, will you like to have further test in this case? This is ALK negative young patient with ALCL.
Actually, I will prefer to have bone marrow also.
Yes, bone marrow is negative. It's not involved by lymphoma.
Okay.
Yes, sir.
So Any other test means we can do on PET scan.
PET scan is done, sir. It's an
done.
extensive
PET is already done.
And extranodal in the lungs and the spleen disease.
So I don't think anything else.
Yeah. So Dr. Rajan?
Yeah, Ganesh, I'm sorry, I missed that. I think most of the tests have been done.
Yeah.
So I guess we
But
can go ahead.
I just wanted to point it out for ALK negative ALCL, DUS22 and TP63, which are mutually exclusive and the characteristic of ALK negative ALCL, not a characteristic but exclusively found in ALK negative ALCL, are very prognostically relevant because those having DUS2 positivity, there you can see on the right sided survival graph, the blue bar is DUS22 positive ALK negative ALCL. The dotted black bar, their outcomes are overlapping. So the DUS22 does equally good as ALK positive LCL, whereas the worst performer here is TP63, which has a dismal outcome, and the one triple negative has an intermediate prognosis. So ALK negative LCL is a quite heterogeneous disease, and now molecularly we can distinguish the poor performance from the good performance. Unfortunately, our patient turned out to be TP63 positive. This is done by FISH, and this is done at select centers, like we sent it to TMH Mumbai because of his young age and extensive disease.
Can I ask a question?
Yes.
Myself, Dr. Kundu, is joining from the Apex Hospital, Tata Jamshedpur.
Thank you, sir. Welcome.
And regarding the thing is that I'm sorry that Dr. Jayeshwar, I talked to you in the morning. I'm
Yes,
sorry
sir.
for the delay joining.
No
Regarding
problem.
the ALK thing is that, which is I am a solid tumor practitioner. So ALK is very important nowadays in non-small cell lung cancer in our line also, where we
Yes,
used
sir.
to preserve the crizotinib is a drug
Yes.
that is being preserved for
Correct,
that.
correct.
And this
Yes.
RAS, I am just asking that it is a 10 to 11 jo mutations is there. Is that any TET mutation has any role in this kind of the treatment, having any prognosticated role or like that?
Actually, sir, that is a very valid point you have raised here on this platform. So yes, there are a lot of ontogenic mutations which are being explored, and then but the data is not yet mature to biomarker directed therapeutic tailored therapy has not yet been. But then what has been found, particularly in ALK negative LCL, these two prognostically relevant markers, DUS22 prognostically very, very good, and TP63 a worst marker, and triple negative, ALK negative, TP63 negative, and DUS22 negative having an intermediate.
And just one question from my side is that if you're finding this patient is not good for the anthracyclines, the patient is having any kind of the problem in the taking the 2D echo, is giving that cardiomyopathy, maybe a chance in the later functional or whatever it be, although it is a very minimal. Although it is a very minimal, but if you are adding this kind of the mediastinal disease with the anthracycline previously exposed and radiation after that, it sometimes causes a case of the, you can say, a relative reactive pericarditis, which is a very common feature. The thing is that we mostly miss the things because mediastinal involvement or the tracheal involvement is very close to your pericardium. Whenever even if we are doing this kind of the IMRT or IGRT or whatever it be the best possible thing, we are unable to save the heart if we are already exposed to the particular dose of the anthracycline. So in a non-anthracycline regimen is preferred, or anthracycline regimen is preferred in this kind of the PTCL.
So overall in PTCL subsets, barring NK T-cell extra nodal nasal type of NK, all for that matter, all NK T-cell lymphomas, the anthracycline based therapies are inferior to platinum or aspergillus based therapies, and also they are acquisitively sensitive to radiation. So barring that subset, all other T-cell comprehensive group anthracycline based the chemo combinations or chemo plus targeted drug combinations are preferred. Of course, there have been some anecdotal reports of non-anthracycline based, like French LISA trial, and one North American group where they have tried non-anthracycline and have proven that the anthracycline versus non-anthracycline across PTCL subgroup, the outcome doesn't differ. Long-term EFS and OS doesn't differ. So coming to that, the same point, Dr. Kundu, you use a lot of crizotinib. For ALK positive ALCL, of course, there is data only for the pediatric population by the Children's Oncology group where crizotinib has given 90% OR and very good 80% CR, very good short-term follow-up data, promising data. But for adults and older patients, the common population of ALCL, there, will you prefer crizotinib versus chemo-based CHOAP or brentuximab plus CHP combination?
So the thing is that main important thing is that we are not that much of the conversation on giving the crizotinib in leukemia or lymphoma.
Yes.
The main problem is that we deal with the mostly non-small cell carcinoma, which is EGFR mutation negative and having the ALK mutation positive. So in that case of the non-small cell lung cancer, we are more conversant and the more frequently we used to give. We don't have a neither data, or you may say that neither we have that on-hand experience to explain or to justify your question. So that is the main important thing.
Dr. Ganesh, can I sort of come in? Dr. Sudipto Roy, can I sort of come in for a minute?
Sir.
On this point of ALK, the ALK in lung is on the chromosome. It's an intrachromosomal mutation with EML.
Yes,
but
sir.
ALK in lymphoma is an NPM.
Yes, sir.
The molecular things are different. So from the molecular part, I don't expect that when there is an NPM translocation in lymphoma with ALK, crizotinib has not been described for that.
Can I come in? Can I come in, Ganesh?
Yes, please.
Ganesh, okay, so we had an experience of crizotinib in ALK positive ALCL in a young person, as you said.
Yes.
And there has been dramatic.
Yes.
But sir, the molecule is small enough. That's why this kind of the molecule, which is used as a MTKIs or tyrosine kinase inhibitor kind of the things, which is such a small molecule, and LPL solubility is so high that they can go and internal dimerization is being blocked. So that's why, as far as you have said, that it is very important for the choosing a proper MTKIs, multiple tyrosine kinase inhibitor, on giving a in our line. I don't have a on-hand experience. At the Chrysler is very common to hear. That's why I am giving this comment.
So this I'll share my personal experience. The ALK positive young person with. Hello.
Dr. Rajan, how many cases of?
Okay, I've got two patients. So the one with an extra medullary mass, and there was a dramatic response. As you said, a younger person are likely to respond. No, there are studies, short series of 11 to 12 patients,
so
where their overall response was around 70%. So crizotinib can be tried in patients whom we had a patient who was paraparetic because of the extradural compression, and there was a dramatic response with crizotinib.
So there have been I also had a patient currently, a young patient, as you mentioned, an educated family, very apprehensive of chemotherapy and long-term genotoxicity of chemotherapy. So opted for crizotinib. Now question here is, how long crizotinib should be continued?
Yeah, so these are the things which have not been decided, but yes, you can offer these. If you can buy time, you can offer. This is one treatment which is likely to work, because I have seen in young patients, definitely, as you said, they have chemotoxicity and not refractory. Definitely crizotinib is one of the drugs which can be tried in ALK positive ALCL. And probably if you buy some time, consolidate them with a transplant or something, there are no answers because they're very short series. But there is a response. There's definitely a response, and there is one.
Yes, particularly in the pediatric and young adolescent population.
Yes, definitely. In young, I'm talking about that group, adolescents to young. Crizotinib should definitely be tried, and the overall response. I mean, just short, small series, but the response rates have been quite good in this patient, especially.
Sir, I have one question on that. I have one question on that. The thing is that is the crizotinib on the pediatrics or in the little age group have any effect on the pituitary secretion on the long term of the thyroid hypothyroidism or lipid metabolism? Because the adolescent time, the liver is in the booming phase. That's why I'm asking. In the long term, do you have any data of in the small age you are using this, and what will be the effect in the later stage? Just
So,
like
no,
that.
I'm not saying this is not a say standard of care or first line therapy. This is a thing which you have to resort to. Now, the important thing is in pediatric ALCL, allogeneic stem cell transplant is also an option. So if you have a patient who is refractory to chemotherapy, you can give crizotinib and probably take him up for allogeneic transplant. Long-term efficacy, the side effects definitely we don't have an answer to it. Very small series. There are 12 to 14 patients, but very effective. Their response rates have been reported as high as 70 to 80% in these children. So definitely
So the
this is one
standard
part.
of care as of now for all, not only the ALK positive, LCL, but all CD30 positive T cell lymphomas. As for the only prospective trial, as I had mentioned before, as Dr. Rajan has pointed out, HLN2 this year, EHA 2020, the updated results were 4-year follow-up results. So you can see with regard to overall survival, you see the hazard ratio. The median follow-up of 42 months, the 75th percentile not reached, and the hazard ratio of 0.66. So, that means there is 24% reduction in subsequent events, including the death or progression. Whereas progression-free survival, median PFS 48.2 months in the brentuximab arm compared to 20.8 months in the CHOP arm, with a hazard ratio of 0.71, which is statistically significant. So, of course, if the circumstances permit, this is the standard of care. And as I pointed out through the NCCN slide, so this should be opted for. And you see the subset analysis. You can see the benefit favors brentuximab based CHP regimen across all subsets. Whatever IPI score, young patients, old patients, various performance status, young fit versus unfit, comorbidities, various disease stages, early stage, advanced stage, and various PTCL subtypes. Everything favors brentuximab based, brentuximab plus probably this is the R-CHOP of CD30 positive T cell lymphomas. And that is the standard of care. So regarding Dr. Sudipto sir mentioned ALCL versus PTCL and the ALK positive versus ALK negative. These are the important differentiating features, but most important, the DAS22 TP63, if they are positive, they exclude PTCL NOS. They are characteristic of pathognomic of ALK negative ALCL, and incidence is quite good, 30%. DAS22 TP63 8%, and most important is the CD30 uniform or strong positivity. ALK positive versus as well as ALK negative LCL, they are uniform, strong CD30 positive, whereas in PTCL, even if they are CD30 positive, it is heterogeneous and not uniform. So these are the differentiating features, and this our person, because he has gastric GI involvement, so he was given 6 cycles of IT methotrexate. So Dr. Rajan, do you prefer?
Dr. Ganesh, we have 5 minutes more, please.
Yes, sir. Yes, sir. I'll try to run over. Dr. Rajan, any CNS prophylaxis and in circumstances?
Definitely, we should consider CNS prophylaxis as we decide in DLBCL with a high IPI. IT methotrexate is the one which we do give even in the T cell lymphomas.
So again, for him, as I'll just quickly run through, because this is again a young gentleman, extensive disease. He also underwent autologous transplant consolidation. Transplant was quite turbulent. Peri-transplant, he was H1N1, swine flu, and he fortunately came out. Unfortunately, within 8 months, he relapsed as he has TP63 positivity, and that's quite very obvious for this particular TP63 positive ALK negative ALCL. So Dr. Rajan, these are the probably cases where allo transplant can be tried. Just can you enumerate the allo transplant, even though there is no consensus, but the circumstances where you would consider allo transplant or the subsequent brentuximab continuous or combination with novel drugs and chemotherapy?
So you have already brought it out, a young person who's having a relapse and not responding. These are the cases where we can offer allo, but unfortunately, one is the data is so sparse, it's mainly in the form of small case series. So really, whether it's working.
Elaborate that chemorefractory relapses or multiply relapsed refractory patients or patients with bone marrow involvement and relapse or patients relapsing after autologous transplant probably
Yeah.
because of sepsis.
Yeah,
And
these are the ones, but they have a very high TRM because they have been exposed to so much of chemotherapy. And
yes,
obviously, these investigational agents, if we have access to, they would be the ones to
yes.
change
So
the management.
mostly single agents giving response rate to the tune of 25 to 30% max, and of course brentuximab. These are the various salvage regimens. I'll skip through it. I'll just quickly jump on to our next case. This is 56-year middle-aged man, progressive ulcerative lesion over dorsum of nose, 3 months. An examination, it shows a flush-covered mass in over the midline nasofacial area, and the nasal mass biopsy was done. It is CD56, CD3, CD4 positive, TIA granzyme positive lymphoid, extensive necrosis, angioinvasion, and angio destruction. So this was his sticky film, nasally destructive lesion, and it has not only nasal, but he has also involvement of liver, spleen, and gut. This was the histopathology, histomorphology, CD56, CD3 positive. So the diagnosis is clear. This is disseminated extranodal NKT cell lymphoma, nasal type. So how are you going to manage this case, Dr. Kundu, please? Dr. Kundu? Dr. Rajan, can you take over?
I think, I'll just quickly, you had already pointed out this, after the smile has come, it's put a smile to us. We do want to give L-asparginase to this patient, other than the chemotherapy. That should be a
very
part
nice
of it.
chart published recently. So the stage 1, stage 2E non-contagious spread is radiotherapy followed by the dexamethasone asparaginase based therapy. If CR, just observation. If progressive disease or residual disease, smile. Other L-asparginase containing regimens, L-asparginase or gemcitabine or platinum based regimens, and then because of the aggressive nature of the disease, in the advanced diseases, even allogenic transplant can be an option here. So this, I'm sorry. So I'll just quickly run over. So just wanted to highlight that the CHOP versus non-anthracycline based therapy in NKT cell NHL. This is a Chinese lymphoma consortium published in Blood Advances recently, July 2020. Clear benefit of non-anthracycline based regimens across all stages, which is statistically superior. So the platinum, the L-asparginase or platinum based regimens are the and also combined modality therapy for stage 1, stage 2 non-contagious spread diseases, very important. It has shown across the groups that radiation first or sandwich, wherein you start with chemo, give radiation, and then continue chemo, has a superior outcome compared to chemotherapy alone. So this is very important, and this is the radiation first schema of therapeutic plan for such patients. So radiation followed by chemo, and then assessment, and then this was an old paper. So even autologous or allogenic transplant. So this person gets the 45 gray involved site radiotherapy followed by M-SMILE, which is pegylated L-asparginase, achieves complete metabolic remission. And again, the question of allo versus atto here is still unanswered. So I'll just quickly. So we did autologous transplant, and he is now 26 months into his remission. There is a question of, so moving away from the one side doesn't not fit all in the management of PTSL. We know SHOEP is the appropriate for some subtypes like ALK positive LCL. Even for that, brentuximab is surpassing that old standard of care, as Echelon-2 trial has shown encouraging long-term data. And CHOP is no longer standard for some subtypes like extranasal NKT cell lymphoma, where either asparginase based or platinum based therapies along with radiotherapy in limited stage is the standard of care. Hepatosplenic gamma delta T cell lymphoma with a very dismal outcome with CHOP based regimens. So non-CHOP based in dose dense, dose intense regimen followed by upfront allogenic transplant or the targeted drugs. I will skip this last case. So
we just have 1 minute. We need to conclude, Dr. Ganesh. I'm very sorry.
Yes,
we
sir.
have finished off for 45 minutes time.
Yes, sir. I am trying to see how to jump on to the concluding slides.
Yes.
So just one last concluding slide. Let me finish. So, so basically, I want to conclude by this chart, which is recently published in one of the journals. Biomarker driven probably is the the promise for the upcoming future, with a change giving a better chance in such dismally, prognostically dismal group of lymphomas. And I would like to conclude with note appeal to keep all of you safe, take care, stay safe, and thank you for this opportunity.
Thank you very much. A wonderful, wonderful job done, Dr. Ganesh. I must appreciate a very difficult topic, very well done. Some carry-home message is what Dr. Rajan had said. HLH is very important harbinger because T cells secrete a lot of cytokines. They are the B cell lymphomas. And the second thing is, from the lab point of view, we are very disturbed because a lot of reactive T cells happen to prove their monoclonality. Like B cell is easy on an IHC, T cell is not all that easy on IHC, and that is perhaps one of the points why so low grade T cell lymphomas are diagnosed in a low percentage. But thank you very much, Dr. Ganesh and all the panelists. So let me hand over to our speaker, to the organizers for the next session.
Thank you very much, sir. Thank you very much to the coordinator and the speaker. So next, I'll be handing over to my co-host, Dr. Malini, who will be hosting the next session.
Thank you.
Thank you.
So we move on to the next session of chronic lymphocytic leukemia. And this session is sponsored by AstraZeneca. And as a session coordinator, I would like to invite Dr. Deepak Kumar Mishra, sir. And he is the Director of Laboratory, Tata Memorial Center, Kolkata. So I would like to invite Mishra, sir. Over to you, sir.
Dr. Deepak? Dr. Deepak, am I audible? Can you speak?
Am I audible?
Yes, doctor, you're audible.
Yes, yes. So very good evening to everyone, and I thank Malini for that short introduction. And at the outset, before I start, since we are 30 minutes behind schedule, we must try to make up some time. I will fail in my duty if I do not thank Professor Tufan Dalai and Professor R.K. Jaina, who are the secretary and the organizing chair of this meeting, and along with Professor Professor for organizing this meeting. And today's theme is chronic lymphocytic leukemia. And the first speaker is Dr. Anupam Chakrapani, who needs no introduction to the Eastern Hematology Group. And he has been he was with us for some time, and he's an astute clinical hematologist. I have seen him from close quarters, and he is a DM from CMC Vellore, currently in Apollo Gleneagles Hospital. And he is going to speak on the role of acalabrutinib in treatment naive CLLs as well as relapsed refractory CLLs. And his time is 20 minutes, and I would request him to stick to his time, and so that we save some time. Let us not overshoot the time limit. Is Anupam there on the screen? Could you share your screen, Anupam? Your slides?
Doctor, I have a recording of Dr. Anupam. I'm going to play it.
Okay, okay, okay. Yeah. But Anupam was there.
I think
I'm there, sir.
Yes.
I'm there, sir.
Yes, so you would like to speak again, or you want your recorded? I think.
No, sir. I have recorded. I have recorded. So it will save our time.
But you are there for question answer session.
Yeah, if required, sir, definitely.
Yes, yes.
Okay, sir.
Evening. I must thank the organizing chairperson and Eastern Hematology Group for giving me this opportunity to talk about on this new molecule now, which is available in India for patients of chronic lymphocytic leukemia. So before I run into the molecule, I must introduce this subject. CLL is a peripheral blood disorder, and basically the criteria as per WHO 2008, when you have a absolute lymphocyte count more than 5,000 in the peripheral circulation, and clonality proved by flow cytometry, it is called CLL. There is other entity which is called monoclonal B lymphocytosis, where the peripheral count is less than 5,000, but the on flow cytometry, it is similar to the CLL. Incidence-wise, one of the most common pre-malignant condition, this monoclonal B lymphocytosis, and generally 1 to 2% of these MBL patients require CLL therapy per year. That is the overall incidence of this MBL. Incidence of CLL is around 21,000 new cases every year in 2018 in USA, and death is around 4,500 due to CLL. Median age of presentation is around 71 years, but in India, the incidence is in bit younger age group. You see a lot of younger CLL patients, and in the US population, if you see, around 33% of their patients are less than 65 years, and around 10% of the patients are less than 55 years. So we have a lot of young CLL who requires newer molecules because they have to survive for a longer period of time, and whichever available drug we have is going to get resistance over the time. So always in search of new molecule, and this molecule can give a hope to the to our young CLL patients, especially those who are high risk as well. So the criteria remains the same for to start the treatments, like indication as per the international working group. If you have a CLL related symptoms, tumor burden, bone marrow failure symptoms, or immune dysfunction, based on that we decide to start a therapy in CLL. And the follow-up also for a diagnosed CLL patient, those who are asymptomatic, who doesn't require any treatment at the time of diagnosis. Based on their IPI scoring, low or intermediate, you can follow up the patient at every interval of 6 to 12 months. And those who are in a high-risk group, you need to follow up very closely 3 to 6 months. And all patients, those who are in the observation group also should get proper vaccination of influenza, pneumococcal, and they should be monitored annually and frequent interval for any dermatologic manifestation of the cancer or age-appropriate cancer. Also, screening is also required because the incidence of secondary malignancy is quite common with CLL patients. So now come to the topic of this today evening, the CLL. So what is the latest NCCN treatment guidelines for this chronic lymphocytic leukemia? So we have two groups of patients. One group, those who are really very old and frail. So more than 65 years of age, or those who are frail and with significant comorbidity. And another group of patients, those who are young, fit, and less than 65 years. Without any mutation like high-risk markers. What is the guideline says? So the guideline says the preferred regimen, that is category 1, is acalabrutinib, ibrutinib, and venetoclax with obinutuzumab combinations. Other recommended regimen is bendamustine with rituximab, chlorambucil with obinutuzumab, ibrutinib with obinutuzumab. Those who are young and fit also, without any risk factor, ibrutinib and acalabrutinib with plus minus obinutuzumab is a category 1. And with the venetoclax and obinutuzumab is also comes into the category 1. Other preferred regimen, FCR, especially in young patient, FR, bendamustine, rituximab. So in India, generally our first choice, based on our experience and affordability of the patients till now, is bendamustine, rituximab in upfront setting. So in a high-risk group of patients, with preferred regimen is ibrutinib and acalabrutinib with venetoclax and obinutuzumab, and other regimens like those who are falls into a high risk like 17p or TP53 this bendamustine combination doesn't work, so you have to give either high dose methylprednisolone with rituximab or alemtuzumab with rituximab. In a relapsed refractory setting, the frail patients and elderly patients, the preferred regimen is acalabrutinib, ibrutinib, or combination of venetoclax with rituximab, duvelisib or idelalisib with rituximab. Other recommendations are you have a lot of various combination based on your experience or the outcome data you can use, like alemtuzumab, lenalidomide combination, some reduced dose of FCR, that is FCR light. Patient, those who are young, less than 65, with high risk, without high risk markers, ibrutinib and acalabrutinib. So you can see the BTK inhibitors comes as a category 1 recommendation across all the group. Those are with or without risk factor, whether if they fall into a frail group or the fit group. And those relapsed refractory patients, those who are harboring a high-risk group, like high-risk mutations like 17p and TP53, preferred regimen is ibrutinib, that is BTK inhibitor, acalabrutinib, venetoclax with rituximab, duvelisib, venetoclax. Other regimens are like alemtuzumab, high-dose methylprednisolone, adalasib, lenalidomide, and ofatumumab. So this is the current NCCN guidelines recommendation for CLL patients. So now I'm going to discuss about this drug. This is acalabrutinib. It's a highly selective, potent, next generation covalent inhibitor of BTK with a minimal off-target activity. That is the key of this drug. It has a very minimal off-target activity, so side effects are very less. So ibrutinib data, if you see, it has evolved, and now in 2015-16, it has got an FDA approval across by these studies like Resonate 1 and 2, Helios trial, in mantle cell lymphoma like SHINE study. And so FDA and European Union approval has already been done for ibrutinib, and now it is a well-established drug in this group of patients. So acalabrutinib is also a Bruton tyrase kinase inhibitor, but it is slightly difficult in its mechanism of action. Acalabrutinib and its metabolite, that is ACP5862, inhibits the BTK enzymatic activity by its covalent binding, and it further inhibits the downstream signaling of CD68 and CD69, and that causes ultimately inhibition of the malignant B cell proliferation and survival, and ultimately cause the cell death. So if you see this diagram, the inhibition by the ibrutinib and acalabrutinib. So if you see this red dots, so this is quite specifically inhibiting this BTK site. And here there are a lot of off-target activity of these drugs. So if you see, acalabrutinib has only 1.5% of kinase inhibition when it inhibits more than 65% of the BTK. And ibrutinib inhibits around 8.9% of the other kinases when it reaches around 65% of the kinase BTK inhibition. So it is quite selective, so that's why you get a lesser side effect related to this BTK inhibition. So what is the data for acalabrutinib in chronic lymphocytic leukemia? So this is the first trial which was done in treatment naive patient of chronic lymphocytic leukemia, that is ELEVATE trial. It's the phase 3 trial done in the 3 groups: acalabrutinib in combination with obinutuzumab, single agent acalabrutinib, or obinutuzumab with chlorambucil. So the patient was selected, those who are more than 65 years of untreated patients and between 18 to 65 years with a good renal function and good fitness. So arm 1 got obinutuzumab 6 cycles with chlorambucil 6 cycles. Second arm got acalabrutinib with obinutuzumab 6 cycles, and third arm got only acalabrutinib. And there was an freedom of switch over to the if the patient has a progression on one group, they can switch to acalabrutinib. And the primary endpoint was PFS, and the secondary endpoint was the overall response, as well as the overall response and overall survival. And they also stratified this data and try to look that how this drug is effective across the different age group based on the risk status like 17p deletion, and is there any geographic region variation in the action of this drug. So this is the key eligibility criteria. So as I discussed, And the baseline characteristics in terms of age, sex, ECOG performance score, IPI score, RISE score, across all the three groups A, B, C, it was equally distributed. And high risk features like 17p deletion, mutated TP53, and like other parameters like hemoglobin, platelet. So all the three groups were equally distributed, and the study was conducted in 3 arms. And if you see the efficacy results, if you see the first line is acalabrutinib with obinutuzumab combination, second one is acalabrutinib as a single agent, and third line is obinutuzumab with chlorambucil. So if you see at a median follow-up of around 28 months, acalabrutinib plus obinutuzumab has significantly better overall progression-free survival as compared to the obinutuzumab and chlorambucil. An elevated estimated 30 months progression-free survival for this combination is around 90%, with only a single agent acalabrutinib is around 82%, and with obinutuzumab and chlorambucil is only 34%. So progression-free survival was quite dramatic and excellent in this group who received acalabrutinib alone or in combination. So 2-year PFS across the different risk group like 17p deletion, TP53 mutation, 11q deletion, or unmutated IGHV mutations. So if you see this acalabrutinib obinutuzumab combination as compared to chlorambucil and obinutuzumab combination, there was a significant better progression-free survival as compared to this one. Like if you see 88% versus 22% in 17p deleted patients. In deletion 1q, it is around 87% versus 24%. So the efficacy results, if you see the median overall survival was not reached in this arm. So estimated 30 months overall survival for acalabrutinib obinutuzumab combination was around 95%, and acalabrutinib 94%, and obinutuzumab chlorambucil is around 90%. So if you can see here, the overall survival has not made much of a difference, but in acalabrutinib. But when these patients going to survive for a longer period of time, we expect that the graph will separate, and we will come to see that the overall survival also improves with use of this BTK inhibitors. And now the most important thing is adverse event with this new molecule. So overall adverse event in any grade was around more than 30%, or grade overall more than grade 3 was only 5%. And if you see headache, it was the most common side effect with the acalabrutinib, either alone or in combination. Headache was the most common side effect, and second was hypertension. And cytopenia was more problematic with obinutuzumab and chlorambucil combination. So the adverse event of interest, which we have learned with the use of ibrutinib, is atrial fibrillation, bleeding, and hypertension. So the incidence of atrial fibrillation was found around 3% in a combination arm versus 4% in single arm, and in obinutuzumab also 1% atrial fibrillation. The any grade of bleeding was around 43%, but severe grade was only 2%. Hypertension was seen also in 3%. So the incidence of these side effects, especially this bleeding and atrial fibrillation, if you compare from this ibrutinib, the previous generation drug, the incidence is little bit less, and it is safer in terms of cardiac side effects. So in summary, at a median follow-up of around 28 months, acalabrutinib and obinutuzumab has significantly improved the progression-free survival. And as a monotherapy, also it also significantly improves the survival to a very large extent as compared to the obinutuzumab and chlorambucil combination. And if you see, around 25% of the patient in obinutuzumab arm has to cross over because of this intolerability or the progression. And the most common side effect which was noted was acalabrutinib obinutuzumab combination was headache in around 40%, monotherapy was 37%, and cytopenia was in obinutuzumab combination. And as per the trial, the PI of this trial, They found that this headache was also well controlled by 1 or 2 tablets of paracetamol, or sometimes high caffeine intake. This paracetamol is quite tolerable. Atrial fibrillation was also reported in 3% of the patient with acalabrutinib with obinutuzumab combination, and 4% in single agent acalabrutinib. Second study was ASCENT. This is in a relapsed refractory setting where single agent acalabrutinib was used versus rituximab plus adalimumab or other combination like with bendamustine or investigator choice. And here around 310 patients of relapsed refractory leukemia were taken into the consideration, and they were treated with acalabrutinib single agent. With combination, other group received adalimumab with rituximab or bendamustine with rituximab, and the primary endpoint was progression-free survival, and the key secondary point was overall response rate and overall survival. And here also the distribution of this patient across these 2 groups was quite similar. And if you see the progression-free survival at 22 months, in this acalabrutinib, this is the line for this acalabrutinib, and this is the investigator choice like adalimumab, rituximab, or bendamustine rituximab arm. So at 22 months, progression-free survival was quite excellent, as in acalabrutinib, like 82% versus 42%. And in high-risk group also, like the patient, those who are harboring mutation of 17p or TP53 mutation, here also progression-free survival as compared to the other combination, it was better with acalabrutinib as a single agent, and it was nicely tolerated by the elderly population as well. And if you see this forest plot of acalabrutinib in a subgroup analysis across the age, like elderly population, male or female sex, ECOG2, rise stage, bulky disease, all this forest plot in subgroup analysis favors the use of acalabrutinib as compared to the adalimumab or bendamustine rituximab in terms of mutation like TP53, IGHV mutations, complex karyotype. It favors the use of acalabrutinib. So it is quite useful in relapsed refractory setting as well. The overall survival, if you see, has not reached in either arms, but if you see in the latter part of this curve, it is now started separating, and the curve has now flattened after 18 months. So now the patient has gone into a long-term survival once those who have crossed around 18 to 20 months of therapy. And the therapy needs to be continued till progression. So patient disposition also, like this table try to show that the patient, those who were in acalabrutinib arms, there was a very less number of patients. They switched to other protocols because the tolerability was quite good and progression was also less in this group of patients. Safety wise in the relapse refractory setting, it was similar to the CLL naive patients. The incidence of grade 3, more than grade 3 adverse event and serious adverse event or treatment related adverse event and drug and dose discontinuation, all this across all these parameter, it was quite higher in other group as compared to the adalimumab, as compared to the acalabrutinib arm. And the most common side effect, as I told you, in the relapsed refractory arm, is pneumonia was also found to have a risk or adverse event in the relapsed refractory setting. So whenever this patient is on acalabrutinib, you have to be very careful of getting a secondary infection, and the proper vaccination or some prophylactic antibiotic is recommended. Like atrial fibrillation, which is the interest is of our interest, atrial fibrillation and major hemorrhages, hypertension, infections. If you see more than grade 3, it was quite less, 1%, 3%, 3%, 3%, and which was similar or more with other combination chemotherapy. So it was quite acceptable, the side effects of interest. So in the final summary, this Ascent trial says that PFS was prolonged with acalabrutinib as compared to the your adalasib and bendamustine. Median overall survival and depth duration of overall response is better with acalabrutinib, and fewer patient treated with acalabrutinib needs a discontinuation. So it was quite nicely tolerated in this group of patients, those who are elderly and relapse refractory, as well as multiple line treated patients as well. So in conclusion, acalabrutinib is a next generation, highly selective, potent, covalent inhibitor of protein kinase inhibitor with minimal off-target activity. It is available in 100 milligram tablets. It is given twice daily, and it causes near complete and continuous inhibition of BTK without any significant drug accumulation. And these two landmark data, that is phase 3 trial of Elevate, TN, and Ascent, established this drug in treatment naive CLL as well as in relapse refractory CLL as a frontline therapy as a category 1 recommendation. So with this, I conclude, and thanks for your patient hearing. Thank you.
Thank you, Anupam, for that wonderful presentation. You stuck to your time, and
Thank you, sir.
we will open it for discussion at the end of the session.
Yes, sir. Sure, sir.
So we move to the next session, which is a panel discussion on the treatment of CLL in 2020, which will be a case-based discussion. And the moderator for this session is Dr. Soumya Mukherjee. And now I would like to request Soumya to take over. And Soumya is a consultant hematologist at the Ruby Cancer Center. And his present affiliate, he is a member of the Indian Society of Hematology and also Bengal Society of Hematology, and well published. And now I would like to request Soumya Mukherjee to take over and moderate this session. Dr. Soumya.
Thank you, sir, for this introduction. Now, in this session, there is a panel discussion.
Soumya Bhattacharya will not be there because he has some problem. He has messaged, so
Okay.
he will not be there available.
Okay. So, okay, we can start the session. These are panel discussions on the real life cases in the CLL. Our panelists are Dr. Soumya Bhattacharya. I think he is not here today. He's a consultant hematologist from Apollo Clinical Hospital, Kolkata. Dr. Asif Iqbal, consultant hematologist from B. Barua Hospital. Dr. Anil Aram Singh, consultant hematologist from JNMIS IMS Hospital, Imphal. Colonel Rajan Kapoor, Dr. Vivek Radhakrishnan from TMC Kolkata, and Colonel Rajan Kapoor, consultant hematologist from Command Hospital, Kolkata. So, can I share my screen now?
Yes, please.
Is it visible now?
Yes, Soumya.
Okay. So the first case, without wasting any time, I'm going just details in the first case. It is deciding the management of CLL. It is a case 75-year-old male patient of diagnosed BCLL, hemoglobin 10, total leukocyte count 56,000, and platelet count is 80,000, and cervical, axillary, and inguinal regions lymphadenopathy. And the fish shows trisomy 12 and deletion 11q with a comorbidity of hypertension, hyperlipidemia, and benign prostatic hyperplasia. This patient, as we all know, in our setup, we all start with the BR, and it was stopped after 4 cycles due to severe neutropenia, and the patient lost to follow-up gradually. This patient again came after 1 year, and the fish report at that time showing deletion 17 positive and patient having a hepatosplenomegaly. So my question is to Dr. Rajan Kapoor, because anybody can pick up the question, no problem in that, because this question was for Dr. Soumya Bhattacharya, as he is not here now today, so anybody can answer the question. So the first question was, beard the ideal treatment option for this patient? And the next one, will you start BTK inhibitor immediately in this patient? Anyone?
Yeah, may I take this call? I'm Dr. Rajan here.
Yeah,
So,
yeah, Dr. Rajan, please.
Yeah, so Anupam has really summed up well. So one thing which is very clear, the days of chemotherapy in CLL are really numbered. You have to think very hard, whether it's a young patient, elderly, fresh diagnosis, or relapse refractory, whether to subject that patient to chemotherapy in the present era. VR would have been great earlier, but now starting on chemotherapy containing regimen in CLL, it's a big question now. So I wouldn't have thought about giving VR in a 75-year-old at that time also, and more so now that since the del 17p is there, definitely the chemotherapy is definitely out. Now the other thing which I would have liked to know during that, whenever you plan to start treatment for CLL, you should always rule out autoimmune complications. So a bone marrow is a must, whether to know that whether, and a Coombs test. So whether to know that if is it due to the CLL disease progression or it is due to the autoimmune complications, because the management changes in that. So that is one thing before we start for treatment. So your first part, BR definitely I won't have thought of in a 75-year-old. Second question was whether we can start a BTK inhibitors in them. Yes, first we do workup for comorbidities. I probably would like to know what is the bone marrow status in that, and then I can go on for an ibrutinib. I mean, it's one of the BTK inhibitors in this patient.
Yeah, thanks, Dr. Rajan. That is nicely spoken by you. And in the CLL first line treatment, Dr. Nupam also showed the slides, and it was the taken from the recent guideline, which was updated in June 2019. It clearly showed that here you can see the BTK inhibitor is the first choice in every case. Here you can see, except few conditions, just like if you have mutated status and patient have active disease and there is no deletion 70 young patient, then you can think about FCR. Otherwise, definitely ibrutinib, acalabrutinib, these are the definite drug of choice here. So my next question is a 56-year-old male patient of BCLL, no known comorbidities, sorry. Hemoglobin is okay, 12, total count 36,000, platelet 1,90,000, patient having only axillary lymphadenopathy, beta 2 microglobin mildly elevated, and bone marrow was done. It shows diffuse pattern, 80% lymphocyte, but deletion 17p was positive. So the question is for Dr. Anil, how you will manage this patient and how will your treatment change based on the mutational status, IgHV mutation status, and what is the rationale behind prescribing the chemoimmunotherapy in deletion 17p positive patient, if at all you think? So, Dr. Anil.
Yeah, thank you, Dr. Soumya. And this is a very interesting case. If we see the rise score here, because hemoglobin is normal, platelet is normal, and probably TLC is not very high, we would have thought of not even starting treatment. But because of the newer prognosis marker like beta 2 microglobulin, which is mildly elevated, it's a bad prognostic marker. Then bone marrow showing diffuse pattern of these lymphocytes, which is again itself a risk factor for bad prognosis. Then again, most importantly, there is deletion 17p. Now, the thing is, if a patient who is completely asymptomatic, despite having deletion 17pq, 17p, we may wait for some time. If there is a definitely symptom, we should start treatment. So here, even if there is this one, that prognostic markers are there. From the history, there is no symptoms of any patient complaining of much symptom. Any other symptom patient is having?
No, the patient is quite asymptomatic patient.
Okay. So in this particular case, if the patient is asymptomatic, I would still want to wait. And if the patient develops any kind of symptom, I would like to start on BTKI inhibitor, as Dr. Sakrapani also just has said, either ibrutinib or acalabrutinib we should choose. And regarding the
use of IGVH status. Actually, if it is unmutated, it is going to be an issue. And if it is mutated, then we can go for, like, since he is below 56 year, we can go for chemoimmunotherapy like FCR. And if he is fit for this one, and I think since he doesn't have any symptom, I would wait. However,
Yes.
there is a definite deletion 17pq. So once he require treatment, I would definitely go for this what is that Bruton kinase inhibitors. And regarding the rationale behind prescribing CIT in deletion is that there are some studies where they have prescribed chemoimmunotherapy in patients of deletion 17p. The problem is there is the median overall survival is quite less. So because of that, they have gradually shifted to the Bruton kinase inhibitor nowadays.
Exactly, Dr. Anil. So basically what happens is that in CLL, don't be so haste to start the treatment. That is very important. If the patient is symptomatic, having tumor burden related problems, as Dr. Anupam told in the previous slides, previous session, and if there is definitely cytopenia related to the disease itself, definitely we should start. But asymptomatic patient with deletion 17 per se is not the indication to start the treatment, as you have clearly mentioned. So definitely we'll wait and watch, and if at all, and we'll follow up the patient when the treatment requires, we'll decide accordingly. So, and this is the current standard of treatment in CLL. If the patient meets the criteria for the treatment and the patient is a treatment naive, then we have to go for the deletion 17p or TP50 mutation studies. If it is mutated, definitely we should use the Bruton tyrosine kinase inhibitor like ibrutinib, acalabrutinib, or venetoclax like BCL2 inhibitors. And if it is not mutated, and if it is not deletion 17p mutation is there, patient is aged patients with lot of comorbidities, then also the first line is ibrutinib or acalabrutinib. And if the age is low, say it's less than 65, patient having mutated status, then we can think about the FCR. Otherwise, ibrutinib is the choice. So the next case, it is 74-year-old female with BCLL, the trisomy 12, IgHV mutations, status unknown, patient having axial and cervical lymphadenopathy with hepatosplenomegaly. This patient received 2 cycles of bendamustine rituximab, but due to severe toxicity and dermatologic and severe nausea, patient discontinued the therapy and patient was discharged on request. This patient again came to the clinic after 3 months with complaints of night sweats and on and off fever, with hemoglobin 9, total count 55,000, platelet is 70,000. And this, in the past history, patient had a history of CABG 3 years ago, and patient is diabetic. So this question for Colonel Kapoor is that what additional diagnostic tests you will recommend, and what is the rationale of re-challenging in CLL? And if you consider Bruton tyrosine kinase inhibitor treatment, which molecule would you prefer in this case? So it is the case. Dr. Kapoor.
Yeah, so in this case, coming to the test, definitely I'd like to do the molecular markers. I would like to know the IGHV mutational status. And just go back to the previous slide. Do we have a DEL 17?
Sure.
Yeah, so we would like to get both DEL 17p as well as TP53 mutation status.
Exactly.
In this case, because we are deciding to treat this patient. Now, the second part is definitely it seems, and I would like to do a bone marrow. So in CLL, it is very important whenever you decide to, for diagnosis, you don't require marrow because the tests can be done on the peripheral blood. But once you decide to treat the patient, we should ideally do a bone marrow to see what is the pattern of involvement and whether the cytopenias are autoimmune in nature or due to the disease progression. So these are the tests I would like to do. Other than
one thing, Dr. Rajan, Dr. Rajan. Yeah. One thing I just want to ask you in the patient, like this patient, our patient. So bone marrow, you were telling that you are not doing in the initially, but subsequently you follow this bone marrow in every patient of your patient.
Yeah, the thing is that bone marrow, when you decide to treat, because the major indication of treatment in CLL, as has been pointed out, would be the development of cytopenias. So if a person is developing cytopenias, it's very important to know the cytopenias are due to the disease progression as such, or are they due to autoimmune in nature.
Now,
So if
suppose
they
we
are
were
all
doing the direct comb tests, okay, and is negative, then
direct comb test, if it is negative, but still there may be a component of an ITP. I'm just saying if the, because what happens is if there is an thrombocytopenia, anemia is not that severe. So if there you generally in CLL, if there is a severe thrombocytopenia and there is not significant anemia, then ITP has to be ruled out. But if you have a very severe anemia, DCT is negative, and a very severe thrombocytopenia, you may avoid it. But the dictum is, let's say, I mean, for all the residents and all, what I say is that if you have cytopenia, you decide to treat, it's always better to do a bone marrow to see what is the pattern of involvement and whether there is autoimmune. Because if there is an autoimmune complication, especially in a 75-year-old, I would like to give IVIG, start them on steroids, give a weekly rituximab. That is the one treatment which can be offered, though it seems unlikely in your patient. So once we decide to treat this patient, can you just go to the slide? What is the second question? I just forgot. Yeah. What is the, no, obviously in this age, I think she was given BR initially. I'm definitely not going to re-challenge in her. Definitely at 75 years, within 1 year, incomplete treatment, BR would not be an ideal choice. As I had already pointed out, chemotherapy days, it's really hard to convince someone for chemotherapy in the present day, I would say. Now a very important thing is, if we consider a BTK inhibitor as treatment of choice, which one would we prefer? Now we have a choice between ibrutinib and acalabrutinib. Now, as has been pointed out, the major advantage of acal over ibrutinib is off-target inhibition is much less, the SRC kinase is less. So there's a paper which was published in 2019, a real world evidence of acalabrutinib use. So though personally I don't have any experience of acalabrutinib since it's been launched recently, but it seems to be very encouraging, because here we have a population, the septuagenarian 75-year-old, who probably would be on antiplatelets and multiple other drugs. So it would be, and we know the biggest problem with the use of ibrutinib, what we have seen in general practice is, one is bleeding and second is an infection. So there is a paper which says that though we start ibrutinib, almost 40% would be off ibrutinib within 7 to 8 months. So because of the adverse events. So one of the major adverse event is bleeding. Means what I generally do is, people who are on dual antiplatelets, we cut down on one antiplatelet when we start on ibrutinib. So if I have a choice of using acalabrutinib, I definitely would like to choose, because the data suggests that there would be lesser amount of bleeding, especially in this kind of population, 75-year-old, maybe hypertensive and on antiplatelets. I would definitely like to use acalabrutinib rather than ibrutinib.
Yeah, in my personal opinion, actually, I have used a lot of patients ibrutinib, and the main issue, what I have noticed in my patients, bleeding, okay, minor bleeding, bruises is fine, but sudden after few months, 3 months, there is a hypertension. Okay, if the patient is in the baseline hypertensive, sudden there is a increase in the blood pressure and atrial fibrillation in 9 to 11% of the patient. But in the trials of acalabrutinib, it was shown that it is 3%. So it is quite, I think it is quite significant, especially in the cardiac patients. In the patient who is having hypertension, having a history of atrial fibrillation. So there is a lower chance of fibrillation and heart diseases in acalabrutinib, what the study showed so far.
Yeah, that's what I would like to ask you also, means you have used ibrutinib. How long have you been able to give ibrutinib in your patients?
First thing, important thing is that for CLL treatment, what I usually tell the patient, what sort of treatment. If the patient is okay physically well, but do you need a fixed dose therapy, or do you want to continue for long term? So as for ibrutinib, I think there are few case reports are there for fixed dose regime for ibrutinib also, but it should be continued lifelong. And fortunately, my patients are still continuing for last 1.5 years with minor bruises, but hypertension is definitely an issue in my patients. Okay, so we are moving to the next question. It is the case number 4. It's a young patient, 38-year-old male patient who was diagnosed CLL 1 year back. It is unmutated case. Fish shows trisomy 12, and he was on wait and watch as the patient was asymptomatic. After 1 year, there is sudden leukocytosis. It from 20,000 at the baseline, it came out to 3 lakh. Spleen is very large, palpable. Patient is symptomatic, and repeat prognostic markers that showed no difference. It's same like the before. So my question to Dr. Vivek, there are I think 4 questions, one by one. So how often should a patient of wait and watch be examined? What is the, you will call the patient to your chamber how often in this type of patients? And would you consider finite therapy or treatment till progression, and why? And if you have options of CIT, proton tyrosine kinase inhibitor, and venetoclax, what would be your choice and why? And stem cell transplant, particularly in this type of young patients. So, Dr. Vivek.
Thanks, Dr. Soumya. A very interesting case and equally challenging questions. So, if we can just go back to the case.
Yeah.
Essentially, this patient is a 38-year-old who has been diagnosed with CLL. So, a young CLL who is in the most productive age group of his life and has got a very high risk cytogenetics with IGHV unmutated. We don't, at the moment, he does not have any P53 deletion and is on wait and watch. What we see now is that he is symptomatic. So in a patient who is got high risk cytogenetics, which is IGHV unmutated in this case, the general, if you look at guidelines, they would look at advice to recruit in a clinical trial. But in those patients who are asymptomatic but still harbor high risk cytogenetics, it would be better to wait and watch them closely. The general recommendation is to see them in the clinic once in 3 to 4 months and look for evidence of progression. So if he has any signs of progression in terms of counts, or as in this case, he has got a massive splenomegaly right now, which is making him symptomatic, or he develops cytopenias, then it would be mandate enough to start treatment for this patient, knowing very well that he has got high risk cytogenetics in his background. Now, the next question Dr. Soumya has put to us is, would you consider finite therapy or treatment till progression, and why? See, in this patient, we should know that he's young, he has to work, he is in the most productive part of his life. He's not looking at something that he will be taking for a long time. So what are the options that we have before us, assuming that his financial resources are reasonably good? For those who don't have financial resources, we have to look at what our institute practices. But for those who don't have issues with finances, I think the options today are very clear, and Dr. Anupam and Dr. Soumya have already put it up for us to see that in such high risk cytogenetics, it is always better to look at upfront BTK inhibitors or BCL2 inhibitors. The good things with BTK inhibitors is they are oral therapy. Patient can go back to work, but there are long-term issues with ibrutinib, especially. Dr. Soumya has already spoken that it could be anything from hypertension to atrial fibrillation to a tendency to bleed. And acalabrutinib in that case fares better because they do much better in tolerance wise. So recently there was a good real world evidence that was published which showed that with about 9 years data in ibrutinib, the discontinuation rate was as high as 75%, whereas in the case of acalabrutinib, the discontinuation rate was about ballpark 25 28%. So it is better tolerated. So if you're thinking of a BTK inhibitor, maybe a good option that he does not have drug-related side effects and he can take that therapy. But the problem with BTK inhibitors is that this is lifelong therapy. They have to continue this treatment until progression. So that is where the next question comes as finite therapy. So is there any evidence for finite therapy? Recently, there is a publication in the combination of venetoclax plus an anti-CD20. In this case, it was obinutuzumab. So it finite therapy of 12 months. That was what was the study all about. And the significant thing about the study was those patients who achieved an MRD negative status. So they did an MRD based assessment, and those who were MRD negative, they continued to do well. So is there finite therapy today recommended by NCCN and different guidelines? Yes. So venetoclax plus obinutuzumab is the combination that is chosen. So the third question Dr. Shomu has put us is, if you have an option of chemoimmuno, BTK and BCL2, what would be your choice and why? Primarily in the Indian setting, financial resources would be one of your basic cornerstone of making those decisions. But having taken care of that, if we have to understand that he's young and he's got a low-grade disease which is likely to persist for a long time. So somewhere in the lines of therapy, we should have in our mind that he's likely to be a person who's going to get a second line, a third line, and subsequent lines. Even an allogenic bone marrow transplant will have to be kept in mind in a young person, because we want a reasonably long duration of disease-free survival. So we could start with, discuss with him the options of a BTK inhibitor and a BCL2 plus BCL2 and obinutuzumab combination, and offer him finite therapy preferably, so that he's off drugs for at least some time. And in salvage setting, we can offer the other oral therapy, which if he has got first line BTK inhibitors, then he gets in second line, he gets venetoclax. And also keep the option of an allogenic transplant in this patient if he has a tendency to relapse. Another question is, with the development of CAR T cell therapies, we do see, because CLL was one of the diseases where CAR T cell therapy was used first. So this is also something that may be used in young patients who relapse after the first line or second line of therapy. So yes, the small molecule inhibitors BTK and BCL2 would be my first choices, followed by, in the second line or third line setting in a young patient, also keep a consideration for allogenic bone marrow transplant and clinical trials anytime which look at deeper responses, MRD negative status.
Yes, Dr. Vivek, one important thing is that between BTK inhibitor and venetoclax, BCL2 inhibitors, one important question is that BTK inhibitor.
Soumya, if I interrupt you, just 5 more minutes to wind up.
Okay, fine. I have only one slide. So BCL2 inhibitor is very important because it definitely BTK inhibitor never acts in the stem cell level, but BCL2 inhibitor, the study showed it definitely having some role in the stem cell level also. So there is a role of definitely finite therapy in BCL2 inhibitor plus obinutuzumab. So my next question is a last case, 52-year-old male, diagnosed CLL with cervical, axillary, and inguinal lymph node hepatosplenomegaly, complete 5 cycles of FCR. It improves, clinically discharged 8 years after his diagnosis. The patient now is 60-year-old. He develops bulky lymphadenopathy with progressively larger lymph nodes in the cervical and axillary area, and total count is 45,000. FISH shows deletion 11q. So, Dr. Asif, how do you choose between FCR and BR as a first line therapy in CLL?
Yeah, so FCR is always the first choice of chemoimmunotherapy in CLL. provided the patient is deletion 17p negative and IGSV mutated. So FCR is always the first preference, provided the patient tolerates. So our main problem is that the patient is usually does not tolerate FCR, and hence we use bendamustine plus rituximab as the first line of CLL therapy. In fact, both has been recommended as an options for chemoimmunotherapy.
It all
So
depends
it's good.
on the tolerability of the patient.
Yeah, it's good that this patient has tolerated FCR 8 years ago. Now, this patient has had a relapse of CLL, and as we can see that the patient has a bulky lymphadenopathy. So probably the patient is symptomatic for lymphadenopathy. I do not know if the patient is anemic or cytopenic. Is the patient thrombocytopenic? So that will be an important issue, because 1 year ago, probably I would have used bendamustine rituximab or FCR again in this kind of situations. 8 years on and patient has relapsed, but now I would like to use a BTK inhibitor based therapy, either ibrutinib with rituximab or ibrutinib alone in such patients. I just want to know if the patient is thrombocytopenic or not, because that might be an issue with
Exactly. The data is not there actually at this moment. Okay, I don't have the data. So which regimen do you most often use in patient with relapsed in your clinical practice in relapsed refractory CL?
We usually get older patients, so we use ibrutinib alone. So I am using ibrutinib alone, but given a situations, I would love to use ibrutinib plus rituximab also.
But I think the study shows between ibrutinib arm and ibrutinib plus rituximab arm, there is no such significant difference. I think so.
They have I think recommended it to ibrutinib plus rituximab in younger patients and ibrutinib alone in older patients. So that is like tolerability is, I think, is the most important issue again.
Okay. So, and what parameters do you look before prescribing any BTK inhibitor in a patient?
Yeah, we would like to see for the cardiac status, cardiovascular status. We would like to see the patient's co-prescribed drugs, as well as if the patient is thrombocytopenic. So for me, that is an important part. And secondly, I also, that the compliance becomes very important, because ibrutinib, when we use the first 1 month, there is usually no changes in the lymphadenopathy, the symptoms. So that is very important, because after the patient comes after 1 month and they say that there is actually increase in the nodes. So patience becomes very important, because again after 2 or 3 months, then it slowly decreases. Most of the times the response is
counseling is very important also, because there is a decrease in the lymph node size, but increase in the lymphocyte count in the peripheral blood smear that causes problem in the patient also in the report.
Yes.
So I think the last question we have already discussed.
Yes.
So I think this is the last one. So yeah, Dr. Mishra.
Yes.
Yeah, I think we have finished all the cases.
Okay.
Yeah, all the cases. Thank you all the panelists, and thank you AstraZeneca for this program. Thank you, Dr. Mishra.
Thank you, Soumya, and all the panelists for this timely conclusion of the panel discussion, and it was very, very informative. Before I end, just would like to open it for a couple of questions, just 2 questions in case the audience has any.
Hello, Kalpana.
Anyone?
Welcome. Hello, Kalpana.
No, doctor. It could be to Anupam also, it could be to the panel also. I hope Anupam is in the audience.
Good morning and welcome.
Anybody? Okay, so if there are no questions, then we wind up this session, and I hand over the proceedings to the host, to the organizers.
Thank you, sir. Thank you, session coordinator, speaker, moderator, and panelists. So now we move on to the next session, and for that, I invite my co-host, Dr. Prakash, to take over.
Thank you, Dr. Mane. Thank you all. So the next session we are going to hear is on sickle cell disease, and I would like to invite, and the sponsor for this next session on sickle cell is Novartis, the reimagining medicine,
and they are just going to launch this crizanlizumab here with a trial. And I would like to invite Dr. R.K. Jena sir as a session coordinator for next host. Sir is professor in HOD currently in the Department of Clinical Hematology at Cuttack, SCV Medical College, Cuttack. Sir needs no introduction. So straight away to Dr. R.K. Jena sir to take over and proceed further, sir.
So good evening and welcome to this evening session. Probably this is the last session, I believe. Yes. And good morning to our international faculty, Dr. Kalpana. Hi, Kalpana. Morning. Kalpana and Dr. Abdul Kutla. So you know, the sickle cell disease is one of the commonest genetic disease so far the hematology is concerned, and it is a big health problem across the world, in many parts of the world, and even in the many parts of the country and Eastern India also. So we have two international speakers and few national speakers. At the outset, I will invite Dr. Shirish Patel to speak on the real world management of sickle cell anemia. Just to introduce Dr. Shirish Patel, she is a gynecologist by profession. She has done her MD on obstetric and gynecology. Now currently she is the joint director in the medical services and working as a senior medical officer in the sickle cell unit and in the molecular biology of Biro Surendra Sai Institute of Medical Science and Research, Gola, where you know we have a dedicated sickle cell unit and a lot of projects funded by the government of Odisha, even ICMR and DBT are running. She has a passion for the sickle cell research, and she's very much her entire career is involved with the sickle cell research and all the activities. She was very much involved in the sickle cell activities across the Odisha and across the country is concerned. I would like to remind Dr. Patel, since it's already late, I will request you to restrict your talk within 20 minutes so that we can go ahead with the other discussion and other speakers also. With these few words, may I invite Dr. Shirish Patel to speak on our topic. Dr. Patel, please.
Thank you, sir. And thank you for the words. And good evening, esteemed gatherings. I am audible, sir?
Yes, sir. Yes, ma'am. You are audible.
And my slide.
Doctor, I'm sharing your slide. Doctor, I'm sharing your slide.
Okay. So, you know, Odisha is a hub of sickle cell, as Professor Jena has told already. And I'll share some interesting aspects only. And this is the clinical, what we are finding in Delhi day to day in our Western Odisha, especially also the whole Odisha. And our catchment area also becomes Chhattisgarh, and some patients from West Bengal, Jharkhand, Andhra also, they are also coming. And some interesting finding will be. So now under NHM, the Odisha Sickle Cell Project is going on since 2010. Next. So it is a OPD only. And we are seeing the patients, we are screening the family. Next, this is our OPD building, there is an institute here, and we are our motto, next, these are in generation it is passing, so our motto is to prevent the sickle gene transmission to the next generation by prenatal diagnosis, at least decrease the sufferings of the sickle cell disease who are already suffered, already possess the disease, and creating awareness. Next. So one thing I will stress here, from all the OPDs of our center, of our medical college, they are sending, we are requesting them to send all the patients of any age, if there is any symptom related to sickle or like blood disorders, so that we can also exclude sickle cell, because also later on, there are sickle cell disease, they are diagnosed above 50 also in our area. Next. So we do the registration, and we take the informed consent also. We take make a patient record and give a counsel for the treatment and counsel for the family screening also, and regular follow up we advise them. Next. So investigation, once the patient comes, we do the slide test, sickling test, then hemoglobin electrophoresis. If it is coming to AS, SS or something, then we register the case. In SS group, we give the hydroxyurea, and also we have some research by DNA analysis, and also there is flow cytometry is there working. Next. Next. So we are getting many compound heterozygotes, except sickle cell anemia, sickle beta 0, or all other compound heterozygote sickle cell disease also we are getting in our area. Next. So why screening we are doing? Next. So we are giving the patients wherever after we diagnose the case at any age, 6 months, 1 year, we give prophylactic penicillin. We advise them for all the immunization, including pneumococcal and pediatric consultation. If any needed in the local consultation, they should be there. They should be there. They should consult for any fever or like that. Then we give the parents the educations what to do when there is any crisis or there is blood, any fever or dehydration or vomiting, and which reduces the mortality and morbidity if we start from the childhood treatment. So what the parents' role? They should take about the nutrition, and they should take care of the nutrition. They should check the infant temperature, not daily. If any symptomatic or if they feel the child is some sick looking, they must recognize the early symptoms of complications, and if there is fever, pallor, respiratory distress, and at least they should learn how to palpate the infant spleen. That we also tell to the parents. Next. So that acute splenic sequestration crisis we can detect. And couple screening we are doing, because now there is also chance of AS married to AS, and when there is chance of sickle cell disease patients. Next. So these are our extreme age of presentation with the hydroxyurea. This lady is diagnosed now only at the age of 50 plus, and we have started hydroxyurea and doing well for 1 to 2 months, last 1 to 2 months, and the baby is also taking. Next. So one thing I'll tell in the past year, even Brahmin we are giving some, we are receiving some patients Brahmin with SS diagnosis, and there are OBC caste are more than the ST/SC caste. We are finding that is 54%, and ST/SC both combined it is around 33 to 35%. So Brahmin also should be tested for sickle cell. Next. And here there is this old lady's mother and son, and mother is diagnosed first time with her son. So this is the important basis. We should not ignore sickle cell while diagnosing any failure cases, anemia cases. Next. So these are the beneficiaries, and longevity is more in our area. Above 70 patients are there. Next. And if we take the gender, it is male and female around 60%, 40%. But maybe some females may be neglected. It is may not be the true incidence of sickle cell disease, but whatever patients are coming, we are just taking the percentage. This is the incidence: 60 male and female 40%. Next. So clinical presentation is male painful crisis, followed by anemia, and there are splenomegaly, jaundice, infection like that, and leg ulcers, stroke, and priapism are very rare in our area. Avascular necrosis, of course, it is 4 to 6% we are seeing, even in the younger ages. Next. So we are giving hydroxyurea treatment only here, though many newer things have already come and already came, but we'll try to give those include in our treatment also regimen. So already registered sickle cell patient more than 22,000, and patients treated with hydroxyurea. 2/3 patients are treated usually, 1/3 is non-hydroxyurea or irregularly they are coming, so they are not included here. We usually give the low and fixed dose 10 milligram per kg body weight. And if there is no response, we increase it to 15 to 20 milligram per kg body weight. Next. And this is these are the beneficiaries again: the mother, the child, and her mother. Next. So the indications, if we take the hydroxyurea therapy, then indications mainly painful crisis, followed by painful crisis and blood transfusion. Then there is blood transfusion indication. Next. So we are giving 10 milligram per kg body weight. These are the children, and the Professor Jana was also telling whenever the patient comes, 9 months, 1 year, we should start hydroxyurea irrespective of the symptom. Also, we are starting nowadays. Next. So these are just evidences. 8 years on hydroxyurea, they are doing very well. With wherever next, when we are telling previous one, when they are called non-responders. Non-responders, these are not true non-responders. If they are stopping hydroxyurea in between or taking very low dose for a long period, with that, even if the weight is increasing, they are taking the same dose for years together, then there may be some crisis or blood transfusion. So we should have taken the history, whether what is the cause, so that hydroxyurea is not responding. And there are some 10 to 15% of cases, they are not responding to hydroxyurea, even with the higher dose like 15 to 20 milligram. We are not giving the maximum tolerated dose here, not giving, because 15 to 20 they are responding if they are coming regularly. Next, and we have some research publications already, activities is going on. Next. So this is the grassroots level of awareness to the Anganwadi worker and also ASA workers, and in the also ANM level. Next. Health camps are also going on, mainly school screenings like that, and school children screening, also the village screening we are doing. Next. So our message is test once for whole life for sickle cell. One should go for newborn screening, if not, at least go for neonatal period screening, or not, or even go for premarital, if not, at least in the antenatal period of both the partners. If not also done, then after pregnancy, if both in the target couples, you should go for prenatal diagnosis. And early identification is must with prophylactic penicillin and early consideration of hydroxyurea. This is our message. Next. So thank you, sir.
So thank you, Dr. Patel, really finishing before time. We'll now move to the next speaker. So the next speaker is Dr. Kalpana Gupta. It's always a pleasure to introduce her. She's a professor of University of California, USA. And Kalpana, the entire career is involved with the research project and understanding the insights of mechanism of pain and pathophysiology of sickle cell crisis, and locating and identifying the various stages, how to modify the pain and the disease process, including the many innovative receptors, mast cells, and non-cyclic receptors where the benefit can be transferred to the patients. And she has also involved with many research on unusual things, including, say, diet modifications, acupuncture, and perceptions of the modulation of relief of pain and so on. Dr. Gupta is a recipient of so many awards, and one of the important is she has received the Excellency Award in the Hemoglobinopathy Research Award from National Heart Blood Institute, USA. And she has also recipient of the Sickle Cell Disease Program, and she has a lot of projects being supported by NIH and National Heart Blood Institute. She has also received the Pioneer Award from Sickle Cell Disease Association of America. And most importantly, she's a true friend of mine. The entire Indian Society of Hematology Blood Transfusion, Eastern Hematologist Group, and Bengal Society of Hematology, and so on. And it is because of her personal effort, there was a collaboration between the American Society of Hematology and the Indian Society of Hematology could be made possible from the Puri conference in 2012. It is her, so this collaboration is because of her effort it was made possible. With this word, I again thank a lot of on behalf of Eastern Hematologist Group to Kalpana Gupta, really taking so much of personal interest to making this session of sickle cell disease so lively and so important with the two international speakers. With these few words, may I have the pleasure to invite Dr. Kalpana to deliver her guest lecture. So, Kalpana Gupta, please.
Doctor, I have Dr. Kalpana's recording.
Please. So please play the recorded speech, and she's there. Good morning, Kalpana. She's there. She will be answering.
Thanks for those kind words, and it's always a pleasure to see you all. I wish I was there in person, but hopefully next year.
Yes.
Okay, with your permission, I'm starting the video, Doctor.
Evening. Thank you for inviting me to speak at your Eastern Hematology meeting. I'm delighted to be speaking to the audience, and I will be speaking about the promising advances to target pain in sickle cell disease. Before I start speaking about pain, I would like to declare my consultants and research funding from different companies here. Why do we have to think about pain? What is pain? Neither of us know what is pain. And this elephant and three blind men depict exactly the status of pain, its understanding, its treatment, and its feelings are today. Pain alone costs more than $600 billion a year, which totals to about what is spent together on cancer, heart disease, and diabetes. So this just shows how big an issue pain is. And the annual cost of hospitalization for sickle cell disease in just the United States is almost about $500 million. And most of the admissions occur due to pain, and the pain due to VOCs or vaso-occlusive crises. Ironically, the molecular basis of sickle cell disease, or what sickle cell disease is, was described almost 3/4 of a century ago by Linus Pauling, that there is a point mutation in beta globin chain. But after 3/4 of a century, we still do not know the major comorbidity of sickle cell disease pain, what it is, and how to treat it. What does it mean to live without pain? This is a big question, which is often asked by those who suffer with sickle cell disease. Because, unlike many other conditions, in sickle cell disease, pain can start during infancy. It is recurrent, and the unpredictable episodes of crises and acute pain can be superimposed on chronic pain, leading to frequent hospitalization, poor quality of life, increased morbidity, and mortality. Chronic pain occurs in almost 50% of the patients at all times, and they describe it as deep tissue piercing pain. They have increased sensitivity to touch, wind speed, heat, and cold. And in a climate like that of India, where there is also humidity in different seasons, it gets even worse. And with changing seasons, pain also changes. It can be neuropathic, inflammatory, and nociceptive, which means it has a complex pathobiology. Now, hydroxyurea therapy, as you all know, has really improved survival and general condition of the patients. And now curative therapies like transplant are also proving to be therapeutic in sickle cell disease, but they do not reduce pain or ameliorate it. So in the current climate of not really knowing, having any established therapy for pain in sickle cell disease, opioids remain the mainstay. Now, opioids have been known for centuries to relieve pain, but they do have side effects such as sedation, nausea, vomiting, tolerance, addiction, hyperalgesia. Now, due to these three, tolerance, addiction, and hyperalgesia, it is very challenging to treat with opioids, particularly in case of sickle cell disease, where most of the patients, at least in the United States, are African American. So there is some stigma, and there is also fear of addiction, which is quite alarming. And also, a few years ago, our laboratory, in collaboration with our clinical teams, found that higher opioid requirement was associated with reduced progression-free survival and reduced overall survival in men with prostate cancer. Now, this also raised a question that the shorter survival in sickle cell disease, could it be due to use of opioids, which happens very frequently in the United States and in Europe? So what we did was to examine, does morphine influence hyperalgesia, survival, and tolerance? We used a mouse model, which is called Burke mice. These mice express human sickle hemoglobin, and they are called humanized sickle mice. Most of the characteristic features of sickle pain and many of the sickle pathobiologic and hematologic features are present in these mice. So they serve as excellent models to study, because we cannot really fully examine pain and its and therapies in patients, because we cannot stop the therapy that is opioids and start something new about which we don't know. So what we did was we tried to recreate the treatment paradigm in which is used clinically for treating pain in sickle cell disease. So we gave morphine for several weeks to these mice, and every few weeks we increased the dose of morphine and measured pain in these mice, which is called hyperalgesia in mice. And we tried to understand two things here. One is there an increase in hyperalgesia as morphine is used over a long period of time? And the other question was, is there analgesic tolerance when morphine is used over a long period of time? Analgesic tolerance is when the drug stops showing its effect, which means morphine given for some time was showing an effect and reducing pain. But when it's given for a longer period of time, it may not be effective. And that is called analgesic tolerance. So to understand these two, we then treated the mice. We started at a higher dose. You might be alarmed at 20 milligram per kilogram. But in mice, the dose required is much higher than humans, about 12 times higher. So the first outcome that we examined was survival. So we started giving mice morphine when they were about 5 months old. We chose to treat both normal mice without sickle cell disease and the mice with sickle cell disease in green here in the first graph. First of all, we treated them with vehicle. And what we find is that the mice, normal mice treated with saline and sickle mice treated with saline, showed a significant difference in survival. Sickle mice did not survive as long as the normal mice, and they started dying much earlier. And this is pretty similar to what happens clinically to patients with sickle cell disease. Next, what we did was we treated the control mice or normal mice with saline or morphine throughout this period of 600 days. And what we find that morphine-treated mice started dying earlier than the saline-treated mice. And there was a significant difference in survival. Survival was much lower in morphine-treated normal mice as compared to saline-treated normal mice. However, when we treated the sickle mice with either morphine or saline, we did not see a significant difference in survival. Both of them survived to the same extent, or they started dying to the same extent. Now, this could mean two things. One is that the sickle mice have a significantly reduced survival as compared to normal mice. And therefore, when they are treated with morphine, there is really no more increase in mortality. And but we do see that just like our cancer study in humans, when normal mice were given morphine, their survival was reduced. So this confirmed that at least morphine treatment in sickle mice did not reduce survival. And this was very good to know. And next we looked at what happens to hyperalgesia, which means that when a drug is given, say morphine is given, when it's given for a longer time, say 12 weeks or 4 weeks, does it increase pain? So here is a group of mice where we gave saline, just like as a vehicle. And after 12 weeks, we see that there was an increase in pain in these mice. But when we gave morphine, we start seeing an increase in pain just after 4 weeks of morphine use. And this increases further as the treatment continues, which means that morphine does increase the baseline pain in these mice. Well, that is not good. So then we wanted to see, when morphine was used for such a long time, does it still remain effective? On one hand, it does increase pain, but in spite of increasing the pain, when we give morphine, does it show a decrease in pain? And here on the top in blue line, we see that, that the pain over a period of time of 12 weeks, it was high. With morphine treatment, every time we gave morphine, 30 minutes after that, we see that the pain has decreased compared to the blue line. And this effect we show here for 12 weeks, which is a long time in terms of mice. And it just proves that morphine remains effective even after 12 weeks of treatment. Similarly, in the sickle mice, we see that there is higher pain, the black line, and after 30 minutes, it is reduced. And this reduction trend continues even after 12 weeks of use of morphine, that after 30 minutes, pain was reduced with morphine. So this suggested that morphine does not influence survival, does not cause tolerance, but it does cause hyperalgesia or increases pain. So we thought, what else can we do? So we tried to compare the opioids with cannabinoids or cannabis-derived or cannabis-based analgesics. And first we thought, what is the basic difference between the two from what is known until now? Morphine can cause myoclonus and seizures, nausea, vomiting, constipation, respiratory depression, pruritus, mast cell activation, and as we just saw, opioid-induced hyperalgesia. Whereas cannabinoids can act as anticonvulsants. It's used as an anticonvulsant in chemotherapy-induced emesis, antiemetic, and we don't know if it causes respiratory depression or pruritus. Actually, exactly opposite to morphine, cannabis causes mast cell inhibition. And hyperalgesia due to long-term use of cannabis is not known yet. So what we did was, we conducted a proof of principle trial for cannabis to treat pain in sickle cell disease. This was done in collaboration with UCSF, with Donald Abram. And cannabis was obtained from National Institute of Drug Addiction. It was a vaporized form of cannabis that we used, which contained THC and CBD in the ratio of 1:1. It was funded by NHLBI through a UO1 award. This was a randomized double-blind crossover trial in patients with sickle cell disease who were on opioids for chronic pain. We had 2 5-day inpatient admissions following a 5-day outpatient diary. Participants were assigned to either an active treatment which contained cannabis in the ratio of 4.4% to 4.9% THC CBD, or placebo, which did not contain either THC or CBD. A 1-month break was enforced between study periods, and blood collection was done before and after 2 weeks of discontinuation of treatment. Pain and associated effects were assessed daily. Short-term side effects were assessed, and circulating metabolomic analytes and cytokines were analyzed, which will not be presented today. The process of vaporizing should not be confused with vaping. So what we do is, this is called a volcano vaporizer, and the temperature can go up to 190 degrees C. The cannabis is placed on the top of the volcano, and then it's heated. This is connected to a balloon or a bottle. The vapors are connected in this balloon, and then this is tied, and we fill the whole balloon, and each time we use the same size balloon. So this way we can administer equal amount of vapors each time we treat the person with vaporized cannabis. This just shows here the concert diagram just shows how the patients were selected. 90 were actually assessed, and ultimately 23 completed both arms. 23, same patient completed placebo as well as vaporized cannabis. The study requirements were that participants had to be on a stable pain medication regimen for at least 2 weeks, which was opioids. They were required to have prior experience smoking cannabis. They should have discontinued cannabis at least 1 week prior to study admission. And we examined urine for the absence of cannabinoids prior to start of medication to confirm that they were not using cannabis at the time they were enrolled into the study. Cannabis was administered 3 times a day at 8 a.m., 2 p.m., and 8 p.m. Pain was assessed on a VAS scale from 0 to 100 every day, 2 hours after the morning dose inhalation. And the brief pain inventory was administered on day 1 and day 5. Side effects were evaluated constantly every 4 hours, or as if anything occurred, they would let us know. So what we found was that the overall pain during treatment in black line is the cannabis treatment, and in orange is the placebo. We see that the pain was reduced on all days from 1 to 5 while they were admitted, when the subjects were on placebo, were on cannabis compared to placebo, as we see here. And difference in pain rating score was always in the negative below 0, which means that they always had less pain than placebo. And when we compared the 2 ratings between the periods, when in period 1, when cannabis was given to half of the patients and half of the patients received placebo first. So we see that when the subjects received cannabis first, they again showed a decrease as compared to placebo for all 5 days. However, when cannabis was given in the second period and they received placebo in their first admission, we see an unpredictable outcome here. So, but overall, we saw a reduction in pain, at least for pain rating score, as well as for overall pain during the treatment. And then we looked at the pain interference ratings and compared day 1 and day 5. And we see here the negative side on the left shows less interference of these activities with pain, and the right side in the plus values shows that there is more interference with pain. And what we see is that as compared to day 1, on day 5, for all 6 parameters here, that is pain, general activities, mood, walking, normal working, sleep, and enjoyment, on day 5, there was reduced interference from pain with these activities, as we see here. However, none of these values were significant except for mood. The reduction in mood was highly statistically significant. So this again confirms that there is a reducing trend with cannabis, but it was not statistically significant. Then we also compared the subgroups between gender as well as in hydroxyurea treatment. And again, we see there was no significant difference between male and female, but we do see that in females, there was a greater effect of cannabis. Similarly, in patients on hydroxyurea or not on hydroxyurea, we do not see a significant effect, but those who were not on hydroxyurea showed a greater reduction in pain. Again, it was not statistically significant. These data were recently published by us in JAMA Network Open, and hope all of you can see it there. Regarding the adverse effects, we did not see any significant adverse effects between cannabis and placebo for different parameters that were examined: anxiety, sedation, disorientation, paranoia, confusion, dizziness, or nausea. None of these were significant compared to placebo. So we think that there is a potential for treating, for using cannabis as medicine. First of all, it shows that vaporized cannabis is safe. It can be used as an adjunct to opioids. It's good for mood elevation. It has been used as an appetite stimulant. It relieves nausea. We saw in this study that there was a reducing trend towards pain. Relieves stress, improves sleep. So considering all these, we feel that larger prospective clinical trials with specific cannabinoids and routes of administration are required. But at the same time, we have to beware of spurious over-the-counter and online available cannabis products. Those should not be used. And we have to confirm the reliability and validity of cannabinoids before use. And I say this because of recent literature and very well-known unreliable products such as fake cannabinoids or called fake weed. It was reported that cannabinoids contaminated with long-acting anticoagulant rodenticides have led to severe adverse effects in several patients, more than 100 in different studies. And there has been incidence of hospitalization and acute chest syndrome in sickle cell patient using K2 spice, which was used as a synthetic cannabinoid, but it is not actually a cannabinoid to be used or consumed by people. And then there is also the question of reliability of these so-called cannabinoids, which are being dispensed by medical dispensaries all over the United States. In California, several studies have shown that testing of several CBD products revealed only 15% were accurately labeled, with some products containing potentially hazardous solvent contamination. And in another study, 84 cannabinoid products purchased online, only 30% had accurate CBD and THC content, and majority had overlabeled CBD and underlabeled THC, all for obvious reasons, because THC can have psychosomatic effects or motor effects. Therefore, one has to be very careful about using these products. With that, I would like to thank my team, my collaborators at UCSF, Donald Abrams, Elliot Wyszynski, Niharika Dikshit, Bart Hager, Paul Kui, and Mary Ellen Kelly, and the study-associated staff. Most of all, I would like to thank the study participants who participated in this study in spite of any discomfort they might have gone through. And finally, I would like to thank NIH for their funding. And thank you very much for listening to me.
So thank you, Dr. Kalpana, for elaborating that very important aspect of pain, which is the most important cause of the morbidity of sickle cell disease, and such an innovative things. I am sure in the future these cannabinoids will come to the play, and so much of legal restrictions which are there across the world, it may be released to some extent it can be used as a medicinal thing. I think we can take up 1-2 questions because it's a morning, and I'm sure the Kalpana might go somewhere else, etc. Or there may be something, it is becoming too late here also. We can take up 1-2 questions quickly so far Kalpana is concerned. Just to begin with, Kalpana, let me ask one question to you. You know, the pain is considered one of the most important morbidity of sickle cell disease. And you know, the pain can be managed by various ways. One is controlling the pain directly by opiates or by cannabinoids or by other means by the or anti-pain medications. Secondly, if you address the primary pathophysiology also, the pain reduce significantly also. Like if we use hydroxyurea, if we use blood transfusion, if we use means to reduce the hemoglobin S level also, the pain also decrease even in acute setting also. So my question is, what is the relative importance of the addressing the primary pathophysiology vis-a-vis with the pain reducing the agents? So what is your comment in this regard? So for management of sickle cell disease is concerned, in reducing the pain.
Thanks, Dr. Jana, for that question. It's a very important question. And actually, as I said in the introduction initially, that some of these curative therapies are improving the quality of life, are improving survival, but they do not reduce pain. As Dr. Patel just showed in her slide, that there was a significant percent of patients who were still getting severe VOCs in spite of hydroxyurea. So when patients are on hydroxyurea, VOCs are reduced, but the chronic pain doesn't go away. They still continue to have chronic pain. And then what is happening is that with patients living longer, the chronic pain can start later, even when they are on hydroxyurea, and it continues for a longer period of time. So earlier the survival was shorter, now the survival is longer. So there is more chronic pain, which is not addressed. And so what I showed today was more about chronic pain rather than VOC. Now, we also have to distinguish between the two in the patients. VOC has a different pathophysiology. Chronic pain has a totally different pathophysiology, which we don't understand fully. We know that VOC occurred due to vasoocclusion, but we don't know how vasoocclusion really causes pain. How does it really coax the nociceptive system to get the perception of pain? So you are right. If we can treat it as the grassroots levels, that's the effort, is to understand where is this connecting link where the sickle pathobiology meets the nervous system and tells it to cause pain. And if we can actually cut it at that root cause, then there will be less pain. So you're right, there is voxelotor, which increases oxygenation. It improves red cell, it reduces red cell sickling, improves red cells, but none of them have actually looked at, none of these curative therapies have completely ameliorated pain. And we know crizanlizumab has excellent results, outcomes are great in their phase 2, and they show that, you know, the VOCs are reduced significantly. They're reduced, not completely gone. And in still a sizable number of patients or percent of patients, there were still VOCs. So we still require, and the patient population in sickle cell disease is very heterogeneous. We all know that. No two patients are similar, and there is a day and night difference sometimes. So we still need to control it. And the reason which I didn't show about cannabinoids is that they can also alter the sickle pathobiology. For example, they are antioxidants, they're anti-inflammatories, and they also inhibit mast cells, all of which play a big role in the pathobiology as a cause and consequence in sickle cell disease. So And the reason why I showed about cannabis is that many patients may just be using it in India because they get comfort and they can get it. But we have to make sure that they are not using spurious things which can harm them. And it doesn't take very long for anything that is developed here or going on in the United States to move to India as the awareness increases. So that is why we need to be aware of this, and that yes, if taken safely with a reliable product, there can be better outcomes. Does that answer your question, Dr. Jen?
Thank you, Kalpana. So any other question or comment from
Yes,
my?
yes. Could I ask something?
Yes, Dr. Mishra.
Yes, Kalpana, as usual, your wonderful presentation. I have just one question. As you know, that the Indian subcontinent has a lot of cannabis habituation and addictions. So what happens to the subset of people, those who are sickle cell disease and who are habituated and addicted to cannabis? Has their rheology of sickle cell changed in them inadvertently, even though they haven't taken it as a therapeutic medication, but they are being habituated to this agent? Has anything changed in them? Has any study happened in that respect?
Well, there are few studies where they have seen the safety of medical cannabis, different preparations, because the difference in medical cannabis, which is being dispensed here in the United States now to a large number of patients, is that those are purified or extracts, whereas what people are using in India is perhaps the plant product, which they are probably smoking. So as of now, as currently, we don't know in people what kind of rheological changes occur. But from the mouse studies, we know that there is reduced inflammation and reduced oxidative stress. But in the human studies, those analyses have not been performed. And that is something which needs to be undertaken. But these sickle mice that on which I showed the data are very much like the patients with sickle cell disease as far as pain is concerned. And their pathobiology is very, very similar. So what is seen in these mice has always almost replicated in humans. So it's likely that the cannabis will have some effect which is similar to mice in humans, but that remains to be seen. But that's a very important question that we all need to be very observant about, particularly with populations who are using cannabis. We should know that they are using it and also be watchful about any side effects which are not due to the disease, and they could be related to cannabis, and they should be reported in the literature. And I'd be very much interested in collaborating if any of you like to undertake those studies with patients who are using cannabis and what are their symptoms in relative to those who are not using them.
Okay, thank you, Kalpana. Any other question? We can take up one more.
Yes, sir. Dr. Patel.
Yes, Dr. Patel, please.
Ma'am, some patients coming sickle cell trait with pain without any other causes of pain. It is only pain or without any medical diseases. So, are you trying some hydroxyurea with the sickle cell trait patients?
Well, this is why it is one of the major comorbidities. They have no other symptom, but they have pain, and this can start very early.
Yeah.
And even in children, that they can get recurrent VOCs, and dactylitis can also be something like pain, because it's called neurogenic inflammation, that when they get these swollen and red and burning pain, fingers with digits with burning pain. With hydroxyurea, is Dr. Patel, if I'm understanding your question correctly, you're asking if hydroxyurea would reduce it?
In sickle cell trait patient, I am telling them.
In trait, some trait patients also have pain. And
without any other medical causes.
Exactly. They do not have any other. Yeah, and that can be perhaps it has to be treated the same way. We don't know how to treat pain, actually. As I said, we have no established therapy for sickle cell disease, period. And so in trait also, here everybody gets morphine. They've started giving ketamine to some who are intolerant, and duloxetine has shown some better effect. And in a mouse studies also, duloxetine was more effective when morphine is not effective. So there are some things in trials, but there are no clinical trials to prove any of these. But TRAID patients can be treated the same way. But TRAID patients do get kidney disease, some of them, some percent, but not all.
Kalpana ma'am, can I, sir, just one question from my side.
Okay, this is the last question. Okay, Dr.
Yes.
The last question.
Yes, sir. Thank you, ma'am, for the insight on the chronic pain. Just a question that, as Jenna sir also said, that if we treat the cause, so do you think that stem cell transplantation will be a solution to the chronic pain in these patients? Have you come across patients post-transplant who do not complain of pain?
That's a very good question again, and that has been a very big inquiry here. And a paper was published by John Tisdale and Deepika Darbari, I think a couple years ago or last year, where they found that in spite of transplant, because they had done a large number of transplants at NIH, that pain persisted. And the reason is, if it is neuropathic, as it is believed, upon QST in patients and also in mice, where we can see the direct nerve damage. If there is nerve damage, it cannot be cured. Now, there could be a subset of people who do not have nerve damage, and in those patients, the transplant, BMT or gene therapy can help. But it can be variable from patient to patient. And this has emerged as a very big question: how to ameliorate pain post-transplant? And that question remains. And there are efforts on the way to see how we can actually figure out if we can pre-transplant, we can start some kind of integrative approaches like mind, body, etc., so that patients are prepared and we can change their perception towards pain. So there are both: either there is nerve damage, which can cause persistent pain, which will not be ameliorated by transplant. This can happen in a subset. Or there is a perception of pain that they cannot forget about it. And that can be changed if we can start some integrative therapies pre-transplant.
Okay, thank you
so much, ma'am.
Thank you, Kalpana. We will edit your answer. Sickle cell always generates a lot of heat and interest among us. We will reserve many questions for next year in Kolkata. Once again, on behalf of Eastern Hematologist Group, we extend our sincere thanks and gratitude for really delivering such a wonderful space for the lecture on the pathophysiology of pain and how your new study, real cannabis, is being helpful. Hopefully, this new hypothesis will play a role so far, recommending a new modality of treatment, particularly so far the management of chronic pain, which is a very important aspect we miss on many often we miss. Once again, thank you very much for your wonderful speech and have a nice weekend. Thank you, Kalpana.
Thank you.
So now we'll move to our next speaker. He is Professor Abdul Kutlar. He is a professor of the medicine and director of the Center for Blood Disorders, Medical College of Georgia, Augusta University, USA. He has received, but he was involved, his entire career is involved with research in the sickle cell disease in the since the last 20 years from 2001, with so many phase 1, phase 2, phase 3 clinical trials related to sickle cell disease being funded by NIH and NHLBI. And he has authored 230 peer-reviewed publications and 3 book chapters. He has achieved so many awards, and one of the most important awards is he has achieved Lifetime Achievement Award for Medical College of Georgia in the year 2015. He has received Distinguished Faculty Award for the Clinical Research for the year 1997 and 2012. He has also received Excellence in Teaching Award of Department of Medicine in 1998. He has also received the Faculty of the Year Award of Department of the Medicine in 1998. With these words, we really, Eastern Hematologist Group is really honored to have you, sir, as a speaker. Now I request Dr. Abdul Kutlar to deliver his speech. His topic is the role of crizanlizumab in the management of sickle cell crisis. So Dr. Abdul Kutlar, please.
It's my pleasure to join you virtually for this meeting, and I would like to convey my deepest thanks to the organizers, especially Dr. Tupan Kantidolai and my good friend, Dr. Kalpana Gupta. I'm going to talk about the role of P-selectin in sickle cell disease and P-selectin directed therapies. These are my conflicts of interest. Now, as you know, sickle cell disease is the result of either a homozygous condition for hemoglobin S or compound heterozygosity for hemoglobin S and some other beta globin variants, such as hemoglobin C or beta thalassemia. The main event here, because of this mutation on codon 6, the polymerization of deoxyhemoglobin when it unloads the hemoglobin, and this distorts the red cell to the sickle shape. And even before that distortion, there is considerable polymer in these red cells, which negatively impact its rheology. And as a result, two things happen. One, these rigid cells obstruct the microcirculation. And secondly, because of repeated events of sickling and unsickling, these cells are destroyed rapidly with a lifespan of approximately 17, 18 days, as opposed to 120 days for normal red cells. So this is the typical features of hemolytic anemia. For many decades, this was considered to be the main pathophysiology in sickle cell disease. However, especially over the last 3 decades, there has been an increasing interest in downstream effects of this sickling. Now, it's important to point out that sickle hemoglobin polymerization upon deoxygenation is still the central event, and it's the sine qua non of the sickle pathology. But over the years, some of these downstream effects have been increasingly recognized to contribute to disease pathology. One of these is the adhesion of red cells to the white cells and endothelium, which results in activation of these cells with increased NF-kappa B activation, inflammation, vasoocclusion and ischemia reperfusion injury, generation of reactive oxygen radicals, which in turn damage the membrane, resulting in potassium loss, dehydration, hemolysis, resulting in nitric oxide scavenging, which further increases endothelial dysfunction, and finally, a hypercoagulable state generated by various factors, for example, phosphatidylserine exposure and decreased amounts of protein CNS and increased platelet activation. So all in all, this whole picture complicates the sickle cell disease pathology. Now, looking at the evolution of the concept of the role of adhesion in sickle cell disease, it wasn't until 1980 that Bob Hebel made the seminal observation that sickle red blood cells adhere to the endothelium. This was an in vitro experiment. Furthermore, he tested various patients and found that the degree of adhesion was directly proportional to the disease severity. In other words, the red cells from patients with more severe disease showed greater adherence to the endothelium and in vitro systems. John Harlan in 2000 put forth the idea that based upon these observations, there could be a potential role for anti-adhesion therapies in sickle cell disease. But it wasn't until the early 2000s that the mechanisms of this adhesion were elucidated, and these were primarily done in Steve Embury's lab, which I will talk about in a little bit, and thus established the role of P-selectin in sickle cell pathology. So this cartoon shows the role of P-selectin. These are circulating cells this molecule is P-selectin, the light red, and it binds to different cell types, including platelets and different white cells through P-selectin glycoprotein ligand, PSGL1, and to red cells through a PSGL1-like molecule. This is the first step of adhesion and rolling, and then other molecules such as IFM, VCAM enter the scene to lead to a firmer adhesion. And then in the case of leukocytes, this is followed by transmigration through the endothelium to locuses of tissue injury or inflammation. So the role of P-selectin, I just mentioned, that was mostly elucidated in Steve Embury's lab by Matsuya et al. And they showed earlier that P-selectin mediates sickle red blood cell adhesion to human umbilical cord, umbilical vein endothelial cells. And then subsequently that this adhesion could be totally blocked by monoclonal antibodies to P-selectin. This was followed by observations in Paul Frenette's lab that in sickle mice, red cells bind to adherent leukocytes in inflamed venules. And if they repeated these experiments in P and E-selectin deficient mice, they showed that these mice really were protected from vasoocclusion, and in that no adhesion and no vasoocclusion occurred in these mice. And in 2007, there was a publication from Saudi Arabia which showed that the use of low molecular weight heparin, tinzaparin, significantly reduced pain score, duration of crisis, and hospitalizations compared to placebo in sickle cell patients. Now, it's important to remember that low molecular weight heparins, or heparins in general, have anti-P-selectin effects. So this effect can be attributed to the anti-P-selectin activity of low molecular weight heparin. And then this was followed by a large body of evidence using different selectin blockades in sickle cell disease in terms of P-selectin. And Steve Embury used pentosan polysulfate. We did a trial with this which showed that the markers of adhesion were improved in sickle cell disease, but this was not followed up because it was found that it didn't have a significant impact in pain. And then the Saudi Arabian study I mentioned with tinzaparin, and Marilyn Tellen published observations with another heparin derivative, cevuparin, which showed in vitro experimental stages that this molecule blocked P-selectin and improved adhesion. But it wasn't until crizanlizumab that this was demonstrated in human trials, and I will talk about that in a little bit. Then, of course, there was pan-selectin antagonists, rivipansel, which is a small molecule that blocks the selectins altogether, P and E-selectin and L-selectin. A phase 2 study was published in 2015, and phase 3 recently completed, but the phase 3 did not show any improvement in the duration of established crisis. And now it's important to note that these trials were done in patients who were admitted with an already ongoing crisis. And then there were other molecules that were used as anti-adhesion therapies, such as IVIG and beta-adrenergic blockade in smaller studies or in vitro trials. Now, I mentioned the SUSTAIN study, which was the first large-scale study in humans. This was a 52-week phase 2 randomized double-blind placebo-controlled study of crizanlizumab, which is a humanized anti-P-selectin monoclonal antibody. After a period of screening, there were 3 arms. Patients were randomized 1:1 to either placebo, crizanlizumab 2.5 milligram per kilogram every 4 weeks, or 5 milligram per kilogram every 4 weeks. And the study duration was 50 weeks with an evaluation and assessment at 52 weeks. The way the study was conducted was initial loading doses were administered on days 1 and 15 intravenously. Following that, the administration was every 4 weeks up until 50 weeks. Conclusion. Now, inclusion criteria was sickle cell disease, and every genotype was included: SS, SC, S beta 0 thal, age 16 to 65 years, and subjects had to have experienced 2 to 10 sickle cell pain crisis events in the previous 12 months. Concomitant hydroxyurea use was allowed if the patient had been using it for more than 6 months and has been at a stable dose for more than 3 months. However, patients on chronic transfusion therapy were excluded. I have to mention here that this was a multinational study conducted in Americas, in United States, Jamaica, and Brazil. Now, these are the main study results. The medication was well tolerated. We will show the adverse events in a little bit, but end result was there was a 45% reduction in the rate of sickle cell pain crisis, annual rate, from 3 in the placebo group to 1.6 in the 5 milligram kilogram group, which was significant at a value of 0.01. In addition, time to first crisis after enrollment was significantly increased, as was the time to second crisis. And the median rate of annual uncomplicated crisis was also reduced at a significant level. Annual days of hospitalization was similarly reduced, but it didn't reach statistical significance. Acute chest syndrome could not be evaluated because there were not sufficient cases of acute chest in either group. Now, this analysis included all the patients and was intent to treat, and per protocol, patients were also analyzed based upon different genotypes, hemoglobin SS or others, whether they were on hydroxyurea or not, or whether their previous crisis history was 2 to 4 or 5 to 10 events in the previous 12 months. So here is the demographics of the ITT population. As you can see here, patients are well balanced between different arms. Majority of them were African American, very few whites or other nationalities, and the age was pretty close across the different arms of these patients. Now, in terms of the genotypes, hemoglobin SS was the most common, 70%. Now, I have to mention that this is very close to the distribution of different genotypes in different centers here in the United States. And about 2/3 of patients in all groups were on hydroxyurea, and most of the patients were in the 2 to 4 crisis group, about 2/3 again, and about slightly over 1/3 were in the 5 to 10 crisis group. So this is the number and proportion of patients who did not experience any crisis during the study, during the 50 weeks when they were on the study. Interestingly, the 5 milligram group, about 24 of these patients, or over 1/3, did not have any crisis. And, mind you, these patients were enrolled because they had to have 2 all the way up to 10 crises per year. Secondly, this is the event by previous crisis history. And obviously, more of the patients in the 2 to 4 crisis group were event-free during the study, but about 28% of those who had 5 to 10 crises per year also did not experience any crisis during the study while they were on the medication. This is a distribution of the efficacy between genotypes, SS and others. It turns out that in this SS patients, the other genotypes had a higher number that did not experience any crisis during the study, and was concomitant hydroxyurea use. It's interesting that if you look at that, more of the patients who were not on hydroxyurea, 40%, had no events during the study. This was about a third of those who were on hydroxyurea. And this is interesting and may reflect the fact that these patients had a better reduction rate due to the intervention compared to those who were already on hydroxyurea or may have experienced already some reduction. And this is again the distribution of events upon different number of crisis episodes in the previous year based upon intent to treat. Hydroxyurea use, as we saw in different groups. Now, this is a list of adverse events during the study. Majority of patients had at least one adverse event, and this was evenly distributed among different groups. The most common were headache, back pain, arthralgias, nausea, and some extremity pains, but these were not major enough to warrant discontinuation of the study drug. And these are the frequent serious adverse events. Pyrexia was observed in 2 patients, and 3 patients experienced pneumonia, which likely is not related to the study drug. So in summary, crizanlizumab at 5 milligram per kilogram was shown to be effective in decreasing the number of crises in sickle cell patients. And these benefits were observed in patients who had different genotypes or who experienced either 2 to 4 or 5 to 10 crises, or who were on and off hydroxyurea. And thus, these findings suggested that crizanlizumab at 5 milligram kilogram met an unmet medical need as an effective disease-modifying agent. Now, it's important to remember that a 45% reduction in annual crisis rate is even better than what was shown in MSH, multi-center study of hydroxyurea, which showed a 44% reduction. So this was probably the most efficacious disease-modifying treatment since hydroxyurea. And as a result of that, the United States FDA, Food and Drug Administration, approved crizanlizumab about a year ago in November of 2019, and it is now being used for the indications that were mentioned in the study. Thank you very much.
So thank you, Dr. Kotlar. I think he's there on. Hey, Loknath. Loknath. Sir. Am I audible? Hello? Hello?
Yes, you are audible. Audible, sir. Audible.
Thank you, Dr. Kotlar, for this wonderful lecture, and I must congratulate to you because you are the one of the most important person in designing and completing the SUSTAIN study and involving 60 centers in a wonderful way. And you and to the world, to the whole world, you have presented a new molecule which was thought by so many hypothetical, so many animal models. For first time in the phase 3 trial, you have given us, yes, it is beneficial. It can be used in sickle cell crisis. And we'll take up the two questions. And to start with, I have a query which you have already alluded during the speech. If you analyze on your three groups, one is 5 milligram group and 2.5 milligram group and the placebo group, and in the subset analysis of each group, say placebo group, if you see that those patients who are using hydroxyurea and those who are not using the hydroxyurea, the rate of the annual rate of the vasoconstriction crisis is more than the subset who are not using the hydroxyurea. This is one observation. And my second observation is that in 5 milligram group also, in subset analysis with hydroxyurea and without hydroxyurea, you find the vasoconstriction crisis are less without hydroxyurea. How to explain these observations? Dr. Kotla, please.
Yeah, that's a very good point. And I think what you're asking is the difference in event-free rates between those who were on hydroxyurea and not. As I showed in one of the slides, in the 5 milligram per kilo group, the ones who were not on hydroxyurea had a higher rate of event-free period during this study, as opposed to those who were on hydroxyurea. One way of looking at it is that the ones who are not on hydroxyurea did not experience any disease-modifying effects because they were not on hydroxyurea, whereas those who were on already hydroxyurea must have had some improvement, some disease modification, and on top of it, the crizanlizumab had some kind of an effect, but it was not as pronounced as those who one might call treatment naive patients in terms of the crisis.
Okay, my second question was, what was the dose of hydroxyurea which you have used in all the three groups? Is it a fixed dose, or you have used the maximum tolerated dose, or variable dose depending on the different centers? And
Yeah,
how
that's an excellent question. I think that there was no uniform recommendation. The hydroxyurea dose was left to the discretion of each participating center. And of course, some of them might be on a maximum tolerated dose, others were on a fixed dose, but we did not take that into account. So that was not uniform across the study population. You're correct.
Okay, and my third point is, you have so many approved drugs like hydroxyurea, red cell transfusion, L-glutamine, voxelotor, and now your crizanlizumab. What is the current status of crizanlizumab in sickle cell disease management?
Well, it's being increasingly used, and we're still monitoring the use. There have been some reports of pain crisis-like events after the use, but all indications so far do not really point out to the fact that this was a real crisis, but rather sort of an exaggerated infusion reaction, which is commonly seen in any other monoclonal antibodies used in therapeutics, whether it's rituximab and so forth. But so far, it's being increasingly used. Now, what the magnitude of the effect is in actual clinical practice outside of a study remains to be seen, because we've only had about 1 year of experience in the United States with this drug.
Okay, so any other question or comment from the others, from my colleagues? Any other question or comment? Okay, since there is no other question, comment, I once again thank you, Dr. Kotla, for your wonderful speech. And again, once again, we really congratulate you, being one of the pioneer and important person in designing such a wonderful study. We call it sustained study.
Thank you very much. That's very kind of you. It was a pleasure and honor for me to be in this meeting. Thank you.
Okay, thank you very much. We'll end the talk here. Now we'll move to the panel discussion, and now I invite the moderator of the panel discussion, Dr. Priyanka Samal, to introduce. It's always an honor and pleasure and to introduce her. She is now the professor and head of clinical hematology department and bone marrow transplant unit of Institute of Medical Science and Sam Hospital, Bhubaneswar. She did her DM from medical college in hematology, clinical hematology. She is young, dynamic, and really very spark and lot of momentum to carry forward the development of hematology inside across the Odisha state and across the India also. With these few words, I invite Professor Priyanka Samal to take over the charge of this panel discussion and invite and introduce the panelists and complete our panel discussion. So, Professor Priyanka Samal.
Thank you, sir. But please, I will always remain a student for you and teachers. Tufan, sir, I am mobilized that you have given me this opportunity to have this moderation in the session. And I invite my panelists for today. She is Dr. Sudha Sethi, Assistant Professor in the Department of Clinical Hematology at SCB Medical College, Cuttack. Dr. Ashutosh Panigrahi, he is Assistant Professor in the Department of Hematology and Medical Oncology at AIIMS Bhubaneswar. Dr. Subranil Ball, he is Assistant Professor, Department of Clinical Hematology at NRS Medical College, Kolkata. And Dr. Ankita, she is my junior and she is a consultant hematology at AMRI Hospital. So, and she is also a senior resident at NRS Medical College. So I'll start sharing my screen. Just a minute.
Yes, doctor. Now you can share the screen.
Yeah. So we will have a case discussion. First of all, thank you for that very lucid description of sickle cell disease, the presentation in Odisha by Dr. Patel, and then about the chronic pain. Definitely one of the things which the sickle cell patients, the most common complication of the sickle cell patients, but least known about. And then the crizanlizumab, the new drug which is in the armamentarium, and in India also Novartis is getting up with the name of Riverna. So a lot of changes in sickle cell disease in 2020, and we are stepping into 2021 with a new drug in our pocket. So let's start with the case discussion I introduced. So case 1, this is a 23-year-old female.
Doctor, your screen is not visible.
But I'm able to share it from my end.
Do you want me to share it? I can share it.
Just a minute. Just a minute. Are you able to see now?
No, now it's visible, doctor. Make it full screen.
It's visible, right?
Yeah, it's visible. Make it full screen.
Yeah, she is a 23-year-old female, visited to the local physician with a complaint of severe pain. There was no sign of trauma-related injury. Significant skeletal-muscular pain on and off she has been saying since her childhood. Abdominal discomfort with fever on and off. She was recently operated for cholecystectomy 2 months back. There was also a history of hip surgery 9 years ago. No history of jaundice or any other chronic illness. And on examination, there is a mild splenomegaly with pallor. Hemoglobin hovers around 8.5 gram %, TLC within normal limit. And when we did an HPLC looking at gallstone and hip replacement and the pain she is having, hemoglobin S percentage was 62.2% with a fetal hemoglobin of 15.7. So my question to Dr. Sudha will be, would you like to have any other investigations in this patient at the outset?
Good evening to everybody, and thank you organizers to give me this opportunity. This case is a 23 years female with severe pain and operated for cholecystectomy. Hip surgery has done 9 years back, and now her hemoglobin is 8.5. HPLC is hemoglobin S is 62.2, and fetal hemoglobin is 15.7. So I think we'll do. This is a case of hemoglobin SS or sickle cell measure.
Yes, madam. Would you like to do any, since we know that it is a sickle cell disease and we find that these are the complications, having some end organ damage, patient is 23 years old, would you like to have any other investigations done, or you would like to start management directly in this patient?
only thing we can do DCT.
Yes.
And will the patient is in pain and fever, we can start treatment.
Dr. Ashutosh, would you like to add upon something?
Yeah, definitely. The most common complications, that is vaso-occlusive crisis that leads to end organ damage. So definitely whenever we see a patient with sickle cell disease, we'll definitely evaluate what the other organ involvement. Accordingly, we investigate. Second, we do a extended phenotype blood grouping. That is because he may require a further transfusion. Next, agent-specific preventive measures, means organ-specific preventive measures like retina examination, then transcranial Doppler, whichever is available at your institute, that has to be done for this
Yes.
patient.
Dr. Subranil, would you like to start therapy at the outset? Is Dr. Subranil on board? Yeah, Dr. Ankita, can you take up the question?
Dr. Sunuril has not joined yet.
All right, Dr. Ankita, can you take up the question?
Yes, good evening, everyone. And firstly, let me thank the organizers for giving me this chance. So coming back to the case, I would just like to add with regards to your previous question that we should also do certain more baseline tests as well, like echocardiography and blood test baseline for renal function tests, LFT, CBC, just like my previous speaker pointed out, so we can plan which way and what treatment would be more specific, since the patient is already demonstrating certain signs of end organ damage. And accordingly, we'll of course proceed firstly with our target would be to reduce the sickling, definitely. And for that, in addition to hydroxyurea, we have numerous other drugs which have already been discussed.
Yes,
So
we will come to that. Okay, thank you, Ankita. So definitely the patient is in pain. First and foremost important thing is to manage the pain and then look at the organ damage, whichever is available at your center and whatever you have the amenities to do with, starting from the retinopathy to the TCT, for the stroke or an MRI if a patient has a history of stroke, hepatopathy by an LFT, gallstones, already the gallbladder has been removed, just a urinary to see whether there is isostynuria, and you look at the TB echo as Dr. Ankita mentioned, along with the other, if the patient is having other complaints, then we go for the other specific tests. So next is, how do we define pain? Dr. Kalpana had actually very well demonstrated about the chronic pain, and this year in ASH 2020 we have a very good article with the updates on acute and chronic pain. So painful vaso-occlusive crisis, may I know from one of the speakers, how do we define this painful vaso-occlusive crisis? Dr. Ashutosh, can you please enlighten about the painful vaso-occlusive crisis?
Because as we know, pain in sickle cell disease is an acute pain when we see the patient in emergency setting, but most of the situations they are pre-treated at home, so it is very difficult to assess the pain. So, and the pathophysiology of pain in sickle cell disease is also a tricky one. So it can be an acute pain or a chronic pain. But whatever may be the acute or chronic or acute pain, whatever pain perception patient describes, unless otherwise disproved by other etiological factor, it should be regarded as a painful vaso-occlusive crisis and should not be neglected and given utmost importance how to manage the pain and how to prevent it. So definitely all painful episodes complained by a person with sickle cell disease should be regarded as a painful episode.
Yes, that was very well mentioned by Dr. Ashutosh, that whatever pain the patient presents with, when we have excluded the other causes, should be taken as a painful vaso-occlusive crisis of a sickle underlying sickle cell disease. So this is how we actually, a visual analog survey scale is the scale by which we quantify the pain, and most of us are well aware that this is present in our case sheets as well as in the OPDs, so that we understand that what is the degree of the pain patient is having, and once we administer the drugs, how the pain is decreasing and what is the rate of the pain decreasing, whether we need to put on other analgesics or add on other analgesics. So what is our approach? Dr. Subranil, has he joined?
Yes, I am online.
Yes.
Hello.
So yeah, you're audible. Yeah, this question is to Dr. Subranil. How do we manage the pain in our setting? What is your way of managing the pain of a sickle cell patient in your OPD or in your IPD?
Yeah, that's true. The pain is an emergency, and every pain has to be treated with an opioid analgesics as quickly as possible. And depending on the severity of pain, patient needs to be hospitalized. But practically, Priyanka, I will tell you my experience with sickle handling was when I was trained in Orissa. Right now, I have been Kolkata, and here we get a very few physical patients rather than I get few in my private practice. But I treat sickle pain as an emergency with the analgesia, which is preferably opioid analgesia, hydration. I do not institute transfusion immediately. I wait for a few days, checking the hemoglobin status. And next is other things like you have mentioned about sedation regarding non-pharmacological approaches, which I don't practice often. I rely more on the opioid analgesia and hydration.
Thank you so much. Okay, Dr. Sudha, what will be your approach in a patient in the OPD as well as in the IPD? Yes, Dr. Sudha. Madam, are you there? Dr. Ashutosh, would you like to put in something more to it?
Actually, opioid analgesia is recommended everywhere. Practically, it is not available. And at midnight, we do not get a opioid drug. So, but luckily now what we have practiced here, we have indented some opioid drugs that is under control by two of the faculties. So we are issuing in emergency only. And next, most important, what we do is hydration, making the patient calm. Then whatever analgesia is available with us, excluding morphine, other morphine substitutes. Then if there is acidosis or associated infection, we try to control it. And once the patient is stabilized, we start with hydroxyurea. And next, even if after all the treatment, if the pain is not controlled, we start either exchange transfusion or a top transfusion, which is indicated for this patient.
How often do you use analgesics like NSAIDs? Dr. Ashutosh, how often do you use analgesics like NSAIDs?
Yes, if the renal status is normal, we don't hesitate to control pain because we don't have opioid in our hand in emergency and all the time. So we use NSAIDs, but we try to reduce the use as long as possible. So if at all we use analgesic, it is as and when required basis in severe pain cases.
So our practice in the institute is first to start with the tramadol, nalorphine, and then with the buvalor patch, and then if it is still not controllable with the dinapar, that is the you have the diclofenac if the renal status is all right, and we do have morphine, and we keep it in emergency. Even in our emergency department it is available, but definitely we have to be very careful regarding the use of morphine because since ours is a cancer institute as well as sickle cell patients are there, many a times we run out of stocks, no doubt. So this is a question to Dr. Kutler.
Can I add one?
Yeah, madam. Yeah, yes. Sure.
If after these measures, if sickle cell pain is not relieved, then we add sedatives at
yes,
14 phenargan, and also oxygen inhalation to maintain SpO2 more than 95%.
Yes, madam.
And
Agreed.
obviously you have to address the underlying pathophysiology. And here the patient is having fever, so definitely we should add antibiotics. Yes.
Okay, madam. So this is a question to Dr. Kutler. Sir is there with us?
I think Dr. Kutlar is not there.
Okay, sir. Okay, sir. So next is the role of transfusion in this scenario. Already it was stated by Dr. Ashutosh that even if after the above measures the pain does not subside or the patient complains of pain, but there is no complete subsidence of the pain, we definitely think about a top-up transfusion if the patient's hemoglobin is less than 9 gram percent, and if it is more than 10 gram percent, we think of a exchange transfusion. So
yes, guideline 2020 for adult and children sickle cell, that suggests there is no recommendation for monthly transfusion therapy. So when all measures to control recurrent pain episodes have failed, like hydroxyurea or other disease modifying therapy, then only we can do transfusion. And some unique circumstances like stroke, silent stroke, abnormal transdoppler ultrasound, or in pregnancy.
So another question is, when a patient comes like this and the patient is having a fever but still having pain, would you like to start the patient on hydroxyurea when you start these analgesics, or you would wait for the things to subside and then start hydroxyurea?
Actually, hydroxyurea also causes fever, but at this time we can start at a time antibiotic and hydroxyurea.
Dr. Ashutosh, what is your practice?
My practice, and also I think BCSH recommendation also, during acute episodes after stabilization of the patient, start hydroxyurea. So we also practice that one.
Okay. So next is, this is what we discussed, decision to start hydroxyurea. Should we, and what is the benefit? We all know about the benefits of hydroxyurea. So though it has a lot of benefits, it has very few side effects as related to the patients when used in patients with sickle cell disease. And since the outcome with hydroxyurea is very good, we have been knowing it for last 20 to 30 years. Therefore, hydroxyurea remains the mainstay of treatment in all the patients diagnosed as sickle cell disease. So patient was given hydroxyurea with a starting dose of 15 milligram per kg for 6 months. Her pain episodes decreased but not fully subsided, and she developed some GI symptoms. So repeat HPLC was done after 6 months, and it showed increase in fetal hemoglobin with an increase in hemoglobin A percent and decrease in the hemoglobin S percent. So with having this as the presentation at 6 months, would you like to escalate the dose of hydroxyurea at this time point? Dr. Ankita?
No, I would not like to increase the dose, especially because the patient seems to have responded and he also has some level of GI disturbances. So no, I would not like to escalate the dose.
Okay, so then the patient is lost to follow up for 1 year. She continues to be on the same drug with the same dosage. Patient comes back with severe pain, anemia, and leg ulcer, and developed a higher level of serum creatinine, possibly with a kidney injury. Patient had around 6 episodes of pain affecting the joint and abdomen during 1 year, but managed with IV NSAIDs locally and acetaminophen, and possibly because of this, there was a rise in the serum creatinine. During last 1 year, she received 1 unit of blood transfusion, and she has not been taking hydroxyurea for last 1 year. So like after, when we went back to the patient and we interviewed that whether she was taking the drug in the proper dosage which was advised to her, she admitted that she has not taken it for last 1 year. So do you see patients with normal hemoglobin level not requiring blood transfusion who are having recurrent ongoing pain even after hydroxyurea therapy in your clinical practice? Dr. Sudha, would you like to take up the question?
Yes, actually most of the patient they maintain hemoglobin level, and they have very they are not complaining of pain, but 20 to 30% of the patients they are in spite of taking hydroxyurea, they complain chronic pain. As we have already discussed, Dr. Kalpana Gupta already told that there will be chronic pain which will be there, and that is the thing we are experiencing also.
So what would you like to do in this type of a patient? Would you like to increase the dose of hydroxyurea therapy even after this, or you would like to add upon a second drug?
If the patient is tolerating the maximum tolerated dose or
No, she
35
hasn't. She has been on 15 milligram per kg.
Yes. In this setup, we can escalate the dose.
But she also complains of leg
Kidney,
ulcers.
yes, leg ulcer and also
kidney
increased
injury.
creatinine. So we can in this setup we will try new drugs as new drugs are coming. And
Yes. So
three more
previously we
drugs
did
are
not have
already.
much of options with us.
Yes.
We were thinking of going ahead with hydroxyurea. Previously, what we used to do in our setting was we used to look at the hemoglobin S level. If the hemoglobin S level continues to be elevated, we used to give simple transfusion or a top-up transfusion, exchange transfusion, and increase the dose of hydroxyurea till the symptoms subsided or were controlled. But now, because there is advent of these new drugs and possibly these are very costly now, and in near future when the cost come down, possibly when we give combination of drugs, these patients are the ones which are challenging to us, and definitely they would be benefited with the addition of a second type of drug. So we know that. Yes, ma'am. So these are the side effects, but we find, how often do you find these side effects in the patients of sickle cell disease in your practice with the hydroxyurea a dosage of 1500 mg per day? Have you have any of us over here in the panel have gone up to 1500 mg of hydroxyurea per day?
1500? No. No, we have maximum give 1000 per day, not 1500.
Okay, so this is what, if we go according to the guidelines, the BCSH guidelines, they mention up to 35 milligram per kg is the tolerated MTD dose. This is the Western literature data. We do not have much of data from India, though we know the lower data, which is 10 milligram per kg, but nobody has published regarding what is the maximum tolerated dose in our patients. So most of us are practicing at a cap of 1000 milligram per day, and we hardly find any of the side effects among these. I suppose these are the effects which are the outcomes at a much higher dose. So suggested treatment for this patient was transfusion support to tide over the complications which the patient was facing, restart hydroxyurea at the dose which she was tolerating, and then after the thing subsided, it was escalated to 20 milligram per kg, but patient again came back with a leg ulcer after 1 month. So we already discussed that in these cases, the newer therapeutic agents like risanlizumab are definitely new therapeutic options. And these are the ones which are the new drugs in the armamentarium: L-glutamine, risanlizumab, or Riverna, which is available in the name in India, voxelotor, and transfusions have been our old-time friends in handling these cases. So this is what, since 1949, when the sickle cell molecular basis was discovered, till 2017 and in 2020, we have this drug with us now in India. These are the ones which are FDA approved. And one thing to mention about the baby hug trial, this was the trial which actually said that children or the infants with at an age of 9 months can also be started with hydroxyurea to have the advantage of this drug at an early stage, so that they do not land up in crisis or dactylitis, which is more common in the children or the infant age group. We know about this. Dr. Putler have said about that. The voxelotor, it is an HBS polymerization inhibitor, another mechanism of action different from that of the P-selectin inhibitor or hydroxyurea. L-glutamine, we have heard a lot from Professor Jenna regarding his use in L-glutamine in sickle cell patients and how he has been benefited. Though there are a lot of supports, data which supports that L-glutamine in sickle cell anemia has ameliorated the symptoms of sickle cell, but then still the clinical benefit is speculated to derive from the decreased susceptibility. None of the clinical trial show any improvements in hemoglobin or retic count. There seems to be no readily appreciable diminution of hemolysis, and there are multitude other roles of glutamine which needs to be considered. Since it is an antioxidant and has a good role in increasing the life or the survivability of the RBCs, still it has a role in sickle cell disease. So these are the new drugs having a lot of mechanism of actions. And this was what Dr. Kalpana actually mentioned about lot of new things in 2020 guidelines regarding management of acute and chronic pain. And with this, we move on to the next case. This is a 37-year-old female from Sambalpur district, complains of weakness and jaundice 6 days postpartum. She stopped hydroxyurea prior to pregnancy, received 5 units of PRBC during the antenatal period and 8 units. That means she was heavily transfused during her first pregnancy. Post-pregnancy, she was again restarted on hydroxyurea, and you can see how well she has maintained the hemoglobin of around 8 gram per cent. Then during her second pregnancy in May 2018, she again received PRBC transfusion during her pregnancy time to support the pregnancy. And then during the time of her LSCS, she required 4 units of blood transfusion prior and 6 units after delivery. Again, post-delivery, immediately she was started on hydroxyurea with 500 mg TDS dose, that is 1500 milligram OD. So 10 days post-delivery, again she got admitted with hemoglobin of 3 gram per cent. The whole idea over here to say is that she was started on such a higher dose because even earlier it was seen that after transfusion she was not maintaining her hemoglobin. So then we worked her up. She was admitted with us. She was worked up. Liver and spleen. You can see the liver was 2 centimeter and spleen was very much enlarged. Apart from that, she was febrile. CBC 3 gram per cent, TLC 5100, NRBCs were there, retic was 26%, total bilirubin 11.73, and ferritin was high, B12 was low. She had bilateral infarcts in the upper ends of tibia, upper abdomen, huge splenomegaly, and previous HPLC report showed HBS was 84%. Those were the ones which were prior to transfusion. When we investigated in the blood bank, DCT was 3+ and 4+, because when she came to us, hardly there was any blood which was properly matched. Autocontrol was positive, antibody screening positive in 3-cell panel, and then antibodies were detected against these 3 antigens. So from the blood bank, they issued the least incompatible blood. Along with that, they had mentioned that these blood groups should not be mentioned. So advised for extended phenotyping of the RBC. So with this, she was diagnosed actually as a homozygous sickle cell disease with both auto and alloimmunization, delayed hemolytic transfusion reaction, hyperhemolysis, splenic sequestration, VOC infarcts in bilateral knee, hepatopathy, hypothyroidism, vitamin B12 deficiency, and sepsis with Klebsiella pneumoniae. The whole thing actually I wanted to bring up is sometimes we really find such difficult cases with a hemoglobin of 3. You do not find any proper blood transfusion to give to the patient, and it's very difficult to manage. So I would request Dr. Sudha to give her insights regarding how to manage this case.
Actually, this case is really a very critical case, having both auto and alloimmunization and dilated hemolytic transfusion reaction with hyperhemolysis and also splenic sequestration and VOC, and with infarct in knee and hepatopathy. All complications are there, and along with the hypothyroidism. So we first, the patient has already started hydroxyurea in high doses. So we have to load the dose, and then first give supportive care. Then we'll start immunosuppression with immunosuppression, usually with corticosteroid or IVIG or rituximab, and then least match blood transfusion, and you have already started IV salometrol 1 milligram per 1 gram OD for 3 days, and so.
Yes. So
Dr. Priyanka, Shubronil here. Hello.
Yes. Yeah, sure.
So this is in this I want to differ from Sudha madam a bit. Solumetrol is choice of therapy in alloimmunization, but I would prefer IVIG because you have Klebsiella, which is carbapenem resistant.
Yes.
Right, and sepsis is be a very severe issue to manage if you want to save her. Thank you.
Yes.
Okay. And
this
Dr.
is a
Ashutosh?
good point.
Yeah, I also agree. But in such a sick patient, when you are one of my option is since auto allo, I can consider if we can go ahead with a plasmapheresis here. So that
When
is
the hemoglobin is 3 and you are not getting anything, you cannot start plasmapheresis because at this low hemoglobin, the blood bank will never support and allow you to do a plasmapheresis.
that I know. But I'm adding the option what can be done for this patient. That is one option. Second is solumedrol, combination of solumedrol or IVIG. That may be an option. But solumedrol alone can give a good hemoglobin rise.
Good result. Right.
Good result. But I can consider also combination of solumedrol and IVIG.
Yes.
This
So
may
we
be the
started
option.
with we started immediately with IV solumedrol 1 gram for 3 days, and then the hemoglobin was at around 5.9 gram % under the coverage of antibiotics as per the Klebsiella. Klebsiella showed its culture and sensitivity. All the analgesics were given, and after actually first 3 units which had been transferred in as an emergency procedure, we tried to avoid any further transfusion to the patient because C remains asymptomatic even at a hemoglobin of 5 gram %. However, see, this was the cost in our therapy. Being a private hospital, the cost is very high even without an IVIG. I definitely agree that with solumedrol, if it would have not responded to
Increase.
it, we would have increased, then we would definitely have added IV immunoglobulin to it. Her
Yes,
second
another thing
admission,
is just one second.
Yes, ma'am.
Can I? Yes. After stabilizing the patient, we can add erythropoietin and IV iron to increase her hemoglobin.
Yes, ma'am. Definitely, we can think about that. Since he had a very huge splenomegaly, therefore we didn't start with erythropoietin. And with sickle cell patients, also in this sick condition, they are very prone to have thrombosis. So one
Yes,
of the things,
after stabilizing the
with
patient,
stabilization,
then, yes,
definitely this
for,
is also an option to have a higher hemoglobin without exposing the patient to second further transfusions. So again, she was admitted with us with a hemoglobin of 3.3 gram %, restarted since he had a response with solumedrol. She was again re-challenged with that, and then we started on rituximab weekly for 4 doses. And post this therapy, she has been well, and she herself adjusts the doses of hydroxyurea as per her need of maintaining a hemoglobin. So her adherence and her from her side the manipulations, we definitely, she knows more than us, and she is on 1500 of hydroxyurea as per now also.
one question, Priyanka, can I ask?
Yes, ma'am.
If we would have been given 100 milligram of rituximab for 4 weeks, could it be possible?
Madam, it is there in AIHA as well as in ITP, low dose rituximab. But what we have seen in our patients of ITP and AIHA, the relapse rate is higher with the 100 mg dose. So therefore, we tried to avoid the 100 mg dose as the patient is very challenging. And again, if she lands up with a hemoglobin of 3.3, it will be difficult for us to manage at that point of time, thinking that we had compromised the dose. Otherwise, I do not know in sickle cell, but in AIHA, definitely 100 mg is also a recommended dose.
Yes.
So this is regarding the transfusion support in sickle cell. And the next question, this is to Dr. Ankita. 22-year female, nurse by profession, hemoglobin SS disease on hydroxyurea 1000 mg per day since May 2019, presented with recent onset seizures. She maintains a hemoglobin of 8 to 9 gram % with hydria of 1000 per day. TLC is 6500 and platelet 1.5. She has a history of tuberculoma in 2010, for which she was treated with ATT for 9 months. Presently evaluated by the neurologist, and MRI showed frontal lobe gliosis. EEG showed abnormal NREM 11 sleep, suggestive of right anterior temporal epileptogenicity focus. She is presently on levetiracetam 500 mg BD as advised by the neurologist. And post hydroxyurea, this is just a chart to show how hydroxyurea has added up to her hemoglobin %, and she has been maintaining it for last 6 to 8 months before she presented with seizure. So how would you like to manage this case?
So for this patient, so she already has a history of tuberculoma and now a recent onset seizure. So that could mean either of two things, that either she has stopped responding to hydroxyurea and there is another episode of ischemia or stroke, and that has led to this, or there may be a resurgence of the infection. So in
just to add upon, she is presently evaluated and the MRI shows no evidence of infarct. There is only frontal lobe gliosis.
Right. So in this case, perhaps we could rule out that there is a recent onset infarct or stroke. So in that case, symptomatic management as started by the neurologist, and we should monitor her closely. And at the moment, because it doesn't seem to be related to the disease of sickle cell per se, and maybe this is something different. So I would not like to change hydroxyurea as such. So possibly in collaboration with neurologists, a symptomatic management for this case.
Any of the panelists would differ, or everybody goes with Dr. Ankita?
I think she's right. I think she's right. One thing we can add, in addition to hydroxyurea, seizure and frontal gliosis, probably there is subtle cerebral infarctions are going on. So we can think of adding to a transfusion protocol for this patient.
Yes, I also.
Yes. So we discussed deeply with the neurologist, but he said that there is no, as well as with the radiologist, they denied that there is any evidence of silent infarct or any sort of a lesion which we could attribute to sickle cell disease. So based upon that, we just carried on with whatever the neurologists have advised, and she's keeping a very good with hydroxyurea, the hemoglobin and the TLC is being maintained. So we just had to advise her to continue with hydroxyurea, but any point of time on this therapy, if she again develops seizure, we would think or attribute it to a SCD after undergoing an MRI or an evaluation with a
I can add something. I can add something here.
Yes.
If transcranial Doppler is available, we should go ahead with that.
Yeah, that is not available with us. That is not available.
That can support our neurological status, or at least a carotid velocity also can be a surrogate marker whether we are going to do anything else for this.
Yes. So now these are some common questions. What are the causes of hydroxyurea failure? Dr. Subranil?
Due to lack of adherence, due to lack of adverse events, which is very rare, and mostly patients forget to take their medications, and sometimes also the patient also don't want to take a therapy continuously. So these are the common reasons.
So there was a very good article, intentional and unintentional non-adherence to hydroxyurea therapy among patients with STD. So 78% did not start hydroxyurea therapy according to this literature. Those who used hydroxyurea, average number of days were only 190 of the 365 days. Those who collected supply of at least 300 days in a year were only 15% of the cohort. Adherence was least in the elderly sicklers. Although younger patients were more compliant, their adherence was also significantly low, thinking that it was a cytotoxic drug. So this is the US data, and it was presented in this, depicted in this literature, where in US also, even after so much of counseling, only 25% of the population of sickle patients adhere to taking hydroxyurea. We do not have this figure out in India till now. And adverse events, as said by Subranil, these are very less encountered in our patients. We do not find them much, and maximum is the skin or the hyperpigmentation of the skin or the nails, which is very well counseled. If you counsel the patients well, then that is also taken care of. So,
Priyanka, I'm Subranil here, but you have been here in Kolkata also. The adherence in the E-beta group is quite fantastic, right? You will agree?
Yeah, that all depends. Actually, I would even like to thank Novartis that now a lot of awareness is being created for the sickle patients. Previously, it was for the thalassemia patients, right? Starting when the patient first visits to you, we counsel regarding a stem cell transplantation for thalassemia. But for us over here also, we find that much of awareness is not there among the sickle patients. So counseling definitely plays a lot of role. So how do we define failure? Sudha madam, can you tell us how do we define hydroxyurea failure?
If the patient is complaining pain, and in spite of in spite of taking hydroxyurea, there is a continuous complaint of pain, and hemoglobin is not rising or up to the optimum level. And
yes, so actually this is a definition which has been given by the British Society of Hematology. You can go into that 2018 guidelines for hydroxyurea. This is how we define it. A failure to respond to hydroxyurea is defined as failure to reduce the frequency and severity of the VOCs or acute chest syndrome. Failure of response should be based on clinical criteria rather than on just the lab data. A significant proportion of failure is due to non-adherence or failure to escalate the dosage to the MTD. I suppose we are not utilizing this MTD dose till now. We are capping up the doses, thinking that the patient is unable to visit to us frequently to look at what are the cytopenias he is experiencing. And that is why we are not able to take up the maximum tolerated dose. So what are the actions to be taken? Yes, ma'am.
Can I interrupt? Well, actually, our patients are far off. They are
Yes, ma'am. Yes, ma'am. That is what I am saying. That is why we are not able to take up to the maximum
we are very
dosage.
comfortable with the low fixed dose.
Yes, ma'am.
Right.
So actions to be taken, we need to check the adherence, maximize the dose as per the tolerance, resort to frequent blood transfusions if the patient do not optimally respond to the dosage of the hydroxyurea, treat VOCs optimally, hematopoietic stem cell transplantation, very easily said, but very difficult to execute, add or substitute hydroxyurea with Riverna or crizanlizumab. So this patient was suggested to continue hydroxyurea with the optimal dose, whatever the neurologist suggested, we carried on with it. So this is what I was talking about. This is a very good article, guidelines on the use of hydroxyurea in children and adults. And there is just one recommendation. In children or adults with a previous history of acute ischemic stroke or infarct, hydroxyurea should be recommended as a second line of therapy for secondary stroke prevention when transfusions are contraindicated or unavailable. However, there is insufficient data to advise commencing or starting hydroxyurea therapy for primary stroke prevention in adults. Since we see a lot of sickle patients in our domain, that is a take-home message for us. So this is the case for Subranil, 19-year-old male and engineering student. This is the last case. Double heterozygous for sickle vita, presented with limping for 6 months. MRI, it is AVN of left femoral head. Facets, the Fickat stage is 4. Left hip joint is normal. Hemoglobin is 12.5 gram percent. HbS is 68.4%. Hydroxyurea 500 mg OD for 18 months he is on. So this is the X-ray. You can see over here completely, the head of the femur is completely destroyed, and this needs a definitive therapy. So Subranil, how would you like to treat this patient?
So this is avascular necrosis of femoral head, and based on the scoring system that we used is that is less than 15 to 30, more than 30%, and here it is more than 30%. The head of the femur is destroyed. So here we need an orthopedic intervention. We need a hip replacement.
Yes, so his hemoglobin is 12.5. How would you like to go ahead with a HbS of 68%?
Hemoglobin.
Over here I would like to give you an option. Would you like to increase the dose of hydroxyurea and wait for the sickle percent to come down, or would you like to go with the exchange transfusion and ahead with the hip replacement?
I will go with increasing the dose of hydroxyurea. Level of HbS should come down, and then I will go for hip replacement.
But Subranil, it will take a lot of time to decrease the dose of hydroxyurea, and even then you will not get it less than, because this surgery will take more than 3 hours.
Yes.
And for the recommendation is, if a surgery requires more than 1 hour, then you have to exchange transfuse, get the level down to 30%, HbS level down to 30%, and then you go ahead with the total hip replacement of this side.
Yeah, he needs total hip replacement. That is no doubt for sure.
Yes. So these were all the cases. Actually, these are the cases in our department, and that is our experience. And concluding the talk, the discussion, sickle cell disease is quite different in India. Pain crises lead to end organ damage, no doubt. Vaccination is also an important part to decrease the number of the VOCs. In spite of hydroxyurea therapy, some patients develop side effects and suffer with recurrent ongoing pain episode, and which is one of the most difficult things for us to understand. 20% of the patients are refractory or fail to respond to hydroxyurea. Crizanlizumab is the new drug in the armamentarium. 45% reduction in the annual rate of VOCs is observed, as Dr. Kutler already showed us in his previous sustained trial. And the time for multi-agent therapy is now available for us in India as well. So we would like to have a cocktail therapy for them. Which process should be targeted is also important, because looking at the pain, we need to target the pain first or the acute chest syndrome first. At what age should be this approach? I think all of us would agree that the earlier you detect and you start hydroxyurea, the number of VOCs will decrease. Toxicity, we do not yet know how crizanlizumab is going to make the life of the sicklers in our country, in our domain, in our region. And can the toxicity of adding multiple drugs be tolerated by our group of people? Because still now we haven't been able to achieve the MTD. So how much are they able to tolerate these multiple drug therapy is still a big question for us. Will it hamper the compliance with therapy? And should there be a separate cocktail for acute events versus chronic therapy? A very big question because of the chronic pain, which Dr. Gupta actually showed us, and it was a beautiful lecture which was delivered by her. Thank you all for the participation, to all my panelists, and thank you to the EHG organization for giving us this opportunity to discuss on the patients of sickle cell.
Thank you, Dr.
sir.
Priyanka. Thank you, Dr. Priyanka, for moderating this session very nicely. And thank you, Professor Janna.
So thank you, Dr. Priyanka, for completing this panel disease. I think we come to an end of today's discussion on sickle cell disease. To start with, I face a very practical problem on how to manage the sickle cell anemia in a real world scenario, because he has experience of more than 15,000 sickle cells in that sickle cell dedicated unit. And after that, Kalpana narrated very innovative study, and she has all throughout our vast experience in the pathophysiology of the pain and vasopressin crisis, and our new study design, how the cannabinoids also can be effective, particularly in chronic pain. I am sure if it's more and more study will really stratify that finding. So cannabinoids may be an additional therapy, particularly maybe in acute vasopressin crisis also. In addition to opiates, where the patient does not respond to the opiates, pain still continues. You can take the help of the cannabinoids, which can be helpful even in addition to the chronic pain. Then subsequently, there was a master talk on crizanlizumab. You know, the Dr. Kotler was a most important person in designing and conceiving and completing that sustained study, landmark study on the use of p-selectin inhibitors in sickle cell crisis. That was very informative. I am sure at the time will come. This is even too early. It's a very short study, 52 weeks. I am sure as more and more, it has a lot of limitation also because of the interest of time. I couldn't discuss, but there was many limitations of the sustained study also. I am sure in the due course, the things will improve. And lastly, the panel discussion by Dr. Priyanka, she has narrated a very practical, posed many interesting questions, and all the panelists have done a very wonderful job. Overall, the sickle cell really session was very interesting. I'm sure all the people might have enjoyed. So my last comment is that, you know, if you look at the management or the optimal management of the sickle cell disease is concerned, as you know, the best example is you can give it like of acute lymphoblastic leukemia, where combination of the drugs in various mode of the mechanisms at different cell cycles has really become effective, and we have achieved the optimal therapy. Similarly, we have now many drugs like hydroxyurea, L-glutamine, voxelotor, then your crizanlizumab. They have a different mode of action. Now the industry people should come up to have a combination of drugs to reach a diagnosis, to reach a point that which combination are best in what particular or in which category of the patient. That's the kind of approach. I'm sure if the industry people will come forward, in your future, the management of sickle cell disease will improve definitely in a best possible way, as it has done in acute lymphoblastic leukemia. With these words, I end this sickle cell session as well as also the today's program. So good night, all of you. Again, seeing you and interacting with you on tomorrow. You have very interesting sessions. And at the end also, I thank the Novartis Oncology for supporting this wonderful sickle cell program, and other industry people like Intas, AstraZeneca, Johnson & Johnson, Takeda, Intas Plasmagen Division, Bharat Serum and Vaccine Limited, and Plasmagen for supporting this important annual Congress of EAG. With these words, I thank you and good night. Over to the.
Thank you, sir. Thank you all the speakers and eminent participants. And this was an extensive talk on sickle cell. And I would like to thank all the sponsors. And we are slightly late. I would say thank you and good night. And tomorrow, 4 p.m., we will all again meet tomorrow for the day 2. It is going to be again a wonderful session. So, wish you all. So, I think we should conclude this today. I think there is nothing. Does anyone wants to say?
Focus conclude, na? End on.
Yes, sir. Okay, good night.
Good night.
Good night all.
Bye bye.